Look at India. We are in the bottom 25%, right there at the bottom. अब हमारे पेशेंट को 3 साल हो गए हैं. Where does our data mature? The Indian data. We are just above Thailand and Kenya. Our stomach patients are not pulling through. Look at the 5-year data. Look at where we are. We are right there at the bottom of the list. We are probably just above Iran as per the reporting data, and that is, please remember, Iran is in that crescent, in that cancer crescent, and this is a big problem in their part of the world also. But something is happening to our patients. We are doing our best, but they are not pulling through as well as stomach cancer patients stage by stage in other parts of the world. Why is it so? It is very important to address our own problem and to have our own data. We are very grateful that there are authors and so we have people who have identified stomach as a local problem. This is the data from Kashmir which talks about stomach cancer as being the commonest cancer as per their hospital-based history. This is important. We have to identify our problem on a local level first. We also have the good fortune of some papers from Jammu which have talked about the molecular classification of stomach. But apart from these two studies, there is no study which really talks about stomach as a policy problem, as a health problem which is occurring in our part of the world. For a brief revision, we know stomach is essentially, we understand as a classification which has evolved over the last 50 to 60 years. And from a classification which is from the morphological appearance on a endoscopy to the classification suggested by the pathologist, so that we can stratify stomach cancer as per their severity. But is that the end all? Is it only important to understand stomach as adenocarcinoma or adenosquamous or undifferentiated? Does it tell us the whole picture, or does it help us to treat the patient? We are now in the era where we want to identify the problem at the molecular level. And now, stomach essentially is 4 types of cancers. Either it is genomically stable or it is an unstable molecular profile. And why is this important? The prognosis is dependent on that. I'm sorry if this pie chart is not very clear, but it essentially points out that if there are 4 types, we are looking at the hypermutated MSI, we are looking at the genomically stable, and we are looking at the unstable molecular profile. They are distributed. So they are distributed in the stomach accordingly. For a second, the chromosomal instability type predominate the chromosomal instable the molecular classification. They present throughout the length and breadth of the stomach, but the best prognosis, or the ones which we want to address and have a good outcome, are predominant in the body and in the distal. That's not surprising. We know that distal cancers do better. This understanding has been there even before molecular classification was given. So essentially the wisdom of the previous 60-70 decades is amalgamated and is classified so that we have more reproducible data collection as well as communication. So despite the advances in the last 2 decades on the molecular front, it is only herceptin and the HER2 pathway which has really given some tangible results in terms of survival. We know there are a host of drugs, molecular drugs, which are contributing to the survival of this bad malignancy. And essentially, we are going to be, what has really done the job for us is the HER2, especially the single as well as the double blockade. Now, stomach cancer is very common in Japan, and they understood that if we cannot group all the stomach cancers together into a single lump, we also cannot group all stage 4 stomach cancers into a single lump. Maybe there is some heterogeneity in stomach cancer stage 4. Now, this heterogeneity they understood as from the point of view of prognostication and treatment options. So, Yoshida gave a classification of stage 4 gastric cancer and essentially divided into some cases where there is so whether there is microscopic peritoneal dissemination or not? This is very important. Once there is peritoneal dissemination, we would like to label the patient as he has advanced malignancy, इसका कोई prognosis नहीं है. But is it really true? Is it that homogeneous? Or can we even divide the patients who have peritoneal dissemination into two types? Can we still keep an option where we are at least offering the patient a chance at curative intent treatment? Now, it is important that we understand that we would want to understand diseases as homogeneous, but we know cancer is not a homogeneous entity. Within cancer, stomach is not a homogeneous entity. Within stomach, stage 4 cancer, it is not homogeneous. We can have peritoneal dissemination, we can have patients without peritoneal dissemination. Even then we can talk about what will be our intent in offering treatment. This is not new. First paper came out in 2011. I was still early into my oncology training at that time. And they documented that there is a significant difference in survival outcomes when we offer curative treatment to selected patients. It has moved through a lot of trials. These are the ongoing trials which talk about a very specific set of patients. Patients who have peritoneal metastasis. Okay, so I'll rush through. But basically the summary of this crowded slide is that in stage 4 cancer, is chemotherapy the be-all of treatment, or can we have a selected patients who do well with surgery? Selection is key here. Do a laparoscopy prior to subjecting the patient to a chemotherapy, assess the peritoneum, give chemotherapy, whether it is systemic or you want to add intraperitoneal chemotherapy in the form of pipette. For the lack of time, I'm just going to rush through, I apologize for that, and then restage the patient.
You can take time.
Thank you, sir. So, NCCN supports this, that when you are doing a careful selection, we are talking about stage 4 cancer, they have undergone systemic chemotherapy, now you are trying to select your patient. क्या मेरे patient का peritoneal disease burden कम है कि ज़्यादा है? और अगर peritoneal disease burden कम है, क्या मैं उस patient को complete cytoreduction दे सकता हूँ कि नहीं दे सकता हूँ? And then you proceed, and then you have options which you can give to the patient. I will now move to the index patient. So my patient was a 68-year-old retired executive from Kashmir. Patient was diabetic, and he had a history of dyspeptic symptoms, melena, classical presentation. He underwent correct evaluation outside, underwent a CT which was suggestive of gastric body thickening, suspicious lymph nodes, and omental nodules. So primary presentation was M1. The endoscopy was suggestive of growth at the antrum, and the patient had a documented adenocarcinoma. This is something which we did not do. I did not evaluate the patient for these 3 markers. We'll come back to this. It is very clear now that the recommendation, and this recommendation, I deliberately kept it at 2024 when I took up the patient. The recommendation was very clear even at that time, and I missed it. The recommendation was that once you are doing a PET for your workup of your patient, please consider the first biopsy for microsatellite instability. Please consider the first biopsy for HER2 and PDL1, especially if your patient is metastatic. Sometimes, and cross in our own practice, it behoves us to go back what the guideline says. And it is platforms like this which give us an opportunity to interact and come back to each other, that this is how the overall landscape of treatment is changing. The PET was suggestive of a localized disease. There were PET-avid nodules in the omentum. Size significant, 2.1 centimeter. We're not doing this on imaging. It was very well picked up in the imaging done at Kashmir. The SUV was 7.1. So now what do we have? My patient is stage 4 gastric cancer. He has a single documented metastasis in the omentum. How should we proceed? He's stage 4. Convention says इसको chemotherapy दीजिए, इसका prognosis अच्छा नहीं है. What should be our intent? Do we write him off? Do we still approach with a curative intent? So I decided to speak to the family, tell them that we have one chance. हम laparoscopy करके देखते हैं कि अंदर visually कितनी disease है, और उसके बाद उसको biopsy करते हैं. I did the laparoscopy, I did an omental biopsy, it turned out to be positive. Please note here, it is grade 2, not good news. Now what? Does our intention change now? Laparoscopy shows that it is the single site of metastasis. So go back to the Yashika classification. We have peritoneal disease but limited disease. We have ample evidence stretching more than 50 years now that take up the patient after giving chemotherapy. In fact, stomach has moved to a stage, sir, where even if the patient is T2N0, early gastric cancer, the patient will benefit with chemotherapy first. So that's besides this case. And there is also this recommendation that once you have given neoadjuvant, especially if the patient is MSI high, there is still this option. So you may observe the patient. We do not need to be dogmatic in nahi, aapka to operation karna hi karna hai. The patient has responded and was to start with a metastatic disease, you may elect just to observe the patient. How many cycles? It's pretty clear now, we give 2 cycles. But after giving cycles, you have to reassess the patient. Do the same test. Do the laparoscopy, do the PET CT. We did the PET CT. What does the PET CT show? I apologize, it is in a small font here, but I'll read it out. The SUV max has decreased from 7.1 to 2.5. Very good response. Now, should our intent change? Should we go in with a curative intent? I spoke with the family. How should we proceed? I have guidelines which say कि भाई आपके patient ने respond नहीं किया है, आप इसको chemotherapy continue करिए. I also guidelines which say कि limited disease है, आप अंदर जाके अगर पूरा सफाई कर सकते हो तो you should do cytoreduction and you should offer HIPEC. My patient had a low PCI score. I was probably lucky. And we decided to go ahead with a curative surgery and giving chemotherapy inside the abdomen. So that's me and my team. We usually use the open colosseum method. You open up the abdomen, you hang it up. Apologies, didn't have a Thomson retractor at that time, so it was jugaad hai. We have to lift it up with these polyester sutures. And the advantage and disadvantage of open colosseum method is, since this is open, you can make sure by using a wooden spatula that there is an even distribution of the HIPEC solution all in entire abdominal cavity. The drawback is that the temperature controls become very tedious. We have to maintain it at 41 degrees for 90 minutes. So I'll not waste time here. I want you to please go through with me the final histopathology report. Remember, I sold the idea to the patient and their family कि हम curative intent से अंदर जा सकते हैं, बीमारी ने बड़ा अच्छा respond किया है, हमारे पास एक chance है, let us take it. We took that chance. They were supportive. Just look at the final report. It is still T4A. It is still N3A. More than 7 nodes positive. My entire argument fell flat. The patient did not have a very good response to chemo. We ended up giving a very aggressive surgery to a patient who retrospectively now analyzed probably did not make a big difference on chemo. What misguided me was probably the PET CT, which showed a very good response. Now, we subjected the patient to adjuvant chemotherapy, and now we were wise enough to go for HER2 testing as well as MSI testing, as well as check at PD-L1 for immune checkpoint inhibitors. But before I end the slide, I would like to let you know it is 1.5 years now. My patient is disease-free. Sometimes we have to take a chance, but that chance has to be taken in a very informed way. Have we done our selection well? Do we have the right intention? Do we have the right resources to offer to our patient? My request is, we sit in a place where stomach cancer is very common, where stage 4 stomach cancer is very common. Let us not think that it is a homogeneous lump. There is a distinction, there is a heterogeneity in this stage 4. Let us pick it up and let us give the best to our patients. Thank you so much for your patient hearing. Thank you so much for indulging me.
Thank you, Dr. Paras Khanna. You have given such a detailed discussion about the disease. I think you have made us wiser. You have made us wiser, and you have given us very recent information about it.
Hello. Thank you very much. It was really a nice presentation. We've been managing this CS stomach for long now. We have also learned lessons how to manage such patients. One thing I just want to share with my friends here, that never underestimate the formation of oncology boards in your hospitals, especially the referral centers or the medical colleges. Never try to manage such patients alone. Take all these people from different aspects, have a multidisciplinary approach, and reach to a consensus what we should do. What initially, unless and until a patient is obstructed stomach, you should always do a diagnostic laparoscopy now, and always try to find the molecular and IST diagnostics. because this helps in neoadjuvants as well. We have found tumors vanishing from GE junction and even body once we operate them. So once you do a curative, so you can have a curative intent in such, you are absolutely right, we can have a curative intent in such patients in stage 3. So one should not forget information of oncology boards in our areas and have a multidisciplinary approach involving all the people in managing such cases.
Thank you so much, sir. I completely agree. And thankfully, being in oncology practice, multidisciplinary tumor board is something that we have learned to practice with. I mean, even when I want to offer something, my first question will be to my medical oncologist. Yeah, is not do you think this is the right approach for this patient? Yeah, chemo ke baad you would want to give more chemo. So you're right, sir. Once to have a wholesome perspective, we have to trust that the other individual who is not a surgeon has the equal amount of concern for our patient. ये patient उतना उसका भी है जितना मेरा है, and he will give his best to the patient. And I said, before I conclude, sir, I'll again want to kind of reiterate what you said. Sir, molecular analysis हमको आज बता रहा है कि जो MSI टाइप है वो डिस्टल कैंसर में या डिस्टल स्टमक में ज्यादा मिलता है, लेकिन ये तो ट्रेडिशनली हमारे टीचर्स ने हमको बताया ही है कि जितना आप डिस्टल गैस्ट्रेक्टमी करते हो उसका हमेशा प्रोग्नोसिस बेटर आता है. We just now have a molecular signature. So we cannot just write away the wisdom of what was there 60 years ago and supplant it because हमें आज कोई molecular molecular blueprint पता है. We are just renaming wisdom with molecular signatures. Thank you, sir.
Now, broadside infections have been a big challenge in surgical practice. I request Dr. Harvinder Singh Bali to present his case on broadside infections.
Good morning, everyone. All PGs and senior residents are requested to proceed towards conference hall B for paper presentations. Thank you.
Sir, with utmost humility, I would request you to be in time. You will get a reminder at 2 minutes left. Kindly.
I will be sure.
Secretary sir को idea है. He has to be shared time.
Good morning, everybody. Greetings from ESCOMs. From all these trials and scepters and all that, we will shift to something which is giving headache to our surgeons, all laparoscopic surgeons. We are having a headache just because of this problem. So I am just going through this, our experience at ESCOMs regarding the clinical bacterial profile and management of broadside infections in laparoscopic surgery. You know, it has existed, laparoscopy has existed since the development diagnostic lab in 1960 and shifted to 80s when we started, when this was shifted from diagnostic to therapeutic, started with gallbladder and appendix, and then to hernias, colonic surgery, gastric, everything. Everything we are going to do, we are trying to do it through minimal access. And the benefits of this minimal access surgery, they include the decreased post-operative pain, quicker return to normal activity, and the less post-operative complications. But the thing which erodes the confidence of the patient as well as the surgeon is this, the broadside infection, which is, despite being giving headache to surgeons, is a preventable thing. So, this what the laparoscopic surgery was the use of reusable metallic. What we are doing most, I think 90% of the time we are doing this thing, and maybe some private sector they are using disposable plastic trocars routinely. These both form the portal of entry from the surgical procedure using the specialized instruments which are used. The PSI, the broadside infection in the procedure, is manifest in the form starting with cerebral discharge from the both sides with the surrounding skin inflammation and for symptoms related to organ space infection or can lead to small sinuses and tracts which give a nagging sensation to the patients. This I told you, the PSI, these erodes the advantage of laparoscopic surgery. Patient becoming worried with the indolent and nagging infection and he loses the confidence in the operating surgery. And surgeon also, it increases the headache of the surgeon. So, admissions. The wound becomes unsightly, the cerebral discharge and surrounding inflammation to suspect patients. So what are the predisposing factors for the emergence of post-surgery? Some are related to the doctors, the technique, the instruments, what we use in this laparoscopic surgery, and other are related to the patient with a history of steroid use, diabetic mellitus, malnutrition. And there are a number of factors related to patient. So disruption of this intact cutaneous mucous membrane as a result of such trauma, patient bacterial flora may become opportunistic in these patients and they cause infections. So this is our two here dotted as cones. Out of the approximately 500 laparoscopic procedures performed, 30 patients were at outside, exactly incidence of 6%. And if you see most of the cases where what we did by 360 laparoscopy surgery followed by TAB, laparoscopy, bypass, and sex distribution of these cases was 30% by male and 70%. Most of the patients were female developing these infections. Age of the patient was 20 to 78 years, the male was 47.7, and this was the age distribution. If you see, most of the patients were from 30 to 50 years of age. And occupation different. Nobody tried from electing for a liar. I know a liar. He must be calling me names, but because he has not still recovered from this outside infection. Then there were two nurses, ex-army men, school teachers, everybody from every strata. So the resident distribution, you see people from all over the state, including the Pulwama also, Jammu, Rajouri, Doda, Riyasi, and the bacterial profile of the patient in our series was acid was bacillus, MRSA, Enterobacter, Pseudomonas. But no organism was found in 5 patients. So these 18 out of 30 cases were having AFP positive, 2 Enterobacter, 2 Pseudomonas, 3 MRSA, and 5 Pseudomonas. And the patient involved 77 person. 23 of the 30 patients were there was a patient of lab polycystic. Sport side infection following lab polycystic. 4 after TAB, 2 after IPOM plus and 1 after IPOM. So 15% of 40% of patients were having multiple comorbidities. 20 hypertension and 27 type 2 diabetes, 30 hypertension. So management from conservative to surgical. So initially, whenever the patient comes, the first approach is to treat the patient conservatively. So conservatively means that there is a discharge from the wound and patient comes early to you. You proceed with culture sensitivity of the wound discharge, followed by the localized cleaning and debridement, and then giving antibiotics according to the sensitivity of the patient. So this is most of the patients, 59% received second line ATT, ciprofloxacin, clarithromycin, 17 to ATT, and these 10, 7 and 10% patients, they received according to the sensitivity of that. So these were the common presentations. You are seeing on the first picture, I don't know whether it is really good. On the right, just the discharge, and you can see the sinuses with necrosis of the overlying skin and pus coming out of it. These are the few more patients who are seeing differing both sides and different infections. So these are the 3-4 cases I would like to discuss. This was a 75-year-old patient. This was an ex-army man with IPOM plus he presented to us with swelling and application with discharge from the camera side port and other working ports. The swelling at umbilicus and inferior under the IPOM mesh. After 2 months, just such cases. After 2 months, we started the antitubercular treatment. It didn't respond to that. Then after 2 months, we explored the patient, removed the mesh, and excised all the sinus tract. And this is the final picture. After POD2 and POD16, we are seeing we have removed all the mesh and the sinus tracts. So this is the second case of right-sided hernia, hernia E-tab was done. She presented with pus first discharge of 3 months from the infraumbilical port. Again, exploration giving her this renal and erythromycin for a month. This was followed by complete surgical excision of the mesh and the fistula which was there. Then this, again a case of umbilical hernia, lack of umbilical hernia, IPM plus was done with discharging sinus between the explantation of the mesh and sense tract. And this I was talking about this. I don't know where the patient, we have lost this patient to follow up. He was operated 4 times. I operated first, I did lap cystectomy. He came with us, with ARB positive. We started anti-tuberculosis treatment, didn't respond. Then I operated him second time, removed all the sinus tract. But after 4 months, patient came again to me. Somebody suggested him to go to Ludhiana, he went there. He was operated there twice. But again, after 6 months, he came back with me, the same problem. Now, I don't know why he had just lost that follow-up of this patient. And that is how horrible this disease can be. So this is what we are doing, we have started doing here. That with the patient present within the first 7 days of early PSI, they are treated with regular wound cleaning, the regular dressing and apical antibiotics. If there is a delayed presentation, we start with imaging with USG, CT, MRI, and we accordingly then we do the debridement and excision of the foot tracts. Conclusion. PSI can be a frustrating complication for a patient as well as the operating surgeon. And with the new threat of rapidly growing multi-drug resistant non-tuberculous mycobacterium in laparoscopic surgery, it becomes very crucial for the surgeon to abide by the principles of cleaning. That is the basis. The principles of cleaning and sterilization of the laparoscopic instrument and with the appropriate sterilizing agent so that the complication can be avoided. What is on our part we should do. Thank you.
Sir, thank you very much for this time. Nice presentation. But one thing how do you differentiate a mesh infection from port-side infection? In a patient because the mesh is too down, the ports are too high, how can you differentiate a mesh infection from a port-side?
So there is there to when we can take the help of an ultrasound, a CT or an MRI. They are definitely going to guide us where is the site of collection and what is the action of extraction of that.
Can I have a point? Most of the patients of these port site infections ultimately reached us. We have seen so many patients. Let me be honest. They are all preventable. It is the problem with us. It is attrition. Most of the times we find a foreign body in the port, a thread, a stone, so many things. And you know, if a surgeon is finding that there are multiple, I'll give you an example. Multiple gallstones are there, I'm doing a dissection, nice. What is in there to just put in a bag? What is in there to put in a glove and get it out slowly and steadily and increase even the size of the port once you are removing. About the mesh, again, the technique of not changing the gloves, not changing the strapping. See, we do not follow the lines. You see, in Western literature, you will find PSI very less common as compared to this area because we are reusing the instruments. Another important problem is that once we shift the instruments to the people who are taking care of the takers, they do not sterilize them well.
Yeah, true, sir.
You see, there are gultered, those bows which are remaining there for 3 months, 4 months, and you don't know what type of infections were having there. So my request would be to have a procedure with the best sterilization techniques pre-op, intra-op, as well as taking care of such patients post-op.
Sir, one thing. What about your experience after using this plasma chamber?
Definitely it has reduced. In fact, we had some problem with plasma unit, we just got another one. It definitely reduces, because see, this is the part of the world where we reuse the instruments. ये हमें आदत है. ये हमें आदत किस चीज़ की वजह से है? Everybody knows it. It is all because of financial constraints. Even in private sector, people like to reuse the instruments, जो ideally आपको एक use के बाद फेंक देने हैं. So all these things ultimately We have to pay the price and the patient has to pay the price. So one has to be very careful. It is better to prevent such occurrences rather than treating them. One more thing, in some patients we have been able to do a diagnostic laparoscopy because once you do it 2 times, 3 times surgery, so they do not respond. It is better to go in, have a look. We have found sinus tracts right from the port up to the gallbladder bed. So we have been able to do a formal laparotomy and excise all the tissue, which has been really a cumbersome procedure. So it's not that easy to manage. So prevention is the best.
I just want to, I'm audible. Yes, I just want to add that I have a lot personal experience of managing these atypical infections. It happened in Kashmir division post-flood. It was not that evident before floods. So we noticed it after floods. So we had a massive surge of these atypical infections, and I managed them. A lot of my good friends used to send them daily because it needs a lot of patience to manage them. And I was able to break the cycle by ETO sterilization. ETO was the answer. It's not a question of managing this patient. The question is how you are breaking the cycle, because every day these patients start piling up. So the moment, say it takes 15 to 20 days to break this cycle, because otherwise you have to change all the instruments. And I found that ETO was the answer, and then you did not get new patients. Thank you.
Commissioner Chair, thank you, Dr. Ravinder, for a very, very insightful presentation. This is a very common condition. We also had a procedure of around 3 months with a severe atypical mycobacterial infection around 20 patients. Then we traced the source. Most of the time is what we see that out of the you also showed it that majority are atypical mycobacterial infection. And what is the source? Source is that we have to look for the water we are using. We did microbiology assessment, all teams came and we said first there was infection in the instruments. We also have a plasma available luckily. So we cleaned the instruments and we got very good results. But ultimately we could find again water testing that spores were present in the water. So we decided to do washing of our instruments with normal saline, and we are also in the process of getting osmotic water for scrubs. That's very important, that helps. So our tanks in the hospitals, especially in private government hospitals, are very dirty. For years together they have not been cleaned, and there's a big source of infection. And another thing is I'm skeptical about the debridement. I'm very much scared of touching these patients. We saw that when most of the patients atypical, they usually get flare up after doing this. And one thing we have added that injection gentamicin definitely helps in those patients who have infection, besides sclerostomicin and other prophylactics.
I think just basically, I think there is no role of anti-tubercular treatment in this case because they are number one. Number two, there should not be any cross-specialty uses of laparoscopic instruments. If you are sharing with a urologist, you are going to have a problem. Yes. So there should not be. It's very important.
Gynecologist and urologist.
Gynecologist, I'm not aware of.
And
then I think I had experience of using intralesional amikacin. I think it works. It works in some of the patients that you have nodules. It may not work in postural lesions, but when there are nodules, induration, you give intralesional amikacin.
Overshooting of time adds to the frustration of foreigners. Please, 8 minutes for presentation and 2 minutes for discussion. We are 20 minutes over and above the schedule time.
Now the whole method follows you. You have to be absolutely correct.
Actually,
topic is the development of foreign platform. It can be presented anywhere in the region. Maybe non-functional due to the construction or where the surgical challenge might come. Can be present again urinary tract infection or why we are choosing the laparoscopic approach. Minimally invasive, less post-operative pain, shorter hospital stay, faster recovery, and the better prognosis. The patient with a 45-year-old may present with a lower urinary tract symptoms and the left leg. Patient was treated from 3 months by a patient for prostate lower urinary tract symptoms. And on USG and the CT scan show grade 4 hadron of the pelvic kidney, compressing the bladder, and the patient had the symptoms of lower urinary tract symptoms. DTP scan done shows a non-functional left. Preoperative planning was that CT angiography, ureter catheterization for intraoperative identification, care for foot placement. Surgical technique modified plank was spine position, 3 to 4 transperitoneal approach, mobilization of segment colon and the bladder, identify and kill the vessel, negate the ureters and retrieve the kidneys. Intraoperative challenges, limited pelvic space, dense adhesion because of recurrent infections, aberrant vasculature, and mobilization of the surrounding organ. Short video how we have done this. Since the kidney was extraperitoneal and we are removing the peritoneal since because of recurrent infections, the dense adhesions between the kidney and peritoneum. So we use both sharp dissection as well as blunt dissection by using the section for releasing these adhesions. But since it was distended, so we plan for aspiration. After this, now we are releasing these adhesions, then we are now holding this line because of tension. Now we plan for aspiration so that we can hold it. There was a lot of fuss. Now we sit on dissection by using the hook. These are the dense adhesions. The adhesion sometimes when we are doing the posterior dissection, we have to keep the capsule of the kidney safe. We have to do the subcapsular nephrectomy. And in aspiration, we have also the infidels that by doing the lateral dissection from the pelvis, there is a vessel, a lot of vessels, even a vessel may be damaged during the dissection, so it is a better deflate before doing the dissection. Now here we are started doing the subcapsular dissection. Now suction has been used on a blunt dissection, adult dissection we are doing, and now we are doing the post-line dissection. Now this is for there one of the important is that we have to identify the ureter and the vessel. Fortunately, there was no aberrant vessel in this patient. Usually these are present in the posterior. But in this patient there was no aberrant vessel. Maybe something associated with the ectopic kidney. Now, also using the gauze for the dissection. Now, again, posterior dissection done, identification of now, during this anterior dissection, bladder was again inflated, so that you see that there should be no red
in the bladder. A leak. This is the bladder again insulated so that there should be no leak. Well, I did do this again by using the Egypt and up. Look at the vision of the cassette. Again, since we have to remove the bladder, quickly from the bladder, we can open it to see whether there is sometimes, but that is so that we cannot cause injury to the bladder. Now we have opened this. We have opened the kidney here. Removing the part that is very adherent to the bladder. So this is the last bit that we are dissecting on the bladder. Now after doing this complete dissection of the complete way, we'll see for hemostasis. Now there was a diffuse from this the dissection phase, not was phase which is really created. After that, we put a gel foam for diffuse. Now, since there is a space, the space that we have favored in the bag, one thing bag. Now, since the peritoneum was there, defect was there, the peritoneum was again closed by using the V-lock suture. The brain was placed. There was a dead space for that remote collection and we are acting. This is the specimen that has been removed. Outcome as a result, the procedure completed laparoscopy, minimum blood loss, no complication, early discharge and smooth recovery. Safer and faster than open nephrectomy, rigorous advanced laparoscopic sequence, preoperative imaging is a critical literature support certification. Conclusion, laparoscopy nephrectomy is a safe and feasible, offer benefits of minimally invasive surgery, preoperative planning and anatomical knowledge is an essential. Commendable job, since it was almost a pionephrotic treatment, but we must have a lot of very efficacy and without injuring any Thank you.
So I think this is the end of this session. Let us hand over the mic to the next session.
And with that, we conclude this enlightening session of guest faculty lectures. We are deeply grateful to all our distinguished speakers for sharing their vast experience and expertise with us today. Our heartfelt thanks also goes to our respected chairpersons, Professor and Dr. Zakir Hussain sir, Professor and Dr. Pankaj Gupta sir, Dr. A.K. Gupta sir, Dr. Akhtar Ganai sir and Dr. Rajesh Chandral sir for graciously guiding and moderating this academic session.
Each of today's talk was a reminder that surgery is not just about precision of hand, but also depth of thought. It's not just about presentations and opinions, but about the underlying expertise and years of wisdom that reflect from each of the slides which were so meticulously created by our subject experts. With that, now we move forward to our felicitation ceremony, and I will request our esteemed chairpersons to stay back for the felicitation ceremony. Now we move on to the felicitation ceremony as a gesture of our gratitude and respect for our esteemed speakers and chairpersons. We would now request our worthy chairpersons to come forward and felicitate our esteemed speakers.
First up, we have Dr. Gurveer Singh. Sir, kindly come on stage. Everyone, please give a big round of applause. Dr. Gurveer Singh, Assistant Professor General Surgery, SMU Kathua. Next up, we have Dr. Avinash Rajra sir, Consultant Oppo Surgeon, ESCOMS, Jammu. Next up, we have Dr. Paras Khanna sir, Assistant Professor Surgical Oncology, AIMS, Jammu. Next, we have Dr. Harvinder Singh Bali sir, Associate Professor, ESCOMS, Jammu. Everyone, please give a big round of applause.
Yes, please. So yes, please. Sir, look here. Yes. Good. Thank you.
Next up, we have Dr. Zahid Mohammad Rathe sir, Associate Professor, GMC Kathua. Everyone, please give a big round of applause.
Yes. Okay.
I would now request our chairman, J&K chapter of Association Surgeons of India, Professor and Dr. Ejaz Ahmed Rathar, Head of Department General Surgery SKIMS webinar, to felicitate the chairpersons. Please give a huge round of applause.
Yes, please.
First we have Professor and Dr.
Yes.
Zakir Hussain sir. Then we have our esteemed chairperson, Professor and Dr. Pankaj Gupta sir.
Yes.
Dr. A.K. Gupta sir. Then we have Dr. Akhtar Ganai sir.
Yes. Okay.
Then we have Professor and Dr. Pankaj Gupta sir.
Yes, please.
Then last we have Dr. Rajesh Ingal sir.
Yes, sir. Okay.
Thank you to all the dignitaries for gracing us with their presence.
As we continue this academic celebration, we now move on to our next segment of guest faculty lectures, a session that brings together distinguished experts whose work has shaped the practice and philosophy of modern surgery.
Absolutely, Ananya. These lectures represent the perfect blend of science, skill, and surgical wisdom. Each talk today promises to enrich our understanding and inspire every learner in this hall. So to chair this special session, we are privileged to have with us an eminent panel of academicians and mentors.
We have Professor and Dr. R.K. Srungu sir. Second up, we have Professor and Dr. Tariq Azad sir. Then we have Professor and Dr. N.C. Digra sir. And then we have Professor and Dr. Sanjay Kumar Basil sir. We extend a very warm welcome to our respected chairpersons and request them to kindly take their seats. We would like to hand over session to our esteemed chairpersons. Everyone, please give a big round of applause.
Thank you very much. This is the invited guest lectures session. No question answers, 15 minutes, and they are all stalwarts. They know the importance of time. I hand over to Professor Chirabu sir.
Good morning, everybody. Let us invite Professor Dr. Tushar Chaudhary, Professor Emeritus to deliver his lecture on
morning, everyone. Well, I have chosen the subject of fistula. Apparently a simple surgery, but believe me, it's most challenging and controversial topic in colorectal surgery. And it's tested the patient is of even most experienced surgeon. Because there are two concerns for the surgeon as well as for the patient. One is high recurrence rate, in spite of doing the best possible job, given by experienced colorectal surgeons, and high rate of, rather the risk of anal incontinence following surgery. The risks of recurrence are more in patients with high transient surgery or issue extensions, patients with multiple tracts, when you don't locate the internal opening, anterior surgery, inflammatory bowel disease, patients who have reduced immunity. The technical causes are incomplete division of the fistula, when you don't know the exact anatomy and the location of the fistula, due to the incomplete section or debridement. If you are doing a lift, you do incomplete ligation. Sometimes you miss a side tract, or you leave a cryptoglandular complex, which is the basic culprit for the formation of fistula. The fistula has a variable presentation. It can be simple transcendental low fistula, or it can be a high transcendental fistula with extensions, supralevator extensions, extracerebral extensions, intercerebral extensions. It can have a long tract. Sometimes it may open even in the abdominal cavity. So that's why we can't have a single technique appropriate for all types of fistula. We know there are sphincter cutting options and sphincter sparing options. The sphincter cutting procedures have less recurrence rate, but at the cost of high incontinence. While the sphincter sparing procedures apparently have lesser incontinence risk, but higher recurrence rates. Sphincter cutting procedures we would like to do in complex fistulae, but before cutting the sphincters, we should be well aware that the continence or the sphincter tone is quite good, and you should monitor it pre-operatively by manometry test. And sphincter sparing procedures you would like to do in patients who are high risk for incontinence, like female, previous surgery, elderly people with poor sphincter control. So going to conventional techniques, we know fistulotomy and fistulectomy. These are the time-tested and most commonly performed procedures with the highest success rate reported so far. Fistulotomy, I would say that you should do for acute fistula, which are of recent origin. You lay open the tract and filter out the unhealthy granulation tissue. While as fistulectomy, we do for patients who have chronic fistula with well-epithelialized tract, and you have to excise whole fistula tract along with the cryptoglandular complex. So that is the difference between fistulotomy and fistulectomy. Fistulotomy only for what you call acute onset fistulae, whereas for chronic fistulae you will have to go for fistulectomy. This is one technical issue. Once you have done a fistulectomy, you should try to marsupialize the wound. Stitch the edges of the wound with the underlying tissue in order to reduce the size of wound so as to increase the healing rate and reduce the healing time. Now another concern is about division of a sphincter in a patient who has a fistula, transsphincteric or intersphincteric fistula. How much to cut and how much when not to cut. This is a very important issue and is of concern for the surgeon, really, because it makes a hell of a difference. When it is a low transsphincteric fistula going up to bacterial line only, you can divide it in a healthy young patient with good sphincter tone. You can divide the sphincter no issue without any significant incontinence. So, when the fistula we call as travelers between the pectinate line and the anorectal ring. That means your division will involve the whole of the internal and external sphincter. So there will be definitely some amount of continence. And if you do a primary repair of this sphincter, you are going to reduce the risk of incontinence and improve the results. So then comes question of complete division of tuber rectalis above the anorectal ring. So don't try to go above this line, please. Never go above this line, anorectal ring, because even if you divide it, patient is going to have a gross incontinence. And primary sphincter reconstruction is useful, but definitely patient will be left with some amount of incontinence. So you should always try to avoid tuber rectalis division of tuber rectalis. So as a general rule of thumb, for males, 1/2 of posterior external sphincter and 1/3 of anterior sphincter. Anterior external sphincter can be cut. But in females, you should be more careful. Only 1/3 of the posterior external sphincter, but never divide the anterior sphincter, external sphincter in female. If you have divided the significant amount of sphincter for eradication of the disease, then it is better to repair the sphincter on table. The results will definitely improve and you will reduce the risk of incontinence. See the results. If you are doing a sphincter saving procedures, as I have told you, lesser incontinence but high rates of recurrence. Sphincter cutting reverse. But if you cut the sphincter and at the same time do a sphincter repair, so you are reducing the risk of incontinence and also reducing the chances of recurrence of the fistula. Now setons we use either draining setons or cutting setons, drains for draining the sepsis to downstage the fistula, and cutting setons, sometimes a big chunk of sphincter comes in between the fistula. So rather than dividing it, we just apply a cutting seton. It gradually cuts through the muscle and at the same time healing on the muscle organ. Therefore, thereby you reduce the risk of incontinence by completely dividing the sphincter. Advanced flaps is a popular technique. It is basically a supplementary procedure with some fistulectomy procedure. You have a bigger defect inside the anal canal, you cover it with an advanced flap. But it should be avoided in patients who have high fistulae, patients who have anal stenosis and scarring is there, and patients who have inflammatory disease like Crohn's. These fistulae associated with inflammatory bowel diseases, they are very difficult to treat. One should always try the medical treatment first, followed by surgery if indicated. So if you have to do any sort of intervention from surgical point of view, try to use the sphincter preserving procedures like anal fistula plug and other filling materials. Now let us go to sphincter scaling techniques. I cannot talk in detail all the procedures because of time strain. We know ligation of intersphincter fistula tract. The early results were good, but subsequently we could not duplicate such results. The success rate is around 70%, and the predictors of failure in patients who undergo lip technique are horseshoe fistulae, Crohn's disease, previous fistula surgery, tracts which are more than 3 centimeters are very short tracts, patients who have fistula with multiple side tracts, and because once you are doing a lift, you are not clearing or removing the culprit, that is the cryptoglandular complex. That might be the cause for recurrence or failure for lift. Modifications of the lift have been done by adding some medications to the to these procedures, but they have not been found to be anyway better than the simple lift technique. So it may be reserved for patients who have a simple, short, run sphincter, low fistula in anal. WAFT is a video-assisted anal fistula treatment technique, a minimal invasive technique, I would say that it would be useful for patients who have an inaccessible tract, where you can reach with the help of probe and curate out all the unhealthy tissue above the levators. But the problem or the challenge with that are that tracts which are very long, you have to have a longer probe. Tracts which are acutely curved and you cannot access those acute curves. Low fistula tract is of no use. Sometimes patient has a pelvic extension and this fluid might go into peritoneal cavity. So you have to be careful in such patients. Now going to laser, it is a fashion nowadays to do laser for everything. So is for we call as anorectal surgery. But so far as the fistula is concerned, we don't have much literature, and there are limited studies, small number and short follow-up patients. And there is always you have to use an additional procedure along with the laser. So it is not a laser alone procedure for doing a fistula treatment. There are variable results. Sometimes the dose of energy, how much energy has to be delivered, and the tract might be wider, so at certain places, so that these laser beam doesn't reach to all around the tract, and it's a blind procedure. So these are the reasons for failure of laser in such patients. So one should not be very enthusiastic about the laser. It just burdens the tract. But basic principle is that you have to address these issues before we can include laser for fistula surgery. Then various filling materials have been reported from time to time: fibrin glue, anal fistula plug. Then other filling materials like platelet-rich plasma, autologous cartilage. These filling materials are feasible therapies with complete preservation of anal sphincter with zero side effects. But they should be used only in patients who are unfit for surgery. New techniques have been introduced: perfected props, JFSIA, over-the-cope, clips, photodynamic therapy. All these new techniques have, with limited data available, so it is difficult to make reliable judgment about these technologies. So far, none of these techniques have added a paradigm shift in the success rate of fistula surgery. So we need to have more multicentric prospective randomized control trials with large sample size and long-term follow-up to be validated. New techniques aim to be less invasive and more significant, but at the cost of increased recurrence rates. Technology is advancing very fast. It is always welcome. But new techniques should be properly tested, learned, and adopted as per the guidelines. Present scenario is that if patient has a simple submucous, intersphincter, and low transsphincter fistula, you should go with fistulotomy and fistulectomy. If patient has a complex fistula, once you try to do a conservative procedure, fistulectomy with draining cetons, rather a staged procedure. And later, for high-risk patients, you do a sphincter sparing technique, and for low-risk patients, you do a sphincter cutting procedure with or without sphincter care. Fibrin sealants like anal fistula plug are reserved for patients who are not fit for surgery. So to conclude, I would say that no single technique is appropriate for all types of fistula. There is no evidence to recommend or condemn any single procedure. Fistulectomy is the most commonly performed procedure with maximum success rate and may be considered as the gold standard. So we need to discover efficient and sphincter-friendly techniques. Abundance of techniques and technology, however, should not defer our primary goal, that is patient safety. And the main treatment objectives when you are treating a fistula or when you are operating a fistula in the lobe, you have to drain the sepsis, you have to excise all the fistula tract or the unhealthy granulation tissue has to be removed. No, don't leave a bit of it. If you leave a bit of it, that is going to be the cause for recurrence. You should try to preserve the sphincter function at all costs and excise the culprit, that is the cryptoglandular complex. yellowish. So decision about the surgery has to be based on surgeon's experience, nature and location of the fistulae, amount of the sphincter involved, various patient-related factors like immunity, associated inflammatory bowel disease, sepsis, and other things. So you should sit with the patient and do a proper patient selection and proper procedure selection. Counseling is very important. Sometimes you will have to tell the patient that you might need what we call a staged procedure. Otherwise, it will create issues about litigation and other things and bad things. So it is very important that you sit with the patient and explain him the nature of surgery, the complication associated with surgery, and the type of procedure you are going to do, whether a single stage or a multi-stage procedure. So it has to be a shared decision between the patient and the surgeon, which is crucial. And you choose the treatment option which suits you and the patient best. And make your judgment, which is based on the incidence of recurrence and the risk of incontinence. Thank you very much for taking. So anyway, if there are any questions, you are most welcome.
I think there are questions allowed in this session. As a matter of routine.
Welcome, sir.
There are already doyens of in this session we have doyens presenting there. So I don't think there are any questions. We come to have the privilege of first of all, thanks to the legendary of Master of Fistulectomies.
Not fistula. No, there can't be anyone who can pass the fistula. Even if the best hand is 5 to 10% is the recurrence rate.
No, but that is worldwide. It's not only this
I think there is no other surgery where you can apply the principle of learn, unlearn, and
one should never be overconfident. One should never be overconfident. That's why I try to convey what should you do to do the best for the patient. What should be the technical points which you should keep in mind and how to decide about the type of procedure. That is what I wanted to convey because I thought that all the general surgeons are around, so they should be aware about it. I try to convey my point.
Thank you very much, sir. We invite the next speaker now. Dr. Izaz Mali, Head of Department of General and Medical Access Surgery, Schemes. And he will be talking on from puncture to precision, the evolving philosophy of hepatic hydrolysis. I think very common condition with so many ramifications.
A very good morning to the August gathering here and the chairpersons, respected chairpersons, and the August gathering. It was very difficult for me to choose the subject today because taking oncology and other things, endocrine, breast, colorectal, upper GI, hepatobiliary, pancreatic, and other things, I thought it's better to choose a subject which is of importance to almost all surgeons who are not only doing in the central institutions, but even the peripheries. We need to know a lot about it, what consensus we have arrived after a long journey of managing such patients. I thank Professor Ravinder and the organizing team for organizing this extravagant, nice conference in Kathua, and thank him for the invitation. I thought it's better to talk about hydrated disease, and that too abdominal, but here I touched only liver, because if we take other organs, then it is a day's job. So I thought it's better to concise it to the best possible from puncture to precision. The opening thought is that surgery evolves not with sharper instruments but with deeper understanding. It's a philosophical code because the understanding therefore shapes how you take the management criteria, whether you should go for a simple observation technique or you will try to apply the minimal access laparoscopic approach or do some form of intervention or go to the traditional surgery. Now why did I choose this topic is that The modern hepatobiliary surgery just tries to have a conservative approach of managing such patients, rather than doing resectional surgeries which have proved to have a good morbidity and mortality. Just cover up the worldwide vegetarian very high endemicity. There is a liver cyst produced with low level of sanitation in us and the primary and secondary host. Humans try to be the intermediate accidental and host. The J form is a cystode from Jamia family. It's basically a zoonotic disease. Once you get the egg inside the intestine, small hydrated follicle forms within 12 hours. After 2 weeks, usually a fluid or microscopic hydrated is formed, which then later, within 3 to 4 weeks, forms a hydrated which is visible to the naked eye. We have filters in the body. The first filter is the liver, and second, the heart and lungs. Sometimes primary filter is first involved, sometimes primary filter is missed and secondary it goes across the second filter and tries to go elsewhere else in the body. As the classical three lists, most important is the endocyst, which is the viable portion of the cyst. The rupture and defect in the laminated membrane of the endocyst leads to the germinal membrane passing out through the defect, which leads to the satellite hydrated cyst formation. There's almost everywhere in literature you will find it has been reported, excepting nails and cartilage tissues. But liver forms the major area where it is involved in the primary filter. They can be small cysts which are totally asymptomatic, or you can have large cysts, which usually a compensatory hypertrophy which will be visible on the CT scans. There can be compressive symptoms which may be on the IVC, on the portal vein, or even in the CBD, leading to cholangitis sometimes. And the presentation can be cholangitis, primary cholangitis. And they can develop infection and lead to pus formation and abscesses, pyogenic liver abscess. They can rupture, have a contained or a revealed rupture, may lead to cholangitis, as I have already told you. They can go into circulation and produce constitutional symptoms of urticaria, anaphylaxis, and thrombospasm. You have a cystobiliary communication around 26% of primary hepatic liver cysts. Now, most of the times, these patients are asymptomatic, unless and until they develop some complications, some swelling or some problem. You do not go to the doctor. Usually, ultrasound forms the major method of diagnosing such individuals. The constitutional symptoms may be there, but once the infection suppression occurs, they may come to you as cholangitis or a liver abscess. The triad is a biliary colic with jaundice and urticaria. The ruptures are of two types: the contained CCR, which occurs within the cyst and then forms the multiple cysts within the cyst. Another is either communicating, like the bronchial, which are in the ultimate cure in certain patients of lung. Cyst rupture usually leads to release of the contents and then intra-abdominal distension, and patients present to you as ascites. You don't know the diagnosis. Ultimately, they turn out to be disseminated hydronephrosis. This is one of the early case reports where found an alcoholic whom we operated in an emergency had a huge abdomen, and ultimately it is the laminated membrane from the puncture which we got the diagnosis. So we had to do an emergency project. Serodiagnosis forms an important method of not only diagnosing but having a prognostic value once you are treating such patients in future, whether you use any modality of treatment. And there are various tests. We have done one study with ICMR project which has been published in PLOS Chair. Another way to enhance the diagnostic capability of is searching such agents in the urine also. Another study we did and published both in the serum as well as the urine. Simple radiography sometimes gives a diagnosis to the clinician, maybe a physician. He takes an X-ray abdomen, he finds a calcified cyst. Or sometimes an abscess with the level, the classical level, which most of the people know they can be present. Now, ultrasonography is the primary investigation. You know, we have a Garvey classification where the pathognomic signs would be a detached membrane, presence of daughter cyst, and calcified walls. WHO Inform Group has given the activity and the inactivity of these cysts, where you can recommend a management strategy, whether they are active, which are C up to 2, C E3 is intermediate one, C4, C5, usually is a conservative approach by the pediatricians. Contrast CT is probably the most important thing that gives you the diagnosis and number of cysts, what is the location, which segments are involved, whether there are compressive symptoms, what is the status of the compensatory hypertrophy, and ultimately now with the minimal access approach, having both coronal and transverse scans, you need to have a good approach to laparoscopy. It may also tell you about the vitality of the cyst. There are other investigations, especially ERCP, which can be proved to be not only beneficial from diagnosis but even the management. Then MRI is usually performed in extrahepatic, bone and other muscle tissue. CT angiography is sometimes needed once there are complex hepatic surgeries needed, and positron magnetic resonance spectroscopy is the latest investigation of choice. But we have found that intraoperatively, the ultrasound forms very important modality, especially in looking out cysts which are not accessible in minimal access surgery. What are the treatment options that are available for these high-degree diseases? First of all, the non-operative managed by using chemotherapy and prayer. Then operative methods of being a conservative, radical, and the laparoscopic approach, and RFA in small selected cases. The drugs, these are imidazole derivatives. We know albendazole and mebendazole is commonly used in this part of the world. Now, these are usually used in inoperable patients or even the preventive strategy of these high disease for avoiding a recurrence in the future, and then combination therapy with their surgery and other minimal access approach. There are different contraindications to the drugs that one has to keep in mind, like severe chronic hepatic disease, you need to have an LFT, or a bone marrow depression, or even early pregnancy. So we have to have a CBC and LFT maintenance once you are putting these patients on these drugs. The rate of relapse after chemotherapy has been reported to be around 3 to 30%, varied because different people use different approaches. What WHO has recommended is using it for 4 days before surgery and then continuing it 1 month for albendazole and 3 months for mebendazole. This is especially for areas who are endemic and who do not cross over or who do not have an access to other surgical approaches. We have done one study where we have found an albendazole as an adjuvant to the standard surgical management of hydrolysis. This is a high-impact paper where pre- and post-operative albendazole for 4 months we have found highly effective in reducing both the chances of presence of pernicious viability on the recurrence. This is another study we did, trying to know the role of albendazole in management of hydrolysis. Again, a high-impact paper with high citations. This is where we found that it's an effective adjuvant therapy in treatment of hepatic hydrolysis in whatever form you perform. This is another study we published, outcome of albendazole therapy in management of hepatic hydrolysis. There was a recurrence in patients who received no recurrence, who received both preoperative as well as postoperative treatment. These are the regimens we have followed. This is another paper we have published in the literature, latest prospective study. We have tried to see the cyst viability intraoperatively and then from the microbiology department. And we have tried to find that 2 weeks preoperative medication is sufficient to render most of these cysts in young individuals inactive, whereas we can continue the same treatment for 4 weeks in elderly and especially immunosuppressive these patients. Now the care procedure, we just inject the strolecidal agent, percutaneously aspirated and then again re-aspirated. Then there are modifications of care in form of catheterization and cyst pyrolysis. This was one of the, how to know the indications. Usually simple cysts we take into consideration once we have to do care. We do not take complicated cysts into view, and we have to use an adjuvant chemotherapy in these patients. This is first of its study which was published in New England Journal of Medicine. This was a combination project done by gastroenterology and general surgery, where percutaneous drainage was compared with surgery for hepatic hydrolysis. And this gave a validation to applying even the minimal access procedures to such cysts. We need to have a regular follow-up and imaging, especially ultrasound in these patients. Their titers may increase, which I have told you already, serotiters. Early relapse may be found with high antibody titer, or there may be a late relapse when you have a fall initial followed by a rise. This is very important for prognostication of the disease and to see whether there is recurrence or not. So CBC, LFT, and serotiter. These are the usually three modes of management once you are doing follow-up in these patients. Open surgery, as everyone knows here, forms the important standard treatment for any high-grade disease cyst in liver. But there are contraindications like patients refuse surgery, or they are extreme age, there are pregnant women also, or there are concomitant other diseases or dead cysts. So you have to really see what is the approach, what Garvey classification, how to suggest the management policy in a particular patient. Sterilization of the cyst, I have just touched it. We have initially used hypertonic saline 5%, but most of the time we use povidone or chlorhexidine in our series. There are some complications of surgery also, like immune infection, chest problems, abscesses, leaks, and liver abscesses. This is one of the projects we have done between Cardiovascular and General Surgery and presented and published in British Journal of Surgery, where we were trying to do a mini thoracotomy and then do a frenotomy. So chest surgeon would do a thoracotomy and we would do a frenotomy and access the liver from the chest. This would decrease the mobility in these patients. But you would have a combination liver cyst as well as the lung cyst. This is another study where published the surgical management of complicated hydrolysis of liver. This is again a high impact paper. Just we wanted to review the clinical presentation, surgical management of complicated hydrolysis of liver, and to assess whether conservative surgery is adequate in managing such patients, rather than resection of the liver. This is another study we have published, a significance of bile leaks complicating conservative approach for hepatic hydrolysis. This is one of the problems most of the clinicians face. They put in a drain, there is a persistent bile leak, and they are worried what to do. Ultimately, in this study, we found that most of the patients, they go well with the conservative approach. Very few patients may need just an ERCP and just a sputotomy, nothing else. So you need not to worry about it unless and until there is a recurrence or there is some other problem like myeloma or infection or now there are managing the residual cyst cavity. We are having different methods like tube, introflexion, capsulorrhaphy, and capillage. This is another study we have published in literature using various modes of and seeing omentopexy being the best. This is another study we have published where tube drainage has been found to have a morbidity as compared to omentopexy. Now, laparoscopy forms the latest management of these patients. Deeply situated intraparenchymal cysts and inaccessible posterior cysts form the contraindications, but most of the time you are able to do these procedures. This is just to avoid the slippage. We have to have precautions in these. We have latest published a comparative study between hepatic hydroid disease, conventional surgery, and lab, where we conclude that laparoscopic hydroid surgery is safe and feasible for selected patients if the criteria are met and they are motivated primarily by low postoperative morbidity, mortality, and recurrence. The list of 2008 to 2020, we have done 365 cases, 95% success rate, 7% conversion rate, 9% morbidity, and 3% recurrence. This is the Sikim's advanced laparoscopy data. Now we are applying this approach to the complicated cysts of the liver also, which initially was contraindication. We have a 97 enrolled patients from 20 to 25 with 90% success rate, 5% bile leaks, and no mortality. Now, what are the lessons learned from open surgery right up to the laparoscopic approach? And now applying laparoscopic approach even to the completed varieties is that comprehensive imaging review and anticipation of complications, a backup plan and readiness for conversion reflects surgical maturity and not weakness. And this is the institutional log algorithm for these patients that whether to apply care, whether to apply lab, whether to apply open or even observation protocol is to be defined first, tailored to the patient population. The liver resection forms an important component, especially in patients of angular hypertension. We have found it where the recurrence is low, but the problem is that morbidity is high. The question that usually comes in clinicians' mind is how to manage the recurrence. You need to have a wait and watch policy with application of chemotherapy. Maybe you may have to do a pair again or a reoperation followed by chemotherapy. Now, prevention strategy in our committee forms the best. These are the various principles of personal hygiene, maintaining the meat inspection, and then periodic antibiotic usage and pet dogs. Then safe drinking water, vaccines, and immunomodulators use. All these studies over a period of 25 to 30 years has prompted us to publish a book on human abdominal hydrolysis, which is a Springer book publication having 10 chapters, can be useful to the clinicians if you are interested. Thank you all for patience.
Thank you, Professor Malik. As always, clear and crispy with lot of experience in the subject. Matter of pride is that here is the contribution of Jammu and Kashmir State. Thank you very much.
Thank you very much.
I call upon the next speaker, my dear friend and chairman of JAKASI, Professor Ejaz Ahmed Rathar, and his topic is Ecclesia Cardia, Evolving Strategies for Optimal Patient Care. 15 minutes, sir.
A very good morning to all the delegates and chairpersons. I am going to talk about the evolution of strategies in Ecclesia Cardia. So I will be finishing my talk less than 15 minutes because as a chairman I have to set the trend right because you know we are passing. So, evolving strategies for optimal patient care. W. Churchill, a statesman, a Nobel Prize winner, and a writer, has been twice the Prime Minister of Great Britain 1940 to 45 and 50 to 55. He has rightly said, to improve is to change, so to be perfect is to change often. So change is the only constant, and we as surgeons know that the technology is growing at a very fast pace, and we have to adopt the technology, otherwise we will feel obsolete. You know, the previous old surgeons here, I am also one amongst them, when there was a dictum that bigger the incision, the bigger the surgeon, then change it to keyhole surgeries, laparoscopic surgeries, and then to robotic surgeries, and now artificial intelligence. The question mark is whether we will replace it with this or not, that future will decide. Now, it was Thomas Wilson who first described the disease in 1672, and then von Michaelis in 1881 gave it the name as cardiospasm, and then it was found to be in 1920 through third and rate. They said that it is caused by the failure of the lower esophageal sphincter to relax, and Ernest Heller in 1913, around 1 century back, gave the first treatment for Ecclesia Cardia, which is still being the surgery of choice, first choice for all the surgeons for this disease. Now, the evolution has been from Thomas Wills When he described it, then Ernest held the open Heller's procedure, and then there came the new era of laparoscopic surgery when Alfred Busselli in 1991 performed a minimal invasive technique for this procedure. The pathology, as we know, is there's non-relaxation of lower esophageal sphincter, there's absent alostasis in the body, and it is thought to be because of the loss of inhibitory ganglion cells in the mandible plexus. So, if you go to pathophysiology, the mandible plexus inflammation is there or there is damage, then there is loss of inhibitory ganglion cells in the mandible plexus, and there is imbalance between nitric oxide and acetylcholine, while the relaxation effect of nitrous oxide is less and more activity of acetylcholine, which leads to the atresia cardia. The diagnosis is by the endoscopy. You can find the normal esophagus in the first slide, then you will find a tight or puckered lower esophageal opening. The four findings are classical. Number one is that you find froth at the lower esophagus, and then second, you may find fluid in the lower esophagus, or there may be some food particles, and finally, you may find the puckered lower esophageal sphincter. The barium meal that has been being done, as you know all, that it shows a hold up with the proximal dilatation and distal narrowing, which we call as bird beak sign. And in long staging cases, you may find a very huge dilated esophagus, which we call as like this colonic esophagus. It looks like a colon. And then there may be also an X-ray test, the frontal X-ray, frontal gas shadow may not be seen. Now, manometry is the gold standard for the diagnosis, and this we have the four findings: the hypertension of the lower esophageal sphincter, which is the majority of the cases. Then we may find the non-relaxation of the lower esophageal sphincter, esophageal peristalsis, and elevated pressure. So this is the Chicago classification. I will not go into the detail. Now the management of the atresia cardia, it is medical or it is surgical. So in the surgical, if the patient low risk, you can do the cardio for this myotomy, Heller's myotomy, or you may go for the pneumatic dilatation. And if there is failure of that one procedure, you can go to the second, right? The pneumatic dilators is available with us, or they are the polyethylene dilators, and size as 3, 3.5, and 4. You keep the dilator within at the site for 15 seconds to 30 seconds at the pressure of 15 pascals. So, if there is a failure of myotomy, and in long-standing cases where most of these patients are being treated by our physicians, and they come in the long-standing where you may do an esophagectomy, which is a big drastic procedure and with high complication rate, but that's where the losses are. So if the patient is high risk, we have the drugs for that, which I'll discuss in the next slides. So this is an outline of management. Non-surgical, we have medication. In medication, we have the nitrates, and then we have the calcium channel blockers like nifedipine, 10 to 30 milligram dosage. But the problem is that you have the short-acting drugs. You have to repeat that dose, and then also there's side effects like postural hypertension with these drugs. And then other drugs have also been like sildenafil have been used, and then we have the botulinum toxin, which is given as 1,000 units with the injection form at the lower esophageal sphincter, which cause the relaxation. But the problem is that the repeated injections cause scarring, and which makes the surgery next time more difficult, and the chances of perforation are high after that. Now, POEM has been introduced, which I will discuss in the next slide. So, they are the drugs: isosulfide mononatrate, calcium channel blockers, then sildenafil citrate, as I said, anticholinergics, but they are preserved for these patients who are not fit. So, then POEM was discovered by a Japanese physician in 2008, while we create a subnuclear hybrid procedure, while for endoscopy we create sites and then death. So surgery has been the gold standard. So this is our experience, a limited experience, because most of these, as I said, is the patients are being treated by our physicians till the last stages, and you are happy if you are working in a high volume unit where you have a well-established department which send you referrals, or your friends will send you the referrals, or be happy, lucky like me to have your relative like my grandfather, his father-in-law sent me all these patients, only one I got of my own. So you should have a referral, because otherwise they will be treated by physicians for most of the time. The first patient I reported from Dr. Babar's area 5 years back, though you had not started I think that time, it's 5 years back, a lady who was being treated for this ecclesia cardia for the last 10 years with repeated all regurgitation and foul breath and all dyspepsia, going from pillar to post, but always being managed by drugs. So then what I did, I first investigated the patient. I will describe that in the next my video. So regarding this GRD, this is our result. Sorry, this is the first in lab. We have completed lab procedure in all three, but in one, because of the lot of scarring and we did not proceed laparoscopy, so I have to convert that procedure. There was no complication, and they are doing all well. And follow minimum is 4 months and maximum is 4.5 years. So GRD may occur following myotomy, as the natural anti-reflective barrier of lower esophagus is completely disrupted. So fundoplication is usually added. So preferred option is anterior fundoplication, which is door 180 degree, or posterior propel. GRD was reported in 8.5% of patients of myotomy with fundoplication and 35.1% after myotomy without fundo. So there is a very huge difference between this if we don't do that fundoplication. The recent report on large series of 1,001 patients treated with laparoscopic Heller's myotomy and door fundoplication at Executive Center found that 9.1% had GRD, which was confirmed by manometry. Patient undergoing door or torpid fundoplication expressed no significant difference between the two. It is the choice of the surgeon with which he feels comfortable and which he has been doing, so he can adopt that procedure. Mucosal perforation has been seen to occur in 2.5 to 7% of the patients. If we detect it on table, it is to stitch the esophageal mucosa with 4-0 or 3-0 thread, and then place the drain. So this is the Alfred Puccini who did the first Heller's myotomy laparoscopically. So this is our little experience of this is the barium esophagus. I will be doing it quickly. Here you can find we have used the fan retractor. It is better if you have an Atherton retractor. So, but in government setup, you know there are all limitations, and then false parasita, we just cut it and then so this is the So this is the myotomy, this is the adhesion we are doing, removing with the harmonic scalpel. You know, in long standing case, there are a lot of adhesions. We mobilize the esophagus and separate the cuts from the esophagus. With the right cuts, you can see, mobilize the esophagus completely. Take care not to perforate the esophagus. This is a loose annular tissue. This is the plane of dissection, as you know, holy plane. All over in all the surgeries, you can go and see the honeycomb appearance, and that's the safer plane always. So this is the mobilization. Now then you split the muscle layer 6 centimeters proximally from esophagus, split to 2 centimeters at the gastroesophageal junction, and use a plate of gauze to prevent the bleeding, and it acts as a good hemostatic by giving the pressure for 1 or 2 minutes if there is any bleeding. Take care not to cut the mucosa, because in long-standing cases, especially those where we are doing the ingestion of botulinum toxin, the chances of perforation are high. So you have to be very meticulous in splitting these muscle fibers, and you can guide your dissection by putting blunt some sector or Maryland below the muscle layer once you have separated at one place, so that there are not chances of injuring the mucosa. So this is the muscle we are splitting. Yeah, we can continue with this, and we can continue if you have any questions or so. Thank you very much.
Thank you for letting us revise our knowledge about the ecclesia and updating us also with the latest
wonderful, very
form of treatment. You really cushionize us.
Thank you.
The last and the next speaker is Dr. JAKASI. He will be talking on pediatric plastic surgery and experience in GMC Kathua. Dr. JAKASI.
So, first of all, I congratulate the organizers of this wonderful event, especially Dr. Ravinder, Dr. Anshuman, Dr. Sanjeev, Dr. Ankush. So, they all have been associated with me. Some were my students, some were colleagues. So, very glad to see this and privileged to present my work in front of my working teachers who are on dais. So, the topic is pediatric plastic surgery of experience. So, how much later is later? When to operate the patient, at what age? So, on this side, we are seeing a female, elderly, having a cleft lip, with deformity, which increases with the age, like the nasal ala, which is clear. Right side, a young boy having been operated well in time, and you see a symmetrical lip, a symmetrical nose. So this is the pre-op and post-op pic. You see, the nasal deformity is not that well corrected, which is seen in the previous slide, as can be appreciated in this picture. Another deformity which is seen usually external angular termite. So this will be operated around the age of around 6 to 7 years because the frontozygomatic suture that uses by this age, and if there is a small star, it doesn't have any communication then intraterminally. So the post-op picking. Now when to operate? Within 3 months, there are chances of sudden infant death syndrome as the physiology of the newborn that almost matches the adult by around 1 year of age as regards the anesthesia is concerned. So anything which is not life-threatening or limb-threatening can be postponed at a later date. Then when The reconstructive surgeon is confident and comfortable. That is when the child grows to the adequate size, so that the affected organ has grown to the adequate size. Early age, keeping in view the body image, as the child may go to the school and may feel harassed, inferiority complex, etc. So timing for surgery, cleft lip, 3 to 6 months. Previously it was rule of 10 months of age, 10 lb, 10 gram hemoglobin, but now standard age, 3 to 6 months to avoid the other deformities. Cleft palate, around 9 months, or preferably within 15 months of age. Hypospadias, around 10 to 18 months. Syndactyly, polydactyly, 10 months or around 1 year of age. The Stiction band syndrome, which can be seen on the limbs and can cause a threatening to limb as soon as possible if limb threatening is there, and if not, around the age of 1 year, one can wait up to 1 year. Post-traumatic wounds as early as possible, major reimplantations as early as possible, preferably within 6 hours to avoid ischemic injury. Now we have a late reconstruction, 6 months old child. So this child was from a nomadic family and had a history of being bitten by a mongoose, brought to us. So we freshened the wound edges. On this side you see there was missing upper and lower lids, both gone. Fashioned a forehead flap, this is a pedicled flap. So brought it down. So in first stage we used it to reconstruct both the lids, and they were closed. Later on, the flap was divided in the midline. A part of it formed the upper lid, a part of it formed the lower lid, and the child was well and sent home. Firearm and colostomy. This is a case from a Punch district. The young boy was brought to us with a history of gunshot. You see, this is wound of entry behind the ear, and this was the wound of exit. And the cervical vertebrae, that were upper cervical vertebrae, they were found exposed in the wound. You see, these are the pellets which are seen in the X-ray. So a vertical islanded trapezius myocutaneous flap, it was planned on the back, it was raised, and it was inset here. The wound was primarily closed, and drain is kept. So you see, postoperatively, flap is well set, and there is full function of the arm, as only the vertical part of the trapezius was utilized and horizontal part was intact. So there was no loss of function of the trapezius, and it did well. Another boy, he had a injury to the foot. Accidentally, he had to step on a mine in a Khanur sector. He was brought to us with this situation. So we took him to the OT, debrided all the dead tissue. This was the after debridement. So a split skin graft was applied, utilizing the first step of the reconstructive ladder because the defect was too big. So grafted. This is the post-op around 2 weeks thick. So this was settled. He was planned for this toe reconstruction, but he never reported thereafter. But he was able to walk. No cleft lip. The cleft lip is repaired as already told around 4 months of life. This is a bilateral cleft palate. Isolated cleft of the secondary palate. See, this is the cleft of the secondary palate. Operated around 10 months of age, and it is well post-operative. So left complete cleft lip with palate. So initially the child had undergone a repair for the cleft lip and the palatal surgery. It was planned later on, but this child had reported to us at a later stage around 4 years of age, and this was the post-op result. Now, congenital hand anomalies, when to operate. Ideally, when the child starts using hand, that is grasped with no dexterity, around 9 months, the child starts holding the objects and prehensile function should be restored by 9 months. First is the syndactyly. You see, this is a third web syndactyly, incomplete type. So, planning of surgery is done. This is the post-op result. Again, another child with complete third web syndactyly. Acrosyndactyly, that is the digits they are short and they are fused also. So the nubbins which cannot work, they are excised and rest. We try to restore it. So this is another procedure done around the age of around 3 years preferably. This is you see a hypoplastic thumb, doesn't have any muscles and it doesn't serve the function of the thumb, as thumb constitutes around 50% of the hand. So a planning was a polycization, that is mobilization of the index finger to take over the function of the thumb. So the flap is planned, this is the skin marking. Here, what is done, the index finger, it is cut at the level of the metacarpal, mobilizing all the neurovascular bundle along with it, and then it is mobilized, and this metacarpal part that is then fused with the metacarpal of the thumb. You see, this is polycization index, that will take the function of the thumb. This is the post-operative peak of the child. There was a video, but polydactyly, that is one of the commonest type of the polydactyly of the thumb, that is vessels type 4. So it needs a dissection at the level of the proximal phalanx, as we have to cut the proximal phalanx, only removing the skin won't do. And then sometimes it has a tendon also, which needs to be tied, and tendon reconstruction of the other thumb, that is the main thumb, that needs to be done. So this is the post-op result. Constriction in syndrome. It is a amniotic band syndrome also. It is intrauterine. There are the amniotic bands in which the limb can be intertwined. So they form a constriction mostly on the upper limb or the lower limb. Sometimes they can lead to the in utero amputation also. So if they are brought, multiple Z-plasties are done. As reveals hemangiomas, won't go in detail of types of hemangiomas. So this is a hemangioma. She was first put on intraoral therapy, and after intraoral therapy, it regressed, and whatsoever was left, that was then excised. And another thing is, sometimes we get a venous malformation of the lip or cheek. So the treatment is excision only. Here, hardly the intraoral therapy works. So again, a pre-auricular. On this side, you can see pre-auricular venous malformation. It was first diagnosed as a simple cyst, but on doing the Doppler, it was a low flow vascular malformation or venous malformation, was excised and contour was restored. Another gluteal malformation, a boy around 12 years of age came to us, and then you see number of the hemostats which have been used. It was dissected, whole skin, and then number of hemostats were applied because it bleeds like anything. And ultimately this was the result. Ocular anomaly, that is the coloboma of eye, a part of the lid that is missing in the child, sometimes it is seen. So what is done is a lid advancement at the pretarsal level and putting in the skin to cover the cornea, and this is the later on child. Another condition is hairy knee eye. It must be operated before school going age. Let's see a girl having a large hairy nevus occupying whole of the left lumbar limb. So what was done is, here in this case, it was all excised and we put in integra there. Integra is a bilamellar membrane which has a outside silicon and inside it has got the collagen, which is bovine collagen, and sharp glycosamine glycans which are there. So we laid it because otherwise the uptake of graft and the cosmesis, that is poor if we simply apply the skin graft over it. So after applying this, the silicone sheet is removed after 3 days and it forms a well granulated collagen tissue over which the graft was applied. But later on what happened? So this is after skin grafting, but the child unfortunately died a severe contracture of the elbow because the parents did not put a splint. They reported later on. So again the contracture needed to be released and again the skin graft was made. So this is a malignant nevus. Malignant is larger in size. It was more than 6 centimeters in size, occupying almost half of the parietal region. So it was excised, first stage, put in a skin graft. Then this is a expander, skin expander, which was put beneath the skin. Graft, you are seeing this paragraph, we have put a expander, the skin is expanded and advanced. And this was the result later on. It is well covered by the hair. She has a small patch of alopecia, but lost to follow. Hypospadias, around 10 months of age, or preferably before 18 months. So what is done here is a textile using the perpuse, transverse perpusal flap, which is designed and put in place to restore. So post-traumatic injuries, so there was a heel defect in the child and he has electrical injury also. The posterior tibial vessels, they were intact. So their parascapular flap based on a circumflex scapular artery was planned and vessels, they were anastomosed end to side with the posterior tibial and the flap was well settled. This is around 4 weeks post-op. Fingertip injuries, thumb. This is a thumb injury, partial amputation of the thumb, but reconstructed by a local flap from the index finger. Dorsal metacarpal artery flap. This is from the index finger, mobilized, and this is the pulp of the thumb which is restored by this flap. Now, little finger defect. What is planned is a flap from the palm. This is called a thinner flap. Very simple flap, easy to elevate. In the finger, please elevate this flap. Finger is buried, and it is detached after 3 weeks, and the contour of the finger is restored. So this is the last slide. Major amputations, that is the implantation. Rarely we get such injuries. It was done somewhere, not in the center. I had gone somewhere in collaboration with my other colleague. We had an opportunity to restore this. Child brought with a saw injury. This was the distal, this is proximal. So on radiology, you can see the bones apart. So first, prepared the proximal and the distal parts, debrided everything, did a bone shortening, bone fixation by K-wires, restoration of the tendons and the muscles, restoration of vein followed by the arteries and nerves. It took us around 11 hours at a stretch. So this was a wound. It was initially kept open for around 24 hours so that it acted like a fasciotomy. After that, this small skin graft patch was put, and this is the post-op result of the child doing well. this was a firecracker injury. You see, this is thumb and this is the ring finger, almost amputated thumb, only joined by a nerve, and here it was a subtotal amputation of the ring finger. So restored the thumb, bone shortening, then fixation, neurovascular repair, and repair of this ring finger. This was early post-op. This is great post-op. Thank you.
Thank you very much. Despite your invitation by the APS con, you prefer to come here and attend this conference rather than possible. So you have a national conference outside in Varanasi, I think. So you prefer to attend here. Thank you very much.
Thank you, sir. That's an honor for us, sir.
Yes, sir. Honor for us. Thank you very much. It's all because of Dr. Binder. His love for him.
Thank you so much.
His love for him. And vice versa.
With that, we now move forward to the next segment of today, the felicitation ceremony as a gesture of gratitude and respect of our esteemed speakers and chairpersons. So to begin with, we would like to invite our esteemed chairpersons to felicitate our worthy speakers. Professor and Dr. Nisar Ahmed Chaudhary, Professor Emeritus Surgery. Everyone please give a big round of applause.
Yes, please, sir, please, yes.
Lights on.
Yes. Okay.
Next up, we have Professor and Dr. Ejaz Ahmed Malik, Professor General Surgery and Principal Skims Medical College. Please everyone give a big round of applause.
Yes, wait. Yes, please. Yes. Yes, sir. Look here.
Next up, we have Professor and Dr. Ejaz Ahmed Malik.
Yes, please.
Next up on our stage, we have Professor and Dr. Ratnakar Sharma. Now for the felicitation.
Yes.
Now for the felicitation of our esteemed chairpersons, we would like to invite on stage Professor and Dr. K.S. Mehta, Professor and Head of Department, General Surgery, ASCOMS. First, we would like to invite, Dr. K.S. Mehta to felicitate our chairperson, Professor Dr. R.P. Surungu sir.
Yes, please. Sir. Yes.
Professor and Dr. Tariq Azad sir. Professor Dr. N.C. Dhigra sir. And Professor and Dr. Sanjay Kumar Basin sir. Thank you so much for your kind participation.
A very fruitful morning to everyone once again. Now as we step into the next segment of this academic journey, we are absolutely delighted to carry forward the energy and the spirit of JAKASI Midterm Conference 2025. We are truly honored to have amidst us an august gathering comprising eminent surgeons, distinguished doctors, respected clinicians, accomplished academicians, and enthusiastic students, all united by one shared goal, the advancement of medical science and the spirit of lifelong learning. Ladies and gentlemen, let's give a huge round of applause to this inspiring gathering of tact, compassion, and dedication. With utmost respect and warm regards, we are privileged to welcome our honorable chairperson for this session, Professor and Dr. M.R. Atri, Department of Surgery, GMC Srinagar. Dr. Harvinder Singh Bali, Associate Professor, Department of Surgery, SCOMS, Jammu. Professor and Dr. Pranav K. Sharma, Department HOD, General of Surgery, GMC Udhampur. Dr. Sanjay Sharma, Associate Professor, Department of Surgery, GMC Jammu. The torch bearers of excellence who grace this occasion with their esteemed presence and fills us with renewed motivation. We request our chairpersons to grace the dais and take their seats of honor. Now we would like to hand over the proceedings to our esteemed chairpersons.
So, we are starting the next session. The first speaker is Dr. Bhagat Singh Pandey, next will be Dr. Ravi Bhardwaj, Assistant Professor, General Surgery, GMC, Jammu. She will be elaborating on breast infections in hernia surgery and other related guests.
Dr. Rajani is the assistant professor in GMC Jammu, and I think she's the female surgeon who's giving a tough competition to the male-dominated environment in the state. So best of luck, Dr. Rajani.
Good morning, Chairperson. I'm a esteemed teacher. I'm going to present my talk on mesh infection in hernia surgery and uninvited guests. As you know, the mesh fibula is standard for hernia surgery nowadays, though it has brought the recurrence rate down. But it has invited a problem along with that in the form of complication, mesh infection in hernia as an uninvited guest, which is difficult to predict, annoying, and resistant to treatment. And once in the house, it refuses to leave. Unwanted guest, no surgeon wanted in their life. So coming to what is mesh infection? It refers to colonization of prosthetic mesh leading to local or inflammatory response. If we talk about the incidence of mesh infection, this is more common seen following the open hernia repair, about 1 to 8%, and less with the laparoscopic hernia repair, less than 1%. And it also depends upon the type of the mesh used. If we go for the multi-filament polyester mesh, and the incidence rises more with PTFE mesh to the tune of 10%. What are the routes of infection? That is the direct contamination during the surgery, hematogenous spread, secondary infections following seroma and hematoma, and biofilm formation by the bacteria. Common pathogens involved are Staph aureus, MRSA group of organism, Staph epidermidis, Streptococcus species, especially beta streptococci, gram-negative bacteria, mainly Enterobacteria, androgen bacteria, including Streptococcus, and Pseudomonas and atypical mycobacteria, which are more encountered during laparoscopic surgery as compared to the open surgery. Hernia surgeons, they should know the patients who are likely to get the mesh infection. Those are the patients with the diabetes, who are obese, who are smokers, malnourished patient, patient with the immunosuppression, and patient with ASS score more than 3. And other operating factors which are, if the surgery is done in the contaminated field, emergency surgery, if there is lot of dissection involving the surgery leading to hematoma and seroma formation, associated enterotomy during the surgery, type of mesh used during surgery, if multifilament mesh is used, more chances of mesh infection is there. Lack of tissue coverage of the mesh. Longer operating time, which is seen during early learning curve, is one of the reasons for the mesh to get infected because of breach in the sterility. Poor sterilization. And how does mesh infection present? Usually it is the early infection which is more commonly present between 2 to 4 weeks. With all the signs of inflammation like redness, swelling, pain, discharge, intra-abdominal abscesses in the lap hernia repair, which is more common, and late infection which occurs months and years later, which present as a chronic sinus, persistent discharge from the wound, non-healing wound, and meschoma formation. So these are the pictures where from the patient which are showing a discharge from the wounds following an open hernia repair, multiple sinuses and multiple discharging sinuses, and the tracts they are seen. Then how you will diagnose this infection? The clinical symptoms and signs. Then you can go for the culture from the discharge in the sinus tract. But most of the time, the culture from the sinus tract for atypical mycobacteria, it may be negative and it can delay the treatment. So one has to resort to the clinical symptoms only. One can go for the ultrasonography to detect the fluid collection and involvement of the other organs. CT scan of the abdomen, which will tell you about the site of collection, extent of induration, status of the mesh, and adjacent organ involvement. If there is any involvement with the fistula or communication with the gut, one can easily see. And definitely there may be a role of MRI scan also here, which is not used in the first line investigation. One has to differentiate between the inflammation and the fluid collection. So how you will manage this patient? Initially, one should go for the conservative management in case of the early infection, which has got a limited role. Early management include in the form of percutaneous drainage, culture-guided antibiotics, and if one is planning to salvage the mesh, if one has used the monofilament mesh, then in that case you can go for the negative pressure wound therapy, and ultimately one has to resort to the surgical explantation of the mesh. Approach can be open approach you can use, or you can go by the laparoscopic approach. And later on the reconstruction, it can be done in the one stage only, or you can go for the stage reconstruction using mesh repair or component separation, or if you are planning for the simultaneous reconstruction, one has to opt for the biological meshes. So how you will prevent this mesh infection? So prevention is the key. You have to follow strict asepsis. One should go for the prophylactic antibiotics. Proper selection of the mesh is very important. One should avoid using mesh in the contaminated field, and one should go for a meticulous hemostasis. So this is a picture which is showing the mesh which once acts as a savior, but once it gets infected, it behaves like a devil, which is silent, stubborn, and difficult to treatment. But this devil is need to be out of the house, and how you will take this devil out of the house? By means of the open approach, which is the traditional, which leads to more morbidity, and you can opt for the laparoscopic approach also. I am going to present a short video. This patient who has gone laparoscopic repair for hernia. This is the post appendicectomy hernia in which TAPP repair was done. Why this video is not playing? This is a patient who presented to us with the incisional hernia following post-appendicectomy, in which TAPP repair was done. Initially, this patient was very toxic. He was having all the signs of a systemic infection. He was febrile, counts was there, leukocytosis was there. Then USG and CT was done. It was showing the collection. Percutaneous drainage was done. About 500 to 1 liter of pus was drained out. And the patient was not responding to the conservative treatment, and decision for laparoscopic explantation was taken. And abdomen is entered impacted by the farmer's approach, and after doing the diagnostic lab, the site of adhesion where the previous surgery was done is found. Omentum was found adhering to the site of adhesion, and once the lead point is made, then the dissection is made with the suction cannula, and whole of the omentum is brought down, and gently the mesh was seen, and this was dissected with the help of a hydro dissection, and all the tractors and the cannulas, they were dissected gently out from the anterior abdominal wall, and this mesh was fixed with the metallic cables, and there is also the appreciation of the absorbable tackers also. You can see the presence of the pigtail, which was used as a conservative treatment, which was tapped in as such to guide the further treatment. Then whole of the mesh was taken out, and it is put in an endo bag, which is not a special endo bag. This is just made in the OT from the IV drips cannula, and whole of the mesh is taken out, the epigastric pore, and this mesh is inspected, and this the drain is kept in the pelvic cavity. Another drain after giving a thorough wash in the cavity. We have placed a JP drain in the cavity, and this pneumoperitoneum is slowly exsufflated, and the mesh is extracted, and this mesh was sent for the histopathological examination. There is another video. Just there is another video. This is just multiple videos we have done explantation of the mesh. This mesh repair, he has undergone the inguinal hernia repair, and TAPP was done. And again on the diagnostic lab, we have found the gut was adherent along with the peritoneum. Lead point was found, and with the help of a dissection cannula, the pus was evacuated, and due precaution was taken that there should be no spillage into the peritoneal cavity, and suction is done simultaneously, and no attempt is done to draw the gut down of the peritoneum. Rather, the peritoneum along with the gut is brought down, and you can see the suture. I think previous surgeon has sutured the peritoneum with the suture, which is seen clearly. It is also taken out, and once entering the cavity, you can see the free fluid, and the mesh is lying free floating in the this lateral pocket, and the mesh is got hold. Again, it is dissected off, and you have to take a due care while you are dissecting from the cord structures, because that is the area where the mesh is adherent, and you can injure the structures. And the one point where you can find difficulty in these cases are the Cooper's ligament, where the mesh is fixed with the tackers. And in this case, the mesh was fixed with the metallic tacker and the Cooper's ligament. And every precaution is taken. One should be very, very gentle. One should not adopt for any haste in these cases. Otherwise, you see the mesh is coming out easily, and one is very hasty in taking out the mesh. And this is the point you can injure the structures. And you can go with the gauze dissection also, and gentle dissection and suction, taking all due precautions. Immediately again a pocket is found, and this mesh is again taken out completely, and again this mesh is taken out in this is the medial pocket from where the mesh is removed after the tacker from the Cooper ligament came out. So again this mesh is extracted, and drain is kept in the peritoneal cavity. So conclusion, consider the possibility of mesh infection in every patient who has undergone hernia repair involving a mesh. Mesh infection is preventable by means of selection of the mesh material. Maintaining sterility of the prosthesis is very important, and one should maintain the sterility of the operation theatre also. And one should opt for a proper disinfection and sterilization of the scopes and adequate antibiotic coverage. Late infected mesh explantation is more difficult as compared to the early mesh explantation. Hernia mesh fragmentation following partial explantation burden its complete removal. Laparoscopic removal is associated with higher rate of technical success and less morbidity. However, due to technical complexity, procedure should be limited to the experienced surgeon only. It should not be like that everybody should be taking up the cases. It should be with the experienced surgeon only. An incorrect surgical strategy could catalyze the chain of reaction of the complication. And it's worth to emphasize, prevention is better than cure. Thank you so much.
Thank you, Dr. Rajni, for coming out with such a wonderful topic, because as we, all of us, from senior to junior surgeons, we are going more towards the minimal access surgery in hernia with mesh placement. And as we all know, in Western world, we have most of the litigations are coming because of mesh infection. It's a nightmare. So that even people have stopped putting in a mesh, and they are coming back to the tissue repairs. Right. I would like to have comments from the experienced surgeons in our
Is there any positive role of pre-operative antibiotics?
Sir, they are saying the pre-operative antibiotics, they have a role, but proper sterilization you have to follow. Even the papers, recent literature is saying there is no role of antibiotic as such in the mesh infection. But proper sterilization is more important, one should not ignore that.
And as I get out from this paper, absorbable these tackers have a positive role. Is absorbable tacker usually better than the?
So definitely absorbable tackers, they are better than the metallic tackers because they are associated with the port side infection, they are hernia, and they are more leading to the pain. They form nidus for the further infection also, and these absorbable tags, they get absorbed over a period of time.
And in case of explant, it's easy to uproot the.
Yes, it's very important to uproot each and every tacker.
Yes, thank you.
And even you don't have to leave any part of the mesh also there.
Thank you.
I think let all the questions be directed towards the chairpersons, and this is the routine in every conference. This is what is to be done.
As far as your infection is concerned, the most important thing, have a consent from the patient before take up hernia.
Yes, sir.
I know all related complications of hernia surgery should be there, including mesh infection.
Yes, sir.
Second is, the most important thing is, one should not use Cydex for hernia surgery.
Yes, yes. And we have
that has no role. Plasma is the only answer.
Yes, yes.
Antibiotics and all, that's okay, but the most important is sterilization. That is the most important.
And the most important thing is, because we are all dealing with the public sector hospitals, there are so many cases. So hernia case has to be prioritized as the first case in our OTs, as a protocol. That's not a protocol, that's a religion. That hernia case has to be posted, be it gonguanal hernia or a ventral hernia. It has to be first case. Even over lap police or any other case which we do in the OT.
In olden days, hernia used to be last
case. We
remember. It is first.
We remember. Because we have learned the lessons over the decades of this experience. Thank you, Dr. Rajni, for your wonderful talk.
Can I give?
Oh, yes, please.
Hello.
We have a constraint of time, please.
Excellent presentation by Dr. Rajni. Wonderful discussion. But to the youngers, I would request that kindly treat mesh as a prosthesis. Always visit an orthopedic OT when they are planting an implant. See how they are careful about sterilization. Absolutely, during putting in a mesh, you should be absolutely same precautions and same OT environment as is done by orthopedic. Number one. Number two, when you think that there is a mesh infection and there is a collection, kindly do not put these. I have seen one what's called as regestant. Kindly do not put these pictures. If you think that there is a collection, you go. If it's a laparoscopy one, go in and get it out. Because by putting these what's called as pigtails, you are delaying the treatment. You are increasing the morbidity. The more you wear, the more mesh explantation will be difficult. That's my suggestion.
Thank you, Dr. Rajni, for such a wonderful and wonderful talk. Our next speaker is the darling of our department, GMC Srinagar. He is a professor of surgery and doing wonderful pediatric work in our department. He is the darling of everybody. Dr. Zafar, welcome and take the stage.
Good morning, everyone. Thank you very much, GMC Kathua and JAKASI for giving us this honor. Coming all the way and traveling to such a wonderful place. Greetings from GMC Kathua. And my talk of today is adoption and innovative technology in pediatric neurology. Gratitude to my teachers, Dr. Patnaik, my MCH teachers. There's a race. Who is to be the first? There's a race between GMC Kathua and GMC Rajuri. There's a race between GMC Srinagar and GMC Bharat. Who will get the things first and who will be the first to adopt this innovative technology. But there's no age. This is a simple workshop being conducted in the Premier Institute, and you can see the number of participants for a procedure what is known as stealth surgery. It is nothing but removal of swellings in a subcutaneous plane. And see the zeal and the zest with this age group to learn. So there's no age, is just a number for learning. Adult urology is the strength in the armamentarium. So more higher end armamentarium they have, the better results they have. Ultimately, over a period of time, this armamentarium culminated into pediatric urology. So this is a hyposphere surgery. Do you think this can be done with adult instruments? Do you think this can be done with adult sutures? So, with innovations in technology, the miniaturization of the instruments, the magnification of the vision, we were able to get results. We as postgraduate teachers cannot do alone. We have to inculcate, imbibe our learnings to our postgraduates, which will grow as a better senior residents tomorrow. So whatever we do has to be taught to our postgraduates. This is a simple picture where you can see a high magnified camera is being connected to an operating table. At the same time, whatever we are operating here goes to a monitor, and in the same sitting will be about 15 to 20 postgraduates who will be learning hyposphere surgery in real time in an interactive session. That is what the technology is all about. Coming to the lower urinary tract system. This is just a 9.5 French cystoscope. We have 15, 17 French adults, 22 French cystoscopes which are not available for pediatrics. Even though they are more expensive, these children equipment, they are being used for lower tracts. And we are able to get a newborn posterior valves ablated through this. We are able to get uretroseals ablated through this. We are able to get lower ureteric stones ablated through this. This is an OT of Government Medical College Srinagar, or even any other OT in our Kashmir division or Jammu division will be harnessing these basic equipment. And these things have grown over the years. And all these equipment we are able to adapt into pediatric urology. We have a 3-dimensional 3D laparoscopes, we have a harmonic, we have a very high-end electrosurgical unit, we have an inbuilt, we have a CRM in the OT, these are the LED lights we have, and we have high-end Ashman operating OT tables which we have in our OT, and this is you can't ask for better than this to conduct a pediatric urology program. The latest entry in our equipment has been the 4K. This has been a gift which our college and most of the colleges of our Jammu and Kashmir have been able to get it, and we are able to do these high-end procedures with this kind of equipment. This would not have been possible until and unless we would not have adopted it to this innovative technology. miniaturization of these equipments. They are all 3 mm instruments. We wouldn't have dreamt of them before 10 or 15 years. No, they are a routine because we traveled, we analyzed what is happening in the rest of the world, we got this technology to India, and we are able to produce them here with our own local vendors and all that, and able to give this benefit of these instruments to our children. So we never start with high-end procedures, we always start with something basics without jeopardizing the safety of the equipment, safety of the children. So something basics always have to be done, then you can proceed further as you go on doing it. Simple monopole cautery has been used out here. And this is the 5 mm clip applicator which has been used. Everybody does not have the advantage of having a 5 mm clip applicator. But it's a routine now, we are able to procure it almost every OT we have. With the availability of high-end equipment, we go for a pretty more higher surgery. Then, orthodopexy has been done routinely for non-valuable undescended testes. Then come to reconstructive surgery. Pyeloplasties are being done, whether it's transmesocolon or retroperitoneal. Retrovisualization, the beauty of it is the availability of 5 mm needle holders from different companies which are able to handle the small size of the sutures much better than anything else. These are all reconstructive procedures being done. This is a laparoscopic pyeloplasty in a duplex system. So you have 2 ureters, you are able to see clearly. This is a pathological ureter and this is a normal ureter. With this high magnification, you are able to separate both the ureters, maintaining the vascularity of the lower ureter, and you are able to do a nicely laparoscopic pyeloplasty in the duplex system. Then another reconstructive procedure where you have what we know as a retrocable ureter. So you are able to do a laparoscopic ureterostomy in a retrocable ureter. So this is the ureter I am lifting, and this is the IEC below. And we have another end which is your articulation. So you excise the part and you will be able to do a laparoscopic ureterostomy in a retrocable ureter. Coming to more destructive procedures or mutilating procedures, we were able to achieve a laparoscopic nephrectomy, and here you can see the innovations of using hemolog clips, and we have the privilege of having a 5 clip applicator for hemolog clips as well as hemolog clips also. Then you have partial nephrectomies we are able to do in the case of duplex systems. We are able to appreciate the giant ureter of a duplex system, upper pole moiety, giant ureter, which has to be dissected. And you are able to appreciate the lower normal looking ureter, which you have to conserve during the surgery. Duplex, it's upper pole partial nephrectomy. So we were under the able guideship of our Professor Mufti Mahmood sir, we were able to do a workshop on robotic surgery. But so far it has been a dream for our division, our UT, but we are working hard on it. We were able to get it through tremendous efforts. We were able to get for the workshop. I know how we got it from Bangalore through tunnels and trucks and trains. We did a 2-day workshop there in Srinagar, Kashmir. Got it in some hotel because it was the only the truck would enter into that hotel from the rear gate and all that. So it was a wonderful experience for all of us. So the aim of JAKASI is to learn, to teach, and to present. Thank you very much.
Thank you, Dr. Zafar, for such an wonderful journey through the urological work in pediatrics you are doing in our hospital. Any questions from the audience?
Professor Zafar is doing commendable job. He should be appreciated.
We all appreciate it. Thank you, Dr. Zafar. Thank you so much.
Now I would request Dr. Thomas Elgert, Associate Professor Department of Surgery, GMC Kathua, to present surgical management of pseudoendocrine. Thank you.
Good morning, everybody. And first of all, thank you, Professor Vinder, for allowing me such a stage. I'm really starstruck because I see on stage, off stage, everybody has been my teacher. So my heart is pounding. So if I make a mistake, fumble, please forgive me. It is very difficult to present something in front of those who have known me when I was nothing. I'm still nothing. But I say, when they got them, and we'll be going through what's a pseudonism and imagings of the pseudonism, treatment of pseudonisms, and I'll present a short case also. So, as we all know, pseudonism is a false aneurysm, so it will not be having all the linings of a vessel, and it will be just having the fibrin and the surrounding soft tissues at its wall. So, it's like something like this, but without the walls. So, there will be a neck and an aneurysm, and a pseudoaneurysm, sorry, and usually there is the cause is trauma, iatrogenic, then spontaneous dissections, myocardial infarction in pseudoaneurysm of the LV and heart chambers, vasculitis, and other inflammatory processes may also lead to pseudoaneurysms. Then clinical presentation, the patients usually present with a painful, tender, pulsatile mass. And the patient may note that the pulsatile mass is gradually expanding. And the patient may describe a history of catheterization or trauma. The patient will tell you that I had a PCI or a CT or an angiography done a few weeks back. Usually, either there is a history of angiography or dialysis. And a very big subset of patients that comes to us is IV drug abusers. So, because of the pain, tenderness, redness of the skin, a pseudoaneurysm is sometimes confused with an abscess. And the patients many a time goes to an orthopedician that I have an abscess, or general physical catastrophes are not unknown. We as CTVS surgeons usually get these patients that have been handled by somebody in the periphery. So, locations, they can involve any arterial segment or even a cardiac chamber. So, but femoral artery pseudoaneurysms are relatively very common because ease of access for angiographies, for dialysis, and even IV drug abusers, they easily give drugs into the veins, femoral veins, and they miss sometimes and give it in the arteries. So, carotid artery pseudoaneurysms, aortic and pseudoaneurysms, left ventricular and visceral arteries, but here we will be presenting only the peripheral ones. So this is a carotid artery pseudoaneurysm. Then a CT of the same, the aortic pseudoaneurysm. Here there is a pseudoaneurysm of the branch. And imagings, what imagings, you get a patient, you suspect pseudoaneurysm, you have to confirm it with the imaging. So which imagings we can go for? The options are ultrasonography, the easiest, best, easily available, investigation everywhere, in every hospital, every small clinic is an ultrasonography. The radiologist can easily detect a pseudoaneurysm. There is a typical yin-yang sign like this. You can see there is an inflow, outflow of this blood, and the radiologist can confirm that, say, okay, it's a pseudoaneurysm. But usually we don't operate until unless it's a very dire emergency on an ultrasonography, because we want to know the exact anatomy of the, so we go for CTs. Contrast enhanced CTs are the standard to look for the anatomy and all the peripheral tissues along with it. So CTs will show you something like this. A big thrombus. Contrast enhanced CTs are very good. Yeah, you can see here there's a pseudoaneurysm. Then MR angiography, costlier, time consuming, but sometimes in stable patients it also gives, and patients who have a contraindication for CT scans, you can go for MRI also. So MR angiography will give a picture like this. Angiography, selective angiography, very good pictures but not done routinely. Okay, what is the differential diagnosis? I have already explained that abscesses, hematomas, cysts, and two aneurysms can sometimes also present like this. So left ventricle pseudoaneurysms, I'll not go into that. Treatment of the pseudoaneurysm, how we can treat. The non-surgical options we can go endovascular covered stents. Endovascular procedures are done in patients who are stable and patients who can afford these stents also. It's not easily available, it's not cheap, you need expertise of the vascular surgeon, and still there will be a pseudoaneurysm left. You may block the artery, but you have an aneurysm like of a thing there. So we can give ultrasound probe compression. It's done in small pseudoaneurysms at the initial stages, that they give around 20 minutes compression under ultrasound guidance. They compress the neck of the pseudoaneurysm, and after 20 minutes you lift up the pressure, and you expect that the coagulation has happened by then at the wall and the pseudoaneurysm leak has stopped. But most of the time these usually fail, especially in bigger arteries like femoral, popliteal, they fail. In smaller arteries, maybe radial artery, it may work. Then ultrasound guided thrombin injections, sometimes they are given, and they also work in small leaks, small vessels, bigger vessels, not very useful. Then surgical ligation with or without bypass. I'll go into that. I've explained this, all this. So I'll present my experience at GMC Roda. Till now we have done in last 6 years plus, we have done around 9 cases. So starting in 2019, 9 cases operated till date, 6 were males, 3 females, 5 IV drug abusers. And in Jammu part also we get a lot of IV drug abusers with these pseudoaneurysms. 3 had been on dialysis. They had had a few sessions of dialysis through the femoral vein and maybe a puncture here and there. Then a post-PTFE grafting case which had been operated by our center. I think 4 years back we did a PTFE grafting between femoral artery and popliteal artery, lower end of the femoral artery. It worked for good for around 1.5 to 2 years. He stopped taking antiplatelets and started smoking again, developed a thrombosis then later gave way to abscess formation, then they developed a pseudoaneurysm. So sites were femoral artery 6, brachial artery 2, and 1 had a radial artery. Again a CKD patient, we had done this fistula in that patient, and that had developed into a pseudoaneurysm. So we have done primary repairs in fire. Primary repairs are usually done in patients who have a short history, because if there is a chronic patient of IV drug abuser with for years he has been having punctures and again sealing and again leaking, they become difficult for primary repairs, because usually a big segment of the vessel is destroyed along with the pseudoaneurysm. You have to resect that, put in some conduit. and we did reverse resection with end-to-end anastomosis in one patient and reverse saphenous vein grafting interposition in 2 patients. Resection with ligation in one patient, the patient I have already told you, the one who had a post-graft thrombosis. So, before we go to the case, a few points about that the one we had to ligate the vessels because he had been operated twice. We had done once an embolectomy plain, then we had done a PTFE grafting, and then a third time we had developed a pseudoaneurysm. When we started off, we had to remove the whole of the graft because it was infected, and we did not have any option of conduit because we could not put in a PTFE graft in an infected patient, and he did not have he had been already amputated on the other leg. We did not have a saphenous venous graft enough to put in a conduit. So we had to put in, we just ligated the femoral, deep femoral, common femoral artery above, and then we proceeded. And he was okay for next 6 months, but because he continued to smoke, he had severe pain and necrosis of the limb, so he landed in amputation on that limb also, but after 6-7 months. So this case is a 48-year-old female with CKD on hemodialysis with a history of few sessions of dialysis via femoral punctures, presented with painful swelling of the right thigh. She was treated as a small hematoma by the dialysis experts and nephrologists for a few days. Then a Doppler ultrasound was advised and which revealed a pseudoaneurysm of the right femoral artery, which was confirmed on CT angio. So that's a big this. So before I thank you, I'll take you to the video. I have a short video. So this is the pseudoaneurysm. Here, this is the proximal and this is the distal. So we are going to first of all take a control about the pseudoaneurysm in the common femoral artery. Here, we have just palpated the common femoral artery. We will just go and take a control there, and then after we have achieved a good control, then we can open up the pseudoaneurysm, because before, if we don't take the control in the proximal vessel, it will bleed torrentially and we may lose the patient on table. So after taking the control, we have this is the pseudoaneurysm, and we are going to evacuate. So we had around 400-500 ml of clotted blood into the kidney tray, and after clearing everything, usually in cases with femoral punctures due to dialysis or angiography, it is not usually that bad a vessel. Usually what happens is we take one suture or two sutures with the 6-0 or 5-0 proline, and that suffices. And the same was the case with this patient. We did 1 or 2 sutures at the whole side hole, put in a drain to keep the area clean after for a few days, and then the patient was doing very well. But if the patient is an IV drug abuser and has a long history, usually what happens, that area gets infected repeatedly. Repeatedly there is a puncture, there is a pseudoaneurysm, gets healed, gets infected, it's all fibrous. So in those cases we usually need to resect that segment. Either if you can mobilize the artery and do a primary anastomosis, or many a times we have to go for conduits. But because it is an infected area, PTFE or Dacron grafts are not used. We have to try and get something, a reverse saphenous venous graft or any other graft you can take from the body to put it inside, so that chances of infection, because if you put in a PTFE graft, you will have to take it out after a few days, because it will get infected and there is no way you can cure that. Same way the Dr. Rajni was presenting mesh, it's a prosthesis. Same way here. And one word of caution, very important, that all patients with pseudoaneurysm should undergo screening. Anyway, any patient to be operated has to undergo screening, because I have I remember one case in GMC Jammu. By the time I was called that there is a patient who has a pseudoaneurysm, it had ruptured inside the hospital. And I could see that PGs, out of enthusiasm to save a life, were all blood drenched. And the first thing I asked, have you done the serology? They said, "Abhi patient aaya tha, sir, we just tried." And he was hepatitis C positive. Make sure that you are sure that the patient is not infected, and still take precautions. Universal precautions we take. So thank you. Thanks a lot. That was the presentation I wanted to do.
Thank you, Dr. Babu. Thank you for the nice presentation. I am also going to
many times we have operated this case and we were not able to take control from the femoral artery. That time we used to go to the retroperitoneum, taking control from lexicon to take care of the femoral artery.
Thank you. Any questions from the audience?
Peripheral vessel aneurysms will need some form of repair or conducting or other things. About visceral aneurysms, I think nowadays more major visceral aneurysm formations, especially post-trauma, are being managed adaptively.
Yes, sir. You're exactly. The point is that what happens in visceral usually is it's usually an end artery. For example, uterine or a branch of the right hepatic.
Liver.
Yeah, this is usually post-surgery, post-trauma. You go embolize that, perfect. But even in, for example, somebody has a femoral artery pseudoaneurysm and there's a small rent, go and put in a curved stent, it will work fine because there is no. But once that pseudoaneurysm has formed, a big swelling is there, and you have cut off the source now, but you are left with a big blood clot which has been there for 2 weeks, 3 weeks. You will have to drain it somehow.
I have seen a new thing here, the drug abusers pseudoaneurysms. I think you should publish it, sir.
Sir, even skims, I think 90% of the patients pseudoaneurysm we did worse drug abusers, IV drug abusers, sometimes both sides. One time we did a couple. There was a husband, wife in their mid-20s, both of them had pseudoaneurysms, both were operated simultaneously within a gap of 2 days, I think. So it's very common, very common.
The population.
Inshallah, sir. We'll publish.
Thank you, Dr. Bhatt.
Thank you. Thanks.
Now I invite Dr. Vijay Konda, who is additional professor at Head, Department of Pediatric Surgery, GMC Kathua. He is going to talk about surgical diseases of newborn.
Good afternoon, respected chairpersons, my teachers from GMC Jammu and from my teachers from Shere Kashmir. Warm regards, sir. My topic basically, which has been given to me, is surgical disease of newborn. It's a very wide topic. I'll be focusing only on the important things and maybe skipping a few of the things. We'll cover only the important things. So this was a long back neonate's request to the surgeon. Please exercise the greatest gentleness with my diminutive tissues and try to correct the deformity at first operation. Give me some blood and proper amounts of fluids and electrolytes. Add some oxygen to anesthesia and I will show that I can tolerate a terrific amount of surgery. You will be surprised at the speed of my recovery and I shall be grateful to you. So this holds true even today. From neonatal surgery point of view, there are few red flags which are important for us as a clinicians and for residents especially. For respiratory distress, labored or very rapid breathing, cyanosis, excessive salivation, vomiting, bilious vomiting, abdominal distension, failure to pass meconium in the first 24 hours, convulsions, jaundice with pale or white stools. So this bilious vomiting, as a surgeon we know, for infants specifically, it indicates intestinal obstruction unless proven otherwise. DDs may include malrotation with or without volvulus, some intestinal atresias, endopancreas, Hirschman disease, or some peritoneal bands. Depending upon the severity of obstruction, different colors of the bile may be there. When we have bilious vomiting, abdominal distension, failure to pass meconium, we know that there is intestinal obstruction. If there is no distension, it may be a proximal obstruction. If there is associated with abdominal distension, we may have distal small bowel or large bowel obstruction. We have this case, the term baby, 2 kg weight, discharged after delivery, passed meconium, antenatal history was normal and presented at day 5 with yellowish vomiting. Admitted and managed conservatively. Gastric shadow with paucity of gas shadows in the other part of the stomach. Presented again after 8 days with bilious vomiting. We got the contrast study done. The DJ was towards the right side of the midline and on Doppler there was a whirlpool sign, a swelling of the mesenteric vein over the mesenteric artery. So on exploration, the malrotation with midgut volvulus. In pediatric surgery, it is considered one of the true surgical emergency. along with the torsion testis. Timely intervention may save a lot of gut. Another patient, very clear from resident point of view, double bubble gas, bilious vomiting, antenatal history of polyhydramnios. From gynae point of view, polyhydramnios has many implications for pediatric surgeons. Down syndrome, pointing towards duodenal atresia. Another one which shows triple bubble, pointing towards the jejunal atresia. For ideal multiple airflow levels. I may be refreshing the basic knowledge of the other people also, but it's important for residents also. Then this is colonic atresia, one large gas shadow occupying more of the abdominal wall. Then there are only few conditions. In most of the pediatric surgery conditions, there is abdominal distension after few days of the birth. But there are few conditions where we have abdominal distension from birth only. They include meconium ileus, meconium peritonitis, or abdominal lump, or ascites. Meconium plug may be seen on intraoperative finding, may present like this. We may have to do enterotomy to remove this. Then this another picture which shows antenatal scan of echogenic ball, possibility of meconium peritonitis and calcification within the abdomen. They may point towards the meconium peritonitis. Yes, this another finding very dear to the pediatric surgeons, absent anal opening. Anorectal malformation, the wide spectrum in males as well as females, like vestibular fistula, opening within the vestibule, or may be anteriorly placed, or may have a low anorectal malformation with bucket handle deformity, or anocutaneous fistula only. So, if it is a high type or intermediate type, may require colostomy immediately within 24 hours. And if it's a low type, it requires angioplasty. High divided sigmoid colostomy preferred for definitive procedure. There are different procedures, many procedures. More commonly preferred one is Alberto Pena's procedure of posterior sagittal anorectoplasty. Another very common disease in pediatric surgery is Hirschsprung disease. Most of the newborns failure to pass meconium within the first 24 hours. Abdominal distension, poor feeding. Classical one includes rectosigmoid type because of the aganglionosis. Depending upon the extent and investigation of barium enema and rectal biopsy is done. Definitive procedures include Duhamel, Sauvet, or Swenson's. Then another anomaly, abdominal wall defects like omphalocele, gastroschisis. Differentiating feature includes covered by sag, without sag, and omphalocele associated with the 50% with associated anomalies, cardiac also with poor prognosis, gastroschisis as compared to has very 10 to 15% associated anomalies and good prognosis. We are able to close gastroschisis immediately, that's good. If not able to, we may require stage reduction using the silo. Then another disease in premature newborns, necrotizing enterocolitis, mostly in medical NICUs, for which they call as regular basis. Clinical abdominal findings may be erythematous distended abdominal wall with cellulitis and maybe hemorrhagic and ischemic intestinal necrosis, feeding intolerances, abdominal bloating, perforations. Diagnosis include X-ray, blood investigation, and treatment may include the intestinal vessels, stop feeding, IV antibiotics, exploration depending upon if there is a perforation or advanced stage. Then respiratory distress in newborns. The few surgical conditions like diaphragmatic hernia, esophageal atresia, lobar emphysema. Esophageal atresia also a dear disease for the pediatric surgeons. Sign tachypnea, nasal flaring, retractions. These are different photographs shown. Chest retractions, nasal flaring, and cyanosis. They should be picked up. William Osler, a few years back, had said, listen, listen, listen. And we think as a pediatric surgeon, along with listening, we need to see, and see. So this esophageal atresia presentation, drooling and excessive oral secretions, sucking the baby appears choke, may choke, may have difficulty maintaining the airway, significant respiratory distress. On insertion of the tube, it doesn't go beyond 10 centimeters. This may be the finding, and if you are inserting the feeding tube, it may curl within the on lateral axilla. And the pectoral anomalies are very common with this, that define the prognosis of the disease also. And Treatment includes surgery, tracheotomy, primary anastomosis, and ventilation few days. And if the gap between the both ends is too long, may require cervical esophagostomy, gastrostomy, and definitive surgery later on. And another is a congenital diaphragmatic hernia. Presentation may be cyanosis at birth, respiratory distress, scaphoid abdomen, absent breath sounds. This may be the finding. And requires, if associated with respiratory distress, intubation, bag and mask ventilation is not indicated here, and surgical reduction, repair with reduction of intestinal contents in the abdominal cavity after properly stabilizing the pulmonary hypertension. The urology part has been covered by the professor, and will only be telling about the sociocultural also has been defined. One of the common disease and commonly antenatal may also present with the hydrouteronephrosis, and for that we require MCU for diagnosis, and then cystoscopic valve ablation is being done, and patient kept on long-term follow-up to prevent the renal damage. So this is basically algorithm. Then is a bladder extrophy. This was a patient which was operated, came to us. It was a delayed case basically of bladder extrophy, where there was a wide pubic diastasis of 7 to 8 centimeter. So we required the help of orthopedician. Iliac osteotomies were done, and with that we could close it. And this was another Wills tumor case which was operated last week with us. And thank you. There are a lot many diseases I missed because of the time schedule. Just covered important.
Thank you, Dr. Gordon, for such a nice presentation. Now I invite questions from the audience for an expert advice.
Surgery to please come forward and felicitate the esteemed chairperson with the token of respect. We first invite Professor and Dr. Emma to kindly come forward and accept the gratitude.
Yes.
Next, we invite Professor and Dr. Pranav K. Sharma on the stage with a huge round of applause.
Yes.
Now we invite Dr. Harvinder Singh Bali to please come forward for felicitation and accept the token for appreciation. And finally, we invite Dr. Sanjay Sharma to please come forward and accept the token of respect. Thank you to all our respected chairpersons for their gracious presence and valuable
surgery as follows. Professor and Dr. Ejaz Ahmed Rathar, Professor and HOD, General Surgery, Skills. Stalwarts in the field of surgery who continue to inspire both students and colleagues with their dedication and whose leadership and contributions have always motivated generations of medical professionals. Thank you, esteemed chairperson. Your presence elevates the academic stature of this conference. We humbly request you to kindly take charge of the session and lead us through the upcoming scientific deliberations.
So now we start the session. First speaker is Professor N.C. Ditra. He was Professor and Principal of GMC Jammu, and he will be speaking on current management of undecided testing. Very interesting topic. And I think your super specialty, super on this topic. Undescended, I think, was a favorite.
Worthy chairpersons, dignitaries of the dais, faculty members, residents, ladies and gentlemen. Testis is a very small organ, but very important organ. And it is not vital, but it is important about the vitality of the person. In next few slides, I will just go through an overview of testicular embryology, undescent, and other related issues. And it will be overview. I'm not going into details on many things. 4 things: hypospadias, congenital hernias, hydrocele, fibrosis, and undentectasis are the commonest congenital anomalies affecting the inguinal region. And it is the most frequent endocrine disorder in male children. It is also called tripartitism because it comes from the term hidden testes. There have been attempts at surgical correction of undescended testes right from 1820, but it was unsuccessful. The successful attempt at occupancy followed somewhere in 1877. The incidence of undescended testes varies according to the age and weight of the baby. In premature children, it may be around 30% at birth, and it reduces to 4% at 1 year of age. Vis-a-vis, full-term babies may have 4% incidence at birth, and it goes to 1% at 1 year. And after that, during adult age, the incidence remains 0.8 to 1%. This figure was given somewhere in 1964 by Farrington and Scorer, and it remains unchallenged and this changed since then. There are shifts in the management of undescended testes. It was first thought it is a mechanical event, then became into neurohormonal, and of course latest genetic mutations and other affected disorders. The diagnosis, which is mainly clinical but was supplemented by ultrasonography, but attempts at angiography, CT, MRI, they have been not so successful. The best investigation, especially for non-terminal testes, is diagnosis with laparoscopy. And those patients who are having some genetic disorders or dysmorphism or syndromic presentation, hormone, karyotypic, and genetics may be important. The age of surgery in undescended testes has been on a sea change within the last 50 years or so. It was late and now it has come on to early surgery from 6 months to 1 year. Even people are thinking it should be done in 3 months, but that is debatable. A surgery which was conventional, often under tension. People were just pulling the testes and fixing it somewhere. I have seen my teachers doing archidopexy, putting the testes somewhere in the thigh, somewhere on the opposite side, but they were just strangling it rather than fixing the proper way. And now with cord lengthening procedures, which may be laparoscopic or may be open, or even some person may be requiring heart condition, this has made a little possibility of decrease in testicular atrophy, which was because of testicular tension and fixation. And the prognosis, which was mainly focused on fertility, now we are talking of decrease in cancer rates. The embryology of testes is a very, very interesting, but I will make it very simple. The testes develop at the lower pole of the kidney in the lumbar region, and this is from genital ridge or ambiguous genitalia, which can differentiate into testes or into a ovary. But the defining factor is the short arm of Y chromosome, where we have a testicular differentiation factor, which causes differentiation to the formation of testes rather than ovary. So testicular development is active, the ovarian development is passive. So we have to have that. There are many factors which I will be coming on later on. So we have a key actors in testicular descent. One is the governor, and second is the cranial suspensory ligament. And then of course these factors are affected by testosterone. Then we have this insulin-like growth factor, and then of course we have other factors which are unnamed sometimes. So this testis, which is there in the lumbar region, which is attached by cranial suspensory ligament, this is regressed under the effect of testosterone, and other hormones, and it causes also testicular, cornacular, growth. Very important is the role of gentle branch of femoral nerve. This is common, and it was studied somewhere in neural tube defects. Those children who are having a neural tube defect where they were defective, gentle femoral nerve, chances of undescended testes are more. So then we have another phase in the testicular development, that is in the inguinal-scrotal phase, and this is again controlled by testosterone and genitofemoral nerve with CGRP, that is calcium genital related peptide. This not only controls the growth of the testes but direction of migration. When we were students in 1980s in MBBS, there was a concept of tails of Lockwood. They say there are 5 tails of Lockwood. One is scrotal, then is perineal, then is other. So if say whichever this tail is strengthened, that will be the migration of testes. And if there is other are broken, then they will go to the ectopic sides. The clinical presentation of testes is very simple. You have a abscess test, one or other scrotum. There may be lump, which may be the scrotal region, suprascrotal region, inguinal region, or in ectopic sites. And pain. Pain is because of torsion, or if there is an associated hernia which is called stenting. In children who are having intra-abdominal testes and they come with a pain, we should always think of a concomitant growth which causes torsion of the testes. Otherwise, intra-abdominal testes hardly undergo any torsion. And then, of course, presentation may be just a inguinal hernia, which may be a clinical hernia, bigger one or a smaller one. The classification of undescended testes is based on either we do a clinical examination, then we say there are impalpable, they may be radicular region, they may be deep inguinal ring, or they may be intra-abdominal, or they are palpable, usually at the neck of the scrotum, superficial inguinal cord, or lower in the canalicular area. And there is another variety of testes which is called emerging testes. These testes come out and then go inside. They are called emerging testes. They are basically intracanalicular testes. And then, of course, when we do exploration on surgery, we may find testes are intra-abdominal, intracanalicular, or extracanalicular, or that they are situated ectopically. I just want to highlight here, testes, undescended testes has been differentiated from a retractile testis. A retractile testis is the one which is a normal testis, but it goes up and comes down. But when you manipulate it and are able to bring without pain at the base of the scrotum and it stays there, that is a retractile testis. But if a testis is there and we are not able to bring it at the base of the scrotum, or we are able to bring it with pain, that means it is a testis which is a high scrotal testis and it is part of undescended testis. Testis may be just a simple mechanical phenomena. There are no associated factors, but these factors are normal. I am not going to take them to syndromic. Or they may have some syndromic features, some syndromes where there are multiple anomalies, there are sexual anomalies or anomalies of disorders of sexual differentiation. So they are called what is called as a syndromic. They are with the syndromes. I think this slide is as old as my professional life. When Professor Kapoor was the HOD, he used to teach us undescended testes, and he used to tell, if you want to remember the complications of undescended, remember testes. I still remember. There are many other mnemonics, but this is the best one. That is torsion, epididymal anomalies, and epididymitis. This is very important, epididymal anomalies. Some of the patient may have normal, descended, or extra testes, but in spite of that they are fertile, infertile or subfertile. There may be epididymal anomaly, like there is a disconnection between the epididymis and vas deferens, and the patient may have no conducting mechanism for the sperm, so they will become sterile or subfertile. That is sterility or subfertility, then trauma, then of course inguinal hernia and susceptibility malignancy. Complications of Parkinson or undescended testes. See, germ cell development is affected because they are in the abnormal place where the temperature is high. Normally, the temperature should be somewhere 33 degree, but they may be at 57 degree because they are internal testes, and this affects the spermatogenesis. And then, of course, the fertility will be more affected when the testes are bilateral or they are unilateral. And then, of course, there is 5 to 10% higher incidence of this malignancy in the testes which are undescended rather than who are descended, or they are brought down by surgery, that is orchidopexy. And then, of course, there is, when you bring testes down, there is chance the testes will have less chances of malignancy, and secondly, it exposes the testes to what is called an TSE or testicular self-examination, so that we are able to detect the malignancy at an earlier time. Other associations like inguinal hernia, torsion, trauma, as I discussed earlier. But one thing is, if the test is not fixed in a proper time, they will have the child will have psychological distress or emotional distress. The diagnostic investigation or diagnosis is based on clinical examination is the best examination, because all testing which are palpable they will be detected by them. So don't need of any investigations. Investigations are only needed when the test is not palpable. So ultrasound is the best investigation we do as screening or as angiography, tomography or magnetic resonance. They are not done. But they may be needed, especially CT may be needed if you are suspecting a tumor in an undescended test which is non-palpable. Routine investigation, as I said, they are not recommended. Diagnostic laparoscopy is the best investigation when the test is not palpable. But so there are patients where there are multiple anomalies, that is extreme hypospedia, multiple dysmorphic faces, or other problems, when you will need serum biochemistry, hormonal assay, ureotaping, and genetic studies to rule out what is called as syndromic type of undescended testes. What are the treatment goals in management of undescended? One is the functional performance of the testes, that you have to stabilize the function of the testes which is being damaged by its unnatural position by thermal damage. And secondly, this, as I said, aids in the early detection of malignancy if the testes are in scrotum. Then, of course, aesthetic appearance is increased because otherwise the scrotum is empty. Then it potentially decreases the complications or reduces the complications as of hernia and testicular torsion. I will come to that later on, but I just want to point out, normally 6 to 18 months of age we do orchidopexy, but in patient where there is a torsion or where there is hernia, the orchidopexy is done earlier, we don't delay it. Hormonal therapy is not so successful, but it has been recommended that may be helpful in patients who are having bilateral undescended testes, or if we want to differentiate a retractile testis from a undescended testes. This slide shows the paradigm shift in the management of undescended testes as far as age is concerned. Now, as I said, 6 to 12 months or 6 to 9 months is the preferred age. In 1950s, people are saying we should do orchidopexy at 10 to 15 years of age. Then in 70s, went to 5 to 6 years, and early 80s, 2 years, and then 1990s and 2000, 1 to 2 years, and now the current protocol is somewhere between 6 to 18 months. 18 months is extreme. People are saying before second birthday or first anniversary of the child, the test should be the scrotum. So why early surgery? As I said, thermal damage is minimized or decreased. Early histological changes. The changes in the testes which are not brought will start as early as 6 months of age, and by 2 years, 30% to 40% of the this spermatogenic potential of the testes may fall. Then, of course, then it reduces, as I said, complications of torsion trauma. This slide I took from the literature, it shows if we do an early orchidopexy, that 1 to 2 years, and late orchidopexy, the malignant risk is somewhere 0.5 to 0.7% in early orthodoxy, and it increases to 2 to 5%, 2 to 5 times relatively, and fertility potential 50%. You see, these figures are all favorable, suggesting that we should opt for an early orthodoxy. So what are the principles of orthodoxy? One is ensure adequate exposure of the cord and the testes. Architolysis, that is, the testes has to separate it from the cord, then we do a herniatomy, and then fix the testes. This is very important. Fix the testes. No tension on the cord, no twist on the cord. See, sometimes you do orthodoxy, the testes may be twisted, then you will potentially damage. And then, of course, testes should not be kept tightly into the subductal pose. It should breathe. That is, it is kept as loose as possible. Previously, people were telling we put it, fix it with a this absorbent suture. Then they came with a delayed absorbent suture. Now people are telling if you are putting a test in a nicely way, there is no need for even putting sutures. There are many procedures which may not, which may be required when the test is not conventionally brought down. So you have to lengthen the this cord vessels. There is no constraint as far as length of the vas difference is concerned. It is the vessels which are short. So these vessels have to be lengthened by any means. So these are the procedures. A retroperitoneal band has to be like this lead, this lysed right up to the upper lower pole of the kidney. Then you can do auto transplantation. Then you have to do what is called a Prentice maneuver. Prentice maneuver is you cut the inferior epigastric vessel, make a middleization of the and then bring down. And then there is multiple Prentice where you don't cut the vessels, you go below the vessel and bring the testes down. Then of course, my favorite is Fowler-Stephens orthodoxy, where you do testicular vessel ligation at least 5 centimeters from the hilum, because there is a triple loop or 4-loop system where testicular vessels, vas deferens vessels, trimestral vessels, and of course vessel from the gubernacle, they form a loop, a bigger loop. So if you cut higher, you will be having alternate circulation. This can be done. But I think this has gone into disrepute, and there is another procedure, especially for interabdominal, that's the heart procedure. This man is from Egypt. I was going through his details. He's from Egypt. It is a very novel method of doing it. So he brings the testes down, fixes it to the other anterior superior linesman, leaves it for 3 to 6 months, let the body movements and the pressure of the intestine increase the length of the vessels, and later on you bring it down. And I was in conference for pediatric surgery a few days back, and it was discussed which is the best procedure for doing this staged orthodoxy. Heart Fowler-Stephens is going down because there are complications. And these are the steps. First step, high volume crease incision. You open the this fascia, then you locate the testes, then you separate the testes from the hernial sac, and then you like it. I will be very happy when I will understand this if I find a patient hernia. Hernia acts as a puller. It goes on pulling the testes down, and you get a higher length of the cord as compared to the testes which is not having hernia. But remember, whenever there is hernia, what we can get is a vas looping. The vas difference will come down, and you can invariably sometimes cut the vas. So you have to be very sure and very careful that vas difference is not damaged. Then of course, as I said, this is how we fix the testes in the scrotal pose or subductal pose. Laparoscopic orthodoxy. I think the point which I want to highlight is when you go inside the abdomen, you want to fix the testes and you mobilize the testes. Testes should be brought easily to the opposite internal inguinal ring. Then and only then it will come down. Otherwise, it will not come down. So that is the end point. And these are the what is called as VIL or basal intact laparoscopy orthodoxy. What we are talking about. Fowler-Stephens, I told you. Then this degree is testicular. I just skip it. These are other this Fowler-Stephens single stage and double stage. Sometimes you fix the taxi there, don't cut it, leave it there, don't and after 6 months or 1 year you go when there is an adequate collateralization of assets and then you bring it down. So whenever there are bilateral on this taxis, as I said earlier, we should always think of associated syndromes or associated hormonal or genetic abnormality which should be needed to by proper investigations. What are the complications of arachidopexy? One is hematoma, wound infection, unsatisfactory position requiring revision, and then testicular torsion. Testicular torsion can happen during arachidopexy if we are not very careful. And then of course, inadequate arachidopexy. This is another one, the unsatisfactory of the same I think. And then testicular atrophy. It depends upon who are doing a single stage, double stage. Somewhere incidence may go to 7 to 20%, very high. Then up to injury to the vas deferens and ilioplantar nerve. What are the adjunct in the management of onset? One is retractile test. Normally, retractile testes don't need any surgery. But if the underside test is having a recurrent pain, that suggests torsion. Or if the size of the test is coming down, that means test is having some problem. Or if patient is adult and there are spermatogenic potential for, then this patient may also need a surgery. And redo arthroplasty, one of the very 5% to 10% of the patients in some studies require redo arthroplasty, and it is a nightmare for any surgeon because you are going to produce a lot of problems, testicular atrophy and damage to the cord. And testicular biopsy method should be taken. In children we don't take, but we take only when we see if there is any genetic abnormality, syndromic type of testicular onset, or if we are treating a bigger children or adult patients that you need because then maybe carcinoma in situ which require. And then of course when we do a laparoscopy for this abdominal testing and you find there are abnormal component which may be over tested or then then of course if there is a testicular ectopia in the adult patients. So how we go concisely about the management of. So if it is a palpable testing, no, nothing much you need to do an open arachidopexy. If there are abdominal, unilateral undescended testing, diagnostic laparoscopy. If it reaches up to the opposite guinal canal, the ring, then we do arachidopexy. If the short vessel, we can do a stage Stephen holder of cicadas. And if there are bilateral testes which are abdominal, then we have to evaluate for any this associated anomalies, or if there are suggestion of testing according to single ortho. Carry home message. I come to the last slide. Undescended testes are one of the commonest conditions in children by surgery. Etiology, diagnosis and management of undescended testes have undergone a sea change during the last 50 years. And early surgery, 6 to 80 months, I will put it as 1 year, is recommended to avoid complications, improved chance of fertility, and decrease risk of carcinoma in future. And PECs or fixed taxis in the scrotum also make it possible of early detection of malignancy by way of TSE or testicular self-examination, just we do in the breast self-examination. Arachidopexy is associated with complications including testicular atrophy, and as such should be done by experienced surgeons who are doing it as a routine, not as a casual operators. And bilateral undescended testes are often palpable, non-palpable, and may require investigation to prove disorders of sexual differentiation. Thank you very much. I think I stayed in time. Just a.
You are in time, but 2-3 things.
Okay.
I want to clear.
Okay.
Where you are putting testes? It is extradartus or in the scrotum?
Subdartus pouch. Subdartus. See, because this is the skin. Just the
muscle is important for.
Yeah. Subdartus.
For how long you will wait for retractile testes? See, people say 7 years is the
7 years is the limit. But I think any testes which is having a persistent pain, recurrent pain, and these testes are having a decreased size, that means this test is having some problem. So you have too early, but 7 years they put in. Because they say around, there are various series. One series by Prakash Agarwal has given a very high incidence that if after 7 years you leave these tractile testes, they may go up or they may have a suboptimal value. So 7 years they put, but you have to do at least their accounts.
Thank you.
We have the next speaker for this session, none other than Professor Vijay Kathua, Additional Department of Surgery at Government Medical College, Anantnag. Besides the medical department, he is one of the strong pillars of JAKASI and always busy organizing the outreach program and researching at all network and staff.
Thank you, Professor Ijaz, over the chairpersons, respected teachers, and dear friends. At the outset, I want to thank Professor Ravinder and his team for doing a wonderful job and giving us this opportunity to be part of this program. I bring greetings from my Institute Government Medical College, Anantnag. So, my topic is that how to preserve sphincter in patients of colorectal cancer. Thanks to the gadgets and the armamentarium we have right now available, laparoscopy, staplers, other things, it has been possible to go as low as possible and to do a surgery, a big mutilated surgery which was previously APR, and now we are most of the time is able to secure our sphincters and give a better quality of life to the patient. So what are the benefits? Benefits are that if you avoid sphincter removal, you are giving a physiological normal pathway and patient is getting a improvement in the quality of life. But there is a rider that sphincter should not be involved. Now what are various goals of treating rectal cancer management? As you know, there are few goals which we have to follow when we are doing laparoscopic surgery in a patient of C rectum. Goal number one is that previously it was said that there is a proximal and distal spread of the carcinoma rectum. But it has been seen now, the question is how much is the resection margin, proximal and distal. Whereas studies have shown that it is less than 2 to 2.9 and more than 3 centimeters distal resection towards the anal region. That is section that there is no difference in survival or local recurrence. So the this shed line is less than 2 centimeters proximally. Distally we can go for resection. But some experts also say that proximal margin should be at least 5 centimeters, distal margin of more than 2 centimeters and tumor less than 5 centimeters from anal verge. And even some people have gone down up to 1 centimeters and closed distal margin should be confirmed with, of course, with a Flogy section. Of course, you have to rule out a bulky disease of the rectum. The second goal is that concept came that it is not only longitudinal spread of malignancies of the rectum, it is the circumferential spread which is more important. So resection margins circumferentially were also taken care of. What concept came, a popular concept of total mesorectal excision, TME. Previously we used to do a blunt surgery and recurrence rate was very high, 14 to 30%, even if we give chemo to these patients. But with the advent of TME, it has come down to 4 to 7%. Because it has been seen that there are various satellite lesions in the TME, in the various nodes, so that has to be taken care of. So TME concept has really given wonders in this malignancy of the rectum, and local has come down to 3.6%, and even we get 86% survival after 9 years of follow-up. So other goals are that important thing is in C rectum is that nodal clearance is very important. If you are doing more than 12 nodes, you are doing a wonderful job with the patient. So another thing, God has kept various planes, various ways wherefrom the surgeon has to negotiate his instruments. So if you follow the holy plan of health, you will be able to do a better job and provide the recurrence. If the lateral lymph nodes are involved, of course you have to go for lateral pelvic lymphadenectomy also. But during this TME, you have to take care of sexual and bladder functions, various neurovascular bundles you have to save. And with advent of TME, it has gone down to 10%. Previously, it was 25 to 75% with the conventional APR surgery. Now, what is the level of assessment? How will you go for low rectal resection with sphincter? So you have to go for upper and middle rectal cancers. We can go for low or ultra low intersection. But very low, ultra low resection, what we call as, we can go for even intersphincteric resection if tuberorectal muscle is free. So people have gone at least 2 centimeters above anorectal ring in individualized patients. Now here is a question that we have to balance between oncological outcome and the quality of life. So this is a balance where you have to think whether we will give a good life to the patient or we will give a recurrence to him. The patient selection is very important. The criteria have been set that less than 10 centimeters from anal verge, no involvement of external sphincter or levator ani, and pre-operative assessment that sphincter is functioning very properly and there is no, of course, no metastasis. Then we know that everybody knows this GME that we have to go for mobilization of sigmoid descending colon, high ligation of inferior mesenteric artery, besides dissection of avascular planes. Then we go for ultra low rectal resection using laparoscopic staples and coloanastomosis, hand seals are stapled, and then you go for protective ileostomy also. So operative time is 3 to 4 hours, but loss is less, and conventionally it's only 5 to 7 days hospital stay, which is better than APR, the total surgeries. RO0 resection is achieved in 95% patients. Adequate distant cerebral margins, lymph node yield is more than 12 nodes, and local recurrence is less than 5 at 2 years of follow-up. The functional outcomes are that sphincter is preserved in more than 90% of patients. Temporary ileostomy is reversed after 8 to 12 weeks. Preoperative continence good to excellent in majority of the post-operative continence is good in majority of the patients, and there is low incidence of anastomotic leak and pelvic sepsis in patients of ultrasound. So here I want to present one. We have a humble experience of doing few patients, also not for the paper or some statistics, so I have not made any tables. So this is a humble beginning in our college. This was a patient, index case, 31-year female with 2 children. She had a bleeding PR and myalgias. We evaluated her. She had a BMI of 19, aesthetic, pallor, emaciated. DRE showed a circumferential growth 6 centimeters from anal verge. Colonoscopy was showing there was no other lesion except this, and biopsy showed moderately different adenocarcinoma. We did CCT of the patient that showed circumferentially enhanced wall thickening, rectum starting 7 centimeters from anal verge and extending superiorly to 6 centimeters after the level of sigmoid takeoff, with multiple mesorectal nodes and thickened mesorectal fascia and mild ascites and nervosity. So we also did contrast analysis MRI in this patient, and we could see that growth was 7 centimeters from anal verge, length was 4.2 centimeters, tumor thickness was 9.5 mm, it was 5 mesorectal nodes were involved in this patient, and sphincter complex anorectal junction was free of the growth. So investigation showed anemia and hypoanemia. Ultrasound was showing mild ascites, HS, ECG were normal. So we did a pre-operative optimization of the patient, and patient was subjected to lab ultra low anterior resection with covering ileostomy. Could you please? So you know that patient surgery of 3.5 hours in 6 minutes is very difficult. We might have missed many steps. So what we did is that we first did a diagnostic lapro, then we conventionally start from the inferior mesenteric artery pedicle, artery and vein. So we dissect them and we follow the dissection of the mesosigmoid and then identify the vein and the artery. It's very important that we have, this is a landmark where from we have to start, and then we go distal and proximal dissection. First of all, we do the vein. We have a harmonic case advanced, so we don't need a other side which is to be dissected. So for the artery, of course, you have to put Phillips on the both sides, you are seeing the Phillips. The important thing is that we have to start high elongation of the pedicle, inferior mesenteric pedicle. This video is brief because most of the time we first to go distally, do a good amount of dissection of the mesosigmoid and mesodescending colon, and then we go for the ligation of the pedicle. This is the right side dissection of the peritoneal reflection, and we have to look for very important that here I have not given full video. Important is that on the landmark sacral promontory you have to leave some pre-sacral fascia, and you have a proper plane where from you have to go to provide to see. And another thing I have avoided here, we have also you have to visualize various retropetal structures like ureter and the gonadal vessels that is to be taken care of. You have to visualize them and then continue your dissection right down into the pelvic cavity. It's a very narrow cavity, and because of the gadgets and laparoscopy we have been able to go down as soon as. So you can see various lymph nodes with the pedicle. Those all nodes are to be taken with the tumor. You can see the baby buttock appearance. Very important. You have to demonstrate it. You have to go as low as possible up to the levator ani muscles and see the baby buttock appearance so that I can little bit go faster in this. So you have to dissect the peritoneum on all sides and then take all mesorectum with the rectum. Important thing is that lovers and wire you have to go for anastomosis, stapling. You have to dissect the mesoperitoneum up and make it visible that. See here it's very important that you have to go and do a per rectal examination to see whether you have not punctured rectum anywhere. I'm not able to demonstrate it. So after confirming it and taking care of all mesorectum, making it nude, and then you have to go for proximal dissection because you have to mobilize the colon down up to the splenic flexure. So we will go for mobilization of the sigmoid colon up to the splenic. These are the holy planes which are very clear, why from your surgeon has to negotiate. And see the spleen. As you see the spleen and get the splenic flexure down, you will be able to do a better anastomosis without any tension. So this is the rectum where you are doing PR and see there is contingency of this, and then after that we confirm it, we go for endo-GI stapler and do stapling. After doing stapling, we go for circular stapler. We take the growth out and remove the growth, and then you have to align the segment, make it tension free, and then put the angle inside this and put it back, and then use a circular stapler to do the anastomosis. So after doing anastomosis, you have to check any leaks, putting some normal saline, and then check the donuts proximal distal for any malignancy. Go to slides. 1 minute, please. Give me 1 minute. So this is the image which is after the surgery, and this is ileostomy and post-operative picture. This is the histopathology report which has shown it was a AJCC stage 3B. 5 nodes were positive out of 13 nodes which were retrieved in this patient. And this is my operative team. And we know that comparison in APR that we have sphincter preservation, quality of life improves, hospital stay improves, oncological safety still we are not sure whether we are getting better results. And technical challenges are their complexity of narrow pelvis, recessive and stomatic leak, need of skilled laparoscopic surgeon, importance of preoperative imaging and planning is very important in these patients. To conclude is that ultra-large is a safe and effective sphincter saving option for colorectal cancers, offers excellent oncological and functional outcomes, requires expertise in laparoscopic colorectal surgery, long-term follow-up essential for functional and oncological surveillance of these patients. Thank you very much.
Thank you, Dr. Sanjeev, for a comprehensive talk on colorectal cancers. Because of time, we won't have any questions, but if anybody has doubts, you can discuss with Dr. Sanjeev in the lunch break. So, our next topic will be by Professor Sanjay Kumar Basin. He is an ex-chairman of JAKASI, the Department of Health So, the topic is antibiotics and antimicrobial resistance. Are we heading towards a disaster?
I'm sure I'm going to make all of you afraid after my presentation. So choosing a topic for such discussions is very difficult, and invariably, though I am not a big surgeon, I have a rich experience of so many surgeries, but I choose the topics away from the mainstream topics. Esteemed chairpersons, galaxy of surgeons, dozens of surgery in front of me, my students, what we have observed is that in recent years, extensive use of antibiotics, more so antibiotics, they have become public health problems worldwide, leading to multi-drug resistance with adverse medical and socio-economic outcomes, creating space for further research. This was the compelling reason to dwell on this subject. I am Dr. Sanjay Basin, many knows me, and my topic is antibiotic and antimicrobial resistance. Are we heading towards a disaster? Historically speaking, world population relied upon as antibiotics on curd, various oils, salts, and even soil to kill the microbials. In just 100 years, antibiotics, they have drastically changed the modern medicine, including the surgical domains, outcome of your big and small surgeries. And they have extended the average human lifespan by 23 years. 19th century saw conceptualization of antibiotics, and we must every day we must bow our heads to Louis Pasteur and Robert Koch, who were the pioneer in developing antibiotic phenomenon. 1910 was the discovery of first antibiotic for syphilis. 1928, Alexander Fleming discovered penicillin, a wonder drug. And 1930, another antibiotic was commercially made available. 1940, another story of
Antimicrobials, 1945, a large scale availability of penicillins. And 1940 to 1960 was the golden era for antibiotics. Whatever 4 or 5 subgroups of antibiotics we are seeing today, we are relying upon today, they were all creation between these 20 years. And this is the house where the discovery of first antibiotic was done. And it reads, this plaque commemorates the discovery in the room of penicillin by Sir Alexander Fleming in September 1928 to the glory of God and immeasurable benefit to the mankind. These are the 4 groups. I need not to go into details. DNA synthesis inhibitors, proton synthesis inhibitors, DNA synthesis inhibitors, folate metabolism inhibitors, and RNA synthesis inhibitors. Antibiotic is the second commonest prescribed drug world over. But there is a problem. Medicines are nothing in themselves if not properly used, but the very hand of God, if implied with reason and prudence. And this is a fact check. 50% of the antibiotics, they are used inappropriately. Mind it. After 10 years, you are going to have a doomsday. Majority of the acute diarrhea, upper respiratory catarrh, bronchitis and so on, they don't need any antibiotics per se at first instance. Even people are using, unfortunately, the antibiotics for upper GI bleed and seizure disorders. I don't know why. And this is not a joke. It is on record. It is on record. Antibiotics don't treat the patients, they treat infections. Mind it. And WHO defines rational use of antibiotics. And for rational use of antibiotics, there should be appropriate patient, there should be appropriate indication, there should be appropriate doses, there should be appropriate administration, appropriate combination, and must consider the socio-economic status of the patient, that is affordability. Reasons for irrational use of antibiotics is lack of information, what danger they possess, especially towards countryside where quacks, they are more in number than the qualified doctors. Lack of diagnostic facilities, patient loads, promotional activities. This is under scanner. Hazards of irrational use of antibiotics. Ineffective and unsafe treatment. Number 1, over-treatment of mild illnesses, inadequate treatment of serious illnesses. Increased drug resistance, exacerbation or prolongation of the illness. And there are so many things. And masking of the infection. You just see on this slide. There are some patients whom we cannot help, but there are none we cannot harm. This is what the irrational use of antibiotics is doing today. End result of all hanky-panky business is antimicrobial resistance. And we must be afraid of this. Superbugs, they are in plenty today. And they are going towards creating a resistance, individual resistance and the community resistance. It's a global threat, and it is recorded that by 2050, Asia will be having 4.7 million deaths by AMR. 4.7 million deaths by antimicrobial resistance. Almost 10 million per year world over. What they will do, increased morbidity, prolonged hospitalization, therapeutic failures, and huge burden on the economy. This is the national impact. India accounts for almost 1/3 of the global burden of MDR TB. 2.5 million cases of tuberculosis with 27% cases with drug resistance. A study in 2018 across major Indian hospitals found that over 50% of the bloodstreams infections in critically ill patients were due to antibiotic resistance pathogens. They are all alarming figures and we must be afraid of them. Misuse of drugs other than antibiotics, analgesic and corticosteroids, they are going to harm persons themselves, individual harms, but misuse of antibiotics is going to harm the whole community, including your near and dear ones. So before prescribing antibiotic, please think of your dear and dear ones. This is what is happening and how the vicious circle is going on. There is a need for antibiotic, there is discovery, there is misuse, there is resistance, there is ineffectivity of the antibiotic, and again a new search for the antibiotics. The research is forced and willing. If you stop using antibiotics rationally, irrationally, it will be a better thing. Alarming bells. Just one. Fourth generation fluoroquinolines. We are in the stage of developing fourth generation fluoroquinolines. We are in the stage of developing further higher generation of cephalosporins because 3 have already failed or having resistance. And then aminoglycoside was one drug which was considered to be free from resistance. But we are in the stage of developing a new aminoglycoside, and so is the case with tuberculosis. अब ये कहानी देखिए, आपके पास रह क्या गया है? मैंने कहा था ना कि you will be afraid. The current assessment of pipeline shows 43 new antibiotics in development, amongst them 15 in stage 1, phase 1 of the clinical trials, 13 in phase 2 of the clinical trials, and another 13 in phase 3 of the clinical trials. At least 19 of the antibiotics in clinical development have the potential to treat infections caused by AMRs. WHO 2020 report says that newly approved antibiotics are not enough to mitigate the emergence and spread of AMR. Just see where we are going. There is limited number of antibiotics approved by the US FDA as well as the Europeans. Remedies, challenges are there. We have to face them. They are difficult but not impossible. Challenges of cultural practices, challenges of healthcare system gaps, challenges of lack of uniformity in implementation of antibiotic policy, and resistance to change. This is our mentality, resistance to change. Only ways: rational use of antibiotics, say no to antibiotics in viral conditions, know your bug before prescribing the antibiotic, culture sensitivity must be there, avoid frequent switch over of antibiotics. 2 दिन 3 दिन दी, वहां से बुखार नहीं आता है, 2 दिन के बाद दूसरी दिन. Wait for some time. Reserved antibiotic should be used reservedly, judiciously. There should be hospital antibiotic policy, audits, biograms, SOPs, and other things. This is one thing which is very important. Counsel for appropriate and rational antibiotic therapy, very important. Just go through antibiotic stewardship programs. Number 1, hospital antibiotic policy. Number 2, all these things are available. What I want to emphasize is that there is a regulatory, but it is not being implemented. It is Schedule HX drugs. 90 antibiotics put in under DCGI. Part A only for use in tertiary hospitals. Part B against prescriptions. Yes, 16 antibiotics under A, 74 under B. They are categorized as non-restricted, restricted and very restricted. Violators 20,000 and 2 years imprisonment. ये देख लीजिए, लेकिन पॉलिसी का क्या होगा? सर ये वाली जरा स्लाइड आप देखिए क्या है इसमें, देखिए क्या है ये थ्रू आउट वर्ल्ड और कंट्री क्या हो रहा है, रूल्स बनते हैं वो वायलेट होने के लिए बनते हैं और पॉलिसी मेकर पहले वायलेट करता है। सो मुझे ये जो एक कोटेशन याद आ गई, I would much rather see responsibilities exercised by the individuals rather than have them imposed by the government. And I would love to be the first one to say this, but it automatically turns into we all have those responsibilities that we ignore because we don't feel like they are ours. And we will be having nothing when we need them in the time of need. Antibiotics, will they work when you really need them? मैं एक ही बात कह सकता हूँ. Let us join hands together and take the challenges. And दुआएं दे सकता हूँ.
Yes.
देखिएगा. Thank you very much.
We should be very careful. So we go on to the next topic. Next topic is by Dr. A.K. Gupta, Medical Director The topic is 30 years of experience of foreign surgery. Dr. Gupta.
Good afternoon, everybody. It's a matter of great pride, pleasure, and privilege for me to be here amongst you today. And credit goes to the organizers of this conference, Dr. Ravinder Kumar, Dr. Anshuman, Dr. Junaid, Dr. Ankush, and all the residents of surgery department in Kathua. After having completed 30 years of my practice in Kathua, I feel proud today because all the stalwarts of surgery, HODs, all the big shots of surgical fraternity of JNK are here with us today. It's a matter of great satisfaction, great pride for me and all of us. My topic is my 30 years journey in Kathua. My topic is not about the techniques today, all of you know. Rather, I have forgotten the techniques also, academics also, because I have been out of touch of academics for so long. My senior colleagues, Dr. Charangu, Dr. Dingra, and so many others are here. I'll discuss about the lessons learned, my mistakes, and what I have come to believe after 30 years of my surgery in Kathua. Let's go ahead. After having completed my MS from Government Medical College, Aurangabad, in 1991, I moved to Breach Candy Hospital, Mumbai. There I had the privilege to work with Dr. Chanchan Udwadia and Dr. V.N. Shiripande. During my training under Dr. Chanchan Udwadia, this was the early era of laparoscopic surgery, lap coolies. He was a pioneer of laparoscopic surgery in India. I was working with him. So he always used to say, people may call me a coward surgeon, but I am a safe surgeon. He always used to say, always put a drain in lap chole, whether open or laparoscopic. He used to say, every surgeon knows when to operate, but a wise surgeon is one who knows when not to operate. And these lines remained with me during my career. When I was working under Dr. Shrikande, he was the domain of hepatobiliary surgery at that time in Mumbai. He used to say, I might do half cholecystectomy, I might do 3/4 of cholecystectomy, but I'll never injure the common bile duct. So these philosophies shaped the foundation of my practice in Kathua. I always remember these lines. Next slide, please. So in 1995, when I started my career in Kathua, it was a very formative center. We had very limited resources at that time. The first surgery, I started my career in Kathua in September, 25th of September 1995. And first surgery was my gallbladder surgery. It was 3rd of October 1995 when I performed first open surgery in Kathua. I'll just tell you a story. I did not have the boil separators, not much of the equipments. We had EMO. There was no anesthetist at Kathua at that time. This was first cholecystectomy to be performed in Kathua. I called Dr. Vijay Mahajan from Pathankot. He gave anesthesia, and I was surprised. He gave spinal anesthesia, and we did this under spinal anesthesia. It was a big challenge for me, and successfully we completed first case on that day. The moment we came out of the OT. So this is a very interesting story. When I came out of the OT, our adjoining chemist, Mr. Vishal, I still remember the story. He came. उसने क्या किया है, एक लड़के को 18 साल के लड़के को उठाया, अपने कंधे पे रखा और वो लेके आया. बोला डॉक्टर साहब मैंने इसको डोलोनेक्स इंजेक्शन दिया है एंड ये बेहोश हो गया. हम ओटी से बाहर निकले थे और टीम हमने उसको लेटाया. He was pulseless, he was unconscious. Immediately we gave him subcutaneous adrenaline and I did venesection. So it was I would say it was a turning point of my career in Kathua, and that patient survived. He had an anaphylaxis, and this is how my journey started in Kathua. This person who had this anaphylaxis is Mr. Sunil Kumar. Day before yesterday, we discharged him again. Now he is about 50 years old now. He was studying at 12th. He had hernia. We operated him few days back and he was discharged day before yesterday. So I felt so proud of it. And this is how my journey started in Kathua. And people of Kathua have blessed me, patients have blessed me. I am thankful to all of you. Then we extended ourselves to be shifted to Kalibadi Kathua. And now, by the grace of God, we have a full-fledged, multi-specialty, 180-bedded hospital with all the facilities. Thanks to all. It was a big challenge for me during these early times. In the first month,
you are audible.
In the first month, we did 5 surgeries, 5 cholecystectomies in the month of October. In the next month, we did 16 lap choles, open cholecystectomies. We kept on doing. In March 1996, we did 99 cholecystectomies. So I never thought I'll be able to do so many cases, but the grace of God, by the affection and love people gave to me, and by the blessings of my teachers and of you, I could do a lot of open cholecystectomies, but there was a passion in my mind to go for lap pull. At that time, we did not have the equipments. We shifted to JMC Kathua in 2002.
We are hearing everything.
In 2002, when we shifted, we got the equipment and we started doing lab. So it was a big passion in my mind because I was trained by under Dr. Udwadia and Dr. Shrikande in Mumbai. I started my lab and by now, by the grace of God, by the grace of everybody, I have completed more than 30,000 lab colleagues. It seems unbelievable, but I did not know how could I do it. Now, I'll tell you the lessons which I learned, mistakes which I made. Next slide, please. There are certain lessons which I have learned over a period of these 3 decades. Nowadays, people say it is a daycare surgery. I always remember Dr. Udwadia's words. Never take anything lightly. Every surgery is a major surgery. I have undergone a lot of challenges during these years. So I would say, when you talk of daycare surgery, never take it lightly. Few days back, a 35 years patient came to me. She was having a single solitary calculus in gallbladder. It was a fit case for surgery. Medically, she was fit. All the investigations were normal. Her husband told me, Dr. Saab, I want to get the surgery done tomorrow morning. I want to go home back tomorrow evening because I have to go to Mumbai. I have got my flight booked. So it was $1 million question for me, what to do. I did not agree. I said no, I will not do. Though it's a very simple case. Whenever I operate, Dr. Udwadia's words, hammer my brain again and again. And never take it lightly. It is quite possible that she could have been discharged the same day, but it's a routine. We have made a protocol. We operate today, we keep the patient for a day and discharge it the day after tomorrow. So this is a routine. Never, whether it is a simple case or not, always keep observation for 24 hours minimum. And another thing, in all cases of gallbladder, I always put the drain, whether it is a simple case or complicated case, open or laparoscopic. Always put a drain. This is my opinion. Next. Now, next point, after 30 years of my journey with gallbladder surgery, now you have to choose a right patient. That means, I've done many cases in acute attack also, but I have committed some mistakes. We have to learn from those mistakes also. Never ever operate a case in acute attack. This is my personal opinion. For all practical purposes, I would suggest, let us not do surgery in acute attack. You may be in trouble. People say, do it after 6 weeks. But I believe, I never do lap poly after 8 weeks. It takes minimum 2 weeks, 2 months. Let's delay for some time. If you do it during an acute attack, you can come across many problems, many stupidity. You may have to open and close. You may have to do partial or subtotal cholecystectomy. You may have to face biliary fistulas, postoperative collections, residual gallbladder stones, duodenal or colonic injuries. All these complications I have gone through, I have seen. To quote a few, next. Recently, a case was posted for surgery. Within last 2 months only, gallbladder ultrasound revealed normal gallbladder. Though she had a pain, I saw her on the table. It was missed rather. Somehow I missed acute attack. I put the scope. It was plastered at all. I started doing dissection, but it was not possible, and it was converted to open. When I opened it, it was such a bad case, gangrenous gallbladder, and we did open cholecystectomy, but there was a colonic injury as well. Colon was opened. Hepatic fracture of colon was, there was iatrogenic injury rather. So we repaired it. Since she was diabetic, we thought this is not the perfect treatment. I did defunctional ileostomy. And why I am quoting this example is, you should not take any case lightly. Now she is under ileostomy, now she is absolutely fine. Had I not gone for defunctioning ileostomy, she would have landed in septicemia. Quite possible. This was a troublesome course for the patient, though, but life is more important. So again and again, I always recommend that we should not do surgery in acute cholecystitis, though it is described in the literature, but in my personal opinion, surgery in acute attack of gallbladder stones should never ever be done. Then next case please. We have seen, I'll take few, I'll just close it. We have seen videomas, I have seen residual stones, we have seen residual gallbladders many a time, sometimes, because these were the mistakes which I might have done during acute attack. We could not complete the cholecystectomy, we had done incomplete cholecystectomies, residual gallbladders, residual stones, and in one case, I still remember there was a lateral injury to the CBD. During my career, I had thermal injury. Patient developed fistula. She remained on the drain for 3 weeks. We had undergone the ERCP. She was all right. Next. Again, techniques and safety. 4 ports standard technique is the best technique. I have tried 3 ports, but I would suggest 4 ports is the standard technique which should always be used. You should be liberal in taking the ports. Next. Now, most important thing which I had to face the problems, battle with port infections. Yes, it is a big problem. Initially, we used to sterilize the equipments with Sidex, glutathione, and some of the cases, say 10%, 5 to 10% of the patients, they developed port infections. And sometimes these infections, they came in crops and they never responded to any antibiotics. They never responded to any treatment. And we had to use ATT. And they responded to ATT, and that too. ATT was given for a prolonged period of time. So after that, we switched to autoclave. We started doing autoclaving the tripods and trays, and hand instruments, these leads, 40 leads, and all these cables, they were sterilized by ETO. Now we are sterilizing them by ETOs. I'll take a few minutes, I'll just close. So after having done autoclaving, starting this funda of autoclaving and ETO sterilization, we are not getting port infections. So this is a big lesson for us. Next. Again, as Dr. Rwani used to say, people might call me a coward surgeon, but I am a safe surgeon. You should be very careful during dissection, callus triangle. Next, during dissection, in callus triangle, 3 things I always remember. See the hathi ki soont. This is first thing. I always complete the cholecystectomy. I never complete hathi ki soont at the junction of cystic duct and gallbladder. and always maintain a wide angle between cystic duct and proper hepatic duct. These are the two issues. And third thing, I always do bipolar cautery of the cystic artery. Somehow it helps, it works. And always I put the drain. These are the only issues. This is the only golden tips for having good results. And during clinical judgment and decision making, you should always take the opinion of your seniors, your juniors, your colleagues, and sometimes I always take the opinion of my OT assistants also. In many cases, they help me. Next. Again, I would emphasize on the point, every surgeon knows when to operate, but the wise surgeon is one who knows when not to operate. From these 30 years of data, I would say these numbers, they are nothing. Next slide. It is only the next slide. It is only, next please, this is all. I'll say true satisfaction doesn't come from how fast you finished or how many cases you have done. I would say, I strongly believe it comes from doing it safely with compassion and seeing a patient go home with smile. Thank you very much. Thank you.
Thank you. Now we close this session.
Now, we would like to thank all our distinguished speakers for those remarkable presentations, each one offering a unique perspective and a wealth of experience.
With heartfelt gratitude, we now move on to felicitate our esteemed guest speakers. Whose insightful talks have truly enriched this scientific session. May we kindly invite our respected chairpersons to do the honors of felicitating us.
We begin with Professor and Dr. N.C. Digra for an engaging and thought-provoking presentation that set the tone for the session.
Yes, please. Sir, please, yes. What a provoking presentation. Thank you. Provoking? Provoking. Sorry, thought-provoking. Yeah.
Next, we felicitate Professor and Dr. Nazir Ahmed Wani, whose clinical depth and clarity made the topic both enlightening and practical.
Wait, yes, please. Hold, karo. Sir, please. Sir, yes.
We now felicitate Professor and Dr. Sanjay Kumar Bhasin for his excellent contribution and insightful discussion.
Yes, please. Yes.
And finally, we felicitate Dr. A.K. Gupta for an outstanding talk that added immense value to today's practice.
Yes, please. Yes.
Next, we would like to felicitate our respected chairpersons for this session. May we request Professor and Dr. Suleiman Chaudhary, senior surgeon and former principal, to kindly do the honors of felicitating all our chairpersons.
We first invite Professor and Dr. B.S. Pathania to kindly accept our token of gratitude.
Yes, please. Yes.
Next, we request Professor and Dr. Nisar Chaudhary to the stage to receive his award.
Yes, yes.
We now invite Professor and Dr. K.S. Mehta for felicitation.
Wait. Sir, please, yes.
And finally, we invite Professor and Dr. Ejaz Ahmed Rathar to please accept our token of gratitude.
Wait, sir, please. Okay.
Thank you, Dr. Suleiman sir, and our esteemed persons for gracing this session with a guided presence.
लंच के लिए बोल रहे थे नाउ वी ब्रेक फॉर लंच
30 minutes.
30 minutes वही
Now we bring this academic segment to a close. It's time to unwind and continue our conversation over lunch. We invite you all to join us for lunch, which has been arranged at the venue garden.
I'm going to speak on laparoscopic polyplasty. It's a video presentation. Laparoscopic polyplasty for PH obstruction. PH obstruction results in dilatation of renal pelvis, major and then minor calyces, which results in loss of renal parenchyma and renal loss, functional renal loss. There are many causes of PH obstruction, most common being the congenital aperistaltic segment of the ureter and apparent low pole crossing vessel will press upon the PH and can lead to obstruction. This is the most common first investigation used. It showed dilatation of pelvis, pelvis, calyces, and then the hydronephrosis. IVP provides anatomic and functional details. The typical box-shaped pelvis is seen in on IVP in case of PH obstruction. More contrast studies can be performed like CT urography, MR urography, and then to diagnose, to document the renal function, it's the dynamic renal scintigraphy. This is showing the dilatation of renal pelvis and calyces with abrupt narrowing at the level of PVG. Again, MR urography showing the same thing, and there is crossing lower pole vessel on the left side on the angiography below. These are the indications for surgery in case of PH obstruction. Presence of symptoms associated with the obstruction. When split renal function is less than 40%, if there are stones, secondary stones, there is infection, and very rarely if it causes causal hypertension. These are the options for treatment. Endourological options include mostly the endopilotomy, which can be done in antegrade manner or retrograde. Then these are the conventional surgical procedures, most common being the dismembered polyplasty and Hines. Then various flap procedures for certain indications and various salvage procedures, and at last nephrectomy in case of non-functioning kidney with a contralateral normally functioning kidney. This patient was 40 years old, male. He presented with a history of pain in left flank. All during investigations they were normal. USG abdomen showed grade 2 hydronephrosis with presence of multiple calculi in inferior calyx. This is the IGP showing the same thing, which with delayed excretion of contrast from the pelvis into the bladder. CT urography was done, which showed the dilatation of pelvis, calyces, and then the narrowing at the level of PJ and delayed excretion of contrast. Renal angiography, there was a apparent lower pole crossing vessel. Dynamic renal scintigraphy with a DTP scan was done, which showed left kidney was hydronephrotic, it was obstructed, and left kidney function was 48%. Could you please? So left-sided laparoscopic polyplasty was performed. Colon was mobilized medially. The upper ureter was identified. It was dissected. This was a fatty patient. Lot of fat was there. So the fat overlying the renal pelvis was excised. This was the lower pole crossing vessel, which was compressing upon the PUJ. All fat was removed so as to expose the renal pelvis completely. The lower pole of kidney was mobilized. There was a vessel which was entering directly into the inferiormost part of kidney. This vessel was preserved. The remaining fat was excised over the renal pelvis. You can see the dilated extra renal pelvis was there. This was the crossing vessel which was compressing upon the PUJ in this case. Now the assessment is being done for division of the renal pelvis. It is being divided. Stagnant urine came out, which was sectioned out. Pelvis was completely dismembered in view of this external pelvis and the apparent crossing vessel. After division of pelvis, the ureter was brought behind this crossing vessel. Secondary stones were present. One large stone was present in the renal pelvis, which was extending into the calyx. It was removed. There were two more stones which could not be retrieved from the pelvis, so they were removed by opening the inferior calyx because of calyctasis. Thorough normal cell irrigation was performed in order to remove all the concretions from pelvis side and from this calyxial side. Then this inferior calyx was closed with vital suture in a watertight fashion so as to prevent any urinary extravasation in the post-operative period. being applied to close the divided pelvis, this is calyx, inferior calyx. This is the divided pelvis. This is the divided ureter, which is adequately mobilized. Then the ureter was speculated on the lateral aspect in a single go, like cutting the cloth by the scissor to prevent the formation of ragged edges, otherwise irregular edges will form. Now the anastomosis is started. The first divide was taken near the apex. So apex suture should not be taken exactly from the apex, it should be from adjacent to the apex, otherwise it can lead to stricture and secondary vein obstruction later on. Anastomosis was performed by vital 3-0. You can see there was no tension on the anastomosis. Both structures they were lying closely. Suture was continued then as a posterior anastomosis between divided renal pelvis and the spatulatory ureter. It was passed behind, and outside in suture was taken. It was passed in this fashion from the renal pelvis side and inside out from the ureteric side. It's very important to take the full thickness suture from both ureteric and renal pelvic side. Anastomosis has to be tension free, watertight, and independent drainage should be there. Funnel shaped drainage should be there to prevent any cases of urine. The posterior layer of anastomosis being done is almost complete. Last suture will be there. The posterior layer. The loose irregularity present over the renal pelvis and upper ureter should be kept intact. It should not be completely scrutinized because there are certain small vessels in this layer which can help, which will definitely help in the healing of this anastomosis in the post-operative period. The Walters layer over the ureter it should be preserved. The posterior layer of anastomosis is almost complete. A separate suture will be taken to start with the anterior layer of anastomosis. This is the completed posterior layer. The vessel has gone posterior to the anastomosis. Then ureteric stenting was performed in an anterior manner. Ureteric catheter was introduced with a soft and interrupted by this guide wire to pass into the urinary bladder. Ureteric catheter should be used, otherwise soft end of the guide wire can curve in the distal ureter and stent will remain in the ureter itself. When the ureteric catheter was removed, the guide wire was a bit advanced further into the urinary bladder. Then the ureteric stent was passed over this guide wire. It was pushed from outside by assistant using a pusher. It is being pushed into the urinary bladder from the ureter. Guide wire is being removed. The upper end of stent was kept in the pelvis. Preferably, it should be kept in the inferior calyx so that it should not come out. Now the anterior anastomosis is started from above onwards. We can start from below upwards. The narrow portion of PJ was excised. The classical Anderson-Hines dismembered pyeloplasty, it gives opportunity to excise the redundant pelvis. It gives opportunity to excise the narrow pelvic junction, and it gives opportunity to transpose the new anastomosis in relation to the vessel. As in this case, the anastomosis is in front of the vessel. It's very important to take suture under vision. The needle should not incorporate the PJ stent. Anastomosis can be done in continuous fashion or interrupted fashion. Interrupted sutures, obviously, they take longer time. So this is the almost complete anterior anastomosis leg is complete. Both the needles were removed under vision. Stones were removed, and the excess segment of PUG was also removed. Port was advanced inside so that if any stone fragment falls, it should fall in the red region so that it can be later on picked up to prevent any septic complications. Normal saline irrigation was performed and hemostasis was checked. Vessel has gone posterior, anastomosis is complete, and now the gauze was removed and the drain was placed near the anastomosis site. Just one slide. This is the post-operative picture. These are the port sites. Thank you very much for your patience.
I would suggest two things. What I could observe from your video. One is that you were a little miser in cutting the peduncle pelvis. So that's one I could find. Because you have to create a new relative junction has to work exactly like a funnel. One. Second is my feeling. Second is that when you are taking the posterior layer, you are taking a continuous.
Yes, continuous.
All knots are going in. If you follow out intact, I know it is difficult to put knots in the posterior layer out. But if you follow out intact, then they will always go together. It's exactly like FJVD, as surgery. I would suggest you start out intact in the posterior. But I could imagine what you see for all knots are placed inside.
So it was a continuous layer. The first was outside, and the last one in the posterior layer, the last knot that was inside.
That's what I saw. The knot light in.
Other knots were there when they were outside.
And you were doing it transabdominal or retrograde?
Transperitoneal.
Why did you go doing it transabdominal?
So in initial case, I started beginning with the transperitoneal.
Do you have any further questions? Thank you.
Thank you, sir.
This is a passionate surgeon. That's honestly telling he's doing a good work. He was associated with us as registrar. I have observed him. He's doing excellent work. Listen. So you want to tell us what tabs in?
Thank you, sir. You might be wondering why I'm here. Actually, I had sent 2 abstracts. They were gracious enough to accept both of them. That's why I'm here again with you. Please bear me for another 10 minutes. So, this is my presentation, blisters and traps, basically showing snippets scenarios of the appendicitis. So, acute appendicitis is a common abdominal emergency, accounts for about 1% of all hospital admissions. It remains the most commonly performed emergency general surgery. Post-operative mortality is about 5 to 8% due to wound infections and delayed diagnosis of perforation. I will not talk about the advantages of laparoscopy or open appendectomy. We all know it, that major being it allows thorough exploration of the peritoneal cavity and prevents negative appendectomy. Port placement is variable, all depends. I'll be sharing a few videos, one picture. Plus.
But you will get only one movement.
Yeah. You can give me half, sir. So, this is the classical one where you just go in, you'll just go in and inspect the peritoneal cavity, find the appendix, localize it, go to the visual appendix, find the appendicular artery. You may clip it, you may use an harmonic to just correlate, as being done here. Then release the adhesions on the lateral abdominal wall if there are any adhesions. And finally, it's commonly available pre-tied loops, which is the Catholic loop, which is doubly ligating the base of it, which we all do, I'm sure. And this we can put a clip and divide the appendix. This is the classical one which we do on routine basis. You can remote it in a second. The second. This is to percolate. Then there could be a scenario where the appendix could be retroilial in position, as is seen over here. I have run the video in 2x so that you are not bored. This you can see a very tense and turgid appendix, which is retroilial in position. More difficult to manipulate with two instruments. Once I experience a situation like this, instead of putting a third port, I do what you will be seeing. I introduce a port closure needle, usually taken from a port, to hold the distal tip of the appendix, as been done here. And rest of the steps go like three. This is another situation where the appendix is paracecal in position. Here the fear is to injure the cecum. So what you do, you remain close to the surface of the appendix rather than being close to the cecum. Use your instruments meticulously, use the suction to lift it, ensure there is no stresses. No special instruments, no routine ones. Here statement, just to stay away from the cecum. And try to look like the body and the tip of the appendix. Finally, you get the tip of the appendix and the rest of the steps for the procedure. So, now see the situation, there was a young girl where appendicitis was diagnosed radiologically, but once we went in, you can see a sort of a structure over there. It looks like an appendix. Once you just dissect it and lift it, you'll see it will exactly look like an appendix. What is actually a gangrenous anatomy? This was the situation. Okay, then there are situations where you may find a mucocele of the appendix. Yeah. Most of the surgeons over here would agree that you may like to do it open because the fear in the mucocele of appendix is that splage. You want to avoid the splage because it contains mucin and it may lead to pseudomyxoma peritoni and if there is a minor leak from this appendix. But if you have the right instruments in your hand, like the harmonic, you can achieve a good control of the visual appendix. Can achieve a good manipulation, then laparoscopy is not a contraindication. You can just go ahead with this as being done here, but one has to ensure zero splage. And how was it ensured in this case? It was ensured by applying a stick. I will make sure this is always in the lab. 6. One more situation where you went in with a diagnosis of appendicitis, but you find that it was a sort of a lump. Ideally, the situation here would be to just allow structural regime, brings it back, no longer setting, but with some meticulous dissection, we were able to achieve without harming the patient. Again, if we have a right instrument in your hand, you just do in a retrograde manner. It's a retrograde appendectomy, where the cecum is being separated, momentum is being separated. This partial lump is not a complete lump actually. This is a near lump. Separated and go in a retrograde manner, meticulously bit by bit, ensuring that there is no damage in the structures. It takes time, and one was able to retrieve. Last one. Now, at times you can come in a situation like this. You go in with the diagnosis of appendicitis, but you find these dilated bowel loops. The patient had an ileus and had a perforation into the pelvis. With a situation like this, where bowel loops are hanging to the wall and all, you still want to go in, but if you ask me what I did in this case, this patient was opened up. So, back to presentation. It was opened up and it was done in an open manner. So, I'm concluding. Slide. My final thoughts are: it is a viable and safe option, that appendectomy. The thorough inspection of the abdominal cavity avoids unnecessary negative nephrotomy. As we know, it's an advantage. It has all the benefits of minimally invasive surgery. And once the difficulty, like I showed in the last video, conversion is not a defeat, but a wise decision. Thank you very much.
Thank you for being in time. Since you are presenting different scenarios, you can add 2 more. I was not happy to see using the stapler there in that appendix. Okay. Avoid staplers on a base which is very hot. It is invariably leak. Avoid in that situation. Here, probably I would see you doing a transfixation of the base and persecute. If you have a hot base, go to the normal healthy cecal earth and invaginate. That's the only time I would.
So the only fear was preventing a splage. Even if the minus stage of the mucin occurs,
base was healthy. In that case, and then you have added a variety of I-60.
Yeah.
Now that you are in that, showing the different type, add these 2 things. One is in a hot base, don't use that. Here, preferably use a transfixation, like we do conventional work. And do bury. This is the only place where I, as surgeon, this is my take, I would bury. Otherwise, many people don't do that. Laparoscopic persistence can easily be done. You can do that. That's one. Second situation would be that transfixation helps you in securing mold, leakage and other things. Rest I think all things. Then other encounter with the which many a times all of us must have seen. You are opening for appendix, then you may have a perforated ovarian cyst. How do you handle? Or you may have a knuckles. Add 1 more variety to that, so that it becomes a total.
I had a few more of stump appendicitis and all, but there was a shortage of time. So
do that.
Yeah.
Thank you.
Thank you, sir. Points well taken. Thank you very much. Thank you.
That concludes our session of video presentation. We sincerely thank all our presenters for their efforts and outstanding demonstrations. A special note of gratitude to our respected chairpersons for their valuable time, insightful inputs and continuous guidance. Now, we would like to request our esteemed chairpersons to come forward to facilitate our presenters. First, we would like to call Dr. Mudassar and Shahdar to kindly accept our token of gratitude.
Yes. Yeah.
Next, I would like to call Dr. Tariq Hussain to receive our token of gratitude.
Yes, please. Center. Yes. Okay.
And now I would like to call Dr. Mudassir and Shahrar to receive their award.
I have taken one.
इसको एक ही
Yes, please. Okay.
Now we would like to call Dr. Y.P. Singh, Senior Retired Surgeon, Health Services, to felicitate our esteemed chairperson.
जगह दे सर इधर से आधे तक मेरे आ गया सर इस जगह दे बस बोर्ड कर दो
Yes, sir. Thank you.
First, we would like to felicitate Professor Dr. Mustaq Charku.
Yes, please. Yes. Okay.
Thank you, sir. Now we would like to call Professor Dr. Rajrishi Sharma.
Yes. Yes.
Thank you, sir.
Okay.
Now we would like to call Dr. Babar Zarni.
Yes. Okay.
Thank you, sir. Now next we would like to felicitate Dr. Altaf Ahmed Malik.
Yes, please.
Thank you.
Good afternoon, everyone. Any PG or delegates who wants to be a member of JAKASI, please contact Dr. Harvinder Singh Bali, Honorary Secretary JAKASI. Thank you. So now we begin last academic session of a scientific program, the invited faculty lecture session under the theme Mastering the Art of General Surgery, Practice with Precision. This session brings together distinguished speakers who will share their wisdom, experiences and perspectives on the evolving practice of surgery.
To lead and evaluate this intellectually stimulating session, we are privileged to have with us another distinguished panel of chairpersons, true surgeons of wisdom, whose expertise keeps our learning curve well incised and perfectly sutured.
We extend a very warm welcome to our respected chairpersons, Professor and Dr. J.G. Langer, Professor Surgery, Professor and Dr. Suleiman Chaudhary, Professor Surgery and former Principal, GMC Kathua, Professor and Dr. Ratnakar Sharma, Professor and HOD, General Surgery, GMC Jammu, Professor and Dr. Ajaz Ahmed Malik, Professor and HOD, General and Minimal Access Surgery, SKIM Sora, Professor and Dr. Nazir Ahmed Wani, Professor and HOD, General and Minimal Access Surgery, GMC Anantnag. We are deeply grateful for your gracious presence and look forward to your valuable insights throughout this session.
Now we hand over the session to our esteemed chairperson.
Professor Dr. B.S. Pathania.
चलो कर दे
At the outset, I must thank Professor Ravinder
and his organizing team for inviting me to speak before you on this topic. This is very important. All the time we have been trained to save lives of patients and fix their complex problems to improve the quality of life. But how often we have thought of our own lives when we are working? So let's see how we can explore this. This is the latest reference in JAMA, July 2025, that surgeons, as compared to other allied branches of medicine, are prone to coronary artery diseases. And the reasons given is high stress levels due to sedentary lifestyle, pressures from patients, families, medical legal problems, and irregular habits of eating food, that all lead to prone to coronary arteries. Now, what is work life? It's not like balance. It's like taking care of your professional life, and at the same time, you take care of your family and personal life. Why? It prevents the burnout. It will help in enhancing your performance, not only in operating room, but beyond that. It improves your personal and personal relationship also. Now, why it matters? Because once the surgeon is happy, you can be more effective, both in academics and in your practical skills. If you are not looking after yourself, so you can't pour anything from an empty cup. Why I chose my line as a surgeon? I became surgeon because it appealed to me, because as compared to other specialty. And but as shown in the movies and dramas, it's not that glamorous and dramatic, but it is still exciting and rewarding. Now, many of our colleagues, when we took up the surgery, they discouraged us, me, not to take up surgery because as surgeons you will not have a good family life and so many things which you will not be able to do. But many years later, I still love what I do as a surgeon. And if you believe in the theory of reborn, I would like to be reborn as a surgeon among all of you. Now, the making of a surgeon is not a simple thing. It requires a lot of dedication, personal sacrifice, and resilience. It takes years to develop skills, and you have to upgrade yourself and update in every way. So, you have to be positive and thankful, because we have been entrusted with a lot of responsibility by our patients. We are rewarded well, surgeons are rewarded well in terms of respect, gratitude and money. But unfortunately, there are surgeons who lack personal insight. You know, these young surgeons practicing, they are not young surgeons, young people practicing music, all do not become experts. They are performing, but they are playing music in their own position. Same way, all surgeons do not become mentors, but they are contributing to society in their less demanding position. No, are surgeons happy? Now, you know, happiness, it is all evidence-based. Happiness, it comes 50% from genetics, 40% from isolated events, and 10% it comes from work, family, community. What are these isolated events? You know, like you are hungry, you feel like having something, cheeseburger or something, you get that. At that particular time you are happy. Same way, you have an old car, you want to have a new car, so you get that car. For that particular moment you are very happy. And same holds for you, then you want to have more and more advanced car. You work more and more. So this has been explained by a hedonic treadmill. This is a scientific psychological concept. A new success or or anything material will give you a very, very fleeting moment of happiness. And as over time, that you come back to your base level. And this, it means, what it teaches us, that chasing material goods, achievement, often doesn't mean that this happiness will last for the long. So, it's a well-heard term that money cannot buy happiness. That is, that once you attain, you have annual income, you have everything you have bought, that more and more you are thinking of buying or achieving, there is a limit of happiness. Beyond that, the happiness remains same. Happiness doesn't increase by having more and more money. So one should be satisfied with what you have. Now, it is a universal truth that a practice of surgery has inherently stressful. It is stressful. And the source of stress comes from various components of our profession. Maybe it's a clinical care, academics, practice in management, and of course now the medical legal problems have added to the stress. Now, external causes could be work, your relationship changes, your financial problems, being too busy, and of course from children and family. These are external. Internal comes from within and negative feeling and all. Now, what are the symptoms? Once there is no balance between life and work, you will have mental, emotional, physical behavior. So stress and work pressure leads to imbalance. Now, what is this work-life balance? That means a sense of control to be productive and competitive at work. At the same time, you should maintain your happy, healthy, and family and personal life. Now, it is not same for every person. Every person has got its own personality and it varies from person to person. It is important to accept that there are some components of our profession we cannot change. So we have to adapt them. Life is about balance, and too much or too little can kill it. The best way to balance is that you learn to say enough. You must have boundaries for everything. And when you are doing work, the private life should not come in between. Because private, you should keep private. Your love life, your income, your next move should be private. You should not mix with work, because then you will be more productive in work. Now, young, when you are learning surgery and you are being observed by your seniors, you may not have time to balance this work and family. But as you climb stairs of profession, you may have some to start getting independent, and then you start balancing your this thing. The best way to gain work and life balance is be honest what you do. Do justice to your work, your family life, enjoyable activity, and whatever happiness means to you, chase it. You must see to it that you are maintaining your health by doing some exercises and keeping your mental health also good by doing some meditation. It's very important that to understand the surgical career, it impacts your family life. It's a very taxing. It puts patient first and family second when you are in your work. So to have a good work and family balance is difficult for a surgeon, but I think you must attempt it so that some productive work is done in your profession. At the same time, you are happy as well as the personal and family life is concerned. Life is what you make it. Okay? If you keep on doing surgery only and don't bother about your personal and family life, that will lead to imbalance and you will not be happy. So it is better to have both. And for young surgeons, when they are choosing their partner, they have to be very selective. and very, very understanding. Otherwise, you know, this means if your wife is happy, so your life is happy. So you have to be careful. Now, learn to cut your routine work. It's not that every day should be same. Have fulfilling life outside your clinic. Maintain your personal relationship. Taking care of your own physical needs, nutrition, and self and health. That is what makes balance. And you must de-stress yourself. You must go on vacation and come back, and you'll see that you will be more productive. There is an evidence base, which I have not put it here. It has been seen that surgeons who maintain their work and life balance, they are more productive as far as the skills are concerned, patient care is concerned. And so positive brain automatically leads to amazing results. Now, this is few slides that when surgeon retires, what to do. You know, surgeons after retirement there is tendency for surgeon to go into depression. So what to do? What he thinks he gets all adjustment difficulties. You know, that he thinks that his identity, he labels his personal identity, he compares to your surgical practice. Now he's not that busy. He has limited surgical practice. So this comes as a negative to a patient. So even it affects your mental health. So how to prevent this depression in a patient, in persons who, doctors, surgeons who are practicing and they have physical challenges after retirement and emotional. So you have to take care of your thinking, rewind yourself and think that identity should not be compared. You are surgeon in the society and you have your identity. Don't compare that with that once after you retire. So you have to redefine your identity beyond the scalpel. So surgeon can still continue to earn if he takes up, teach medical students, do consultation on tele or in your clinics what you are doing, practice telemedicine, and you can publish and do whatever is good. So key message is retirement is not a chance to give back. It is a chance to give back and grow. So thank you very much. Best surgeons are not those who are operating. They are how they are operating in theatres. They will be remembered how they loved, lived, and led their life with purpose. Thank you.
Thank you, Dr. Pathani. So, any comment? So, Dr. Pathani had chosen the profession which show as all of us. So, there is a couplet. जैसे एक बार कदम उठा था गलत राय शोक में मंजिल तमाम उम्र हम ये ढूंढ दी। Thank you.
We have second speaker, Professor Dr. Kumar Kathua, who is the Professor of Surgery in GMC Kathua. He is going to talk about safety and efficacy of mini gastric bypass, or EGB, in opacity, their experience in GMC Kathua. Professor.
Thank you so much, the organizing team led by Professor Ravindra Gupta. After such words of wisdom from Dr. Pathani, we wish we could balance all this. We wish we could balance all this, and I think here comes the role of obesity, which has become a global crisis with its all financial burden. We know obesity is one of the challenging disease in the 21st century, and because it makes you all crippled. And this is what it leads to, and we as a surgeon has a role to play. Today we know it's a World Diabetic Day, and as a surgeon we have a role to play in controlling the diabetes also. So bariatric surgery has emerged as a very you see, a global procedure which has been indicated for control of diabetes in the world. So how we classify the obesity? This is we should all try to remain underweight or a bit of normal weight in the range of 18.5 to 24.5. Very difficult. The balance is to maintain this is very, very difficult. Why the global problem? Because why his talk is more important? Because 1 out of 4 of us are obese in the country. So how we are obese? Because of all these are habits. And JNK is no exception. So we can see the various parameters in children, in women and in men. In this age group, how we are getting our systems deranged because of our various habits which we need to rectify. So what are the risks associated with morbid obesity? So these are, as our weight, obesity goes, BMI goes high, all these type of diseases starts manifesting in us. So type 2 diabetes, breast cancer, hypertension, dyslipidemia, osteoarthritis, sleep apnea, all these parameters as per the evidence starts going up and up. So what are the base role of surgery? So with bariatric surgery we have average weight lot of 60 to 70%. Right? That most of the medical comorbidities are cured or they are off the medications. Like diabetes, we can achieve the cure rate of 80 to 90%. Hypertension almost 30 to 40%, sleep apnea, and long-term weight loss. Almost 80%, 90% of these patients, they have weight loss of more than 50%, even more than 10 years or 15 years of follow-up. This is another evidence that there is a decreased esophageal adenocarcinoma by gastric bypass surgery. So this is the ARMS trial which has shown the glycemic control. The diabetes controlled with the bariatric surgery over a follow-up of 10 to 15 years. Again, gateway trial. It shows that our blood pressure follow-up of 10 years has been controlled with bariatric surgery. In all those patients who are obese or super obese. Even renal heart transplantation, the rate of heart transplantation has come down because it improves our ejection fraction as the BMI comes down. All our liver problems like fibrosis, cirrhosis, fatty liver, all other, you see, NASH, they come down with the gradual follow-up after bariatric surgery. And after 10 years, we have found that they have come back to the basic level. So medications for surgery, of course, there are now obesity pills available in the market, but are they worth it? The results have shown that they are worth considering. They are bridge between the bariatric surgery and the normal after the lifestyle changes fails. But it's the cost. If you have you see metabolic surgery, it reduces the risk by 40 to 50%, but the medical treatment reduces by 10%. So in other words, if you are going for a bariatric surgery, you are treating 10 patients. When you compare the cost and effectiveness of all these semaglutides or Ozempics or all these medical pills which are available. When do you refer these patients for metabolic bariatric surgery? So these are the latest IFSO guidelines. All BMI patients over 40 milligrams per square meter, they are to be referred for bariatric surgery. BMI between 35 to 39.5, even in absence of comorbidity, they are to be referred for bariatric surgery. BMI between 30 to 39.4, if they have comorbidities like type 2 diabetes or hypertension, they need to be subjected to bariatric surgery. All these parameters have been lowered for Asian population because of more comorbidities associated with lower BMI. So even in the Asian population, a BMI of 27.5 can be indication for bariatric surgery. So where we stand in our institution, so this is the data from last 2.5 years. So we have almost operated 135 patients. We are doing most of the procedures in our institution. Dr. Chalku, Professor Iqbal sir, we started our bariatric program somewhere in 2015, and we have now well established, you see, a program in our department where not only the obese patients from J&K, but we are catering the patients, obese patients from all over the country. Not because we are doing some wonders, but it is offered free of cost. Most of the staplers, most of the gadgets, most of the medications are provided free of cost. Whereas all over the country, it is all cost. It will cost you 6 to 7 lakh rupees. So this is a short video. Please come. Yes, once we do a diagnostic laparoscopy in these patients, and once we decide that we have to go ahead after port placement, we retract the liver and we create it. It's a very simple procedure. Mini gastric bypass is a very, very simple surgery, anybody can do it. We create a retrogastric tunnel as distal as possible, because the motto is to create a wide and long gastric tube. It is unlike RYGV where we have to create a small window. So in this we create a wide and long gastric tube, because it is not the totally restrictive procedure, it's a metabolic procedure. So after you see dividing the pylorus, just proximal to the you see vascular claw, we fire the staplers in the loosely along the 37-38 French bougie, and all the retrogastric adhesions are taken down, and make it sure that you fire at least 5 to 6 staplers, because if you fire less than 4, that means the length of your tube is less than 18 centimeter, and it is going to increase the chances of reflux, bile reflux. So your tube has to be wide and it has to be a long tube. So once the gastric tube is made, you take a BP limit depending upon the condition of patient. If it is a super obese patient, go up to 150 to 200 you see centimeters of the small bowel. And once you decide about the BP limit, in diabetic patients we may, who are lean and thin, we may go for even 110 to 120 centimeter of BP limit is sufficient. So once you decide about, depending upon the BMI of the patient, you make a side-to-side enterotomy in the jejunectomy and the gastric tube and fire a single stapler. This is the reason it is very simple. And your gastrojejunostomy anastomosis has to be 4 to 6 centimeters. Minimum of 4 to 6 centimeters. That's the reason you need a long gastric tube. So this is the anti-reflux stitch which is usually given to keep the BP limb in a horizontal with the gastric tube, so that to minimize the chances of bile reflux. So once the gastrojejunostomy is created, we close this tube and do a leak test, so that there are minimum chances of, because leak is one of the complications of the MGB. So after closing the enterotomy, we push this bougie, which is 38 number bougie, into the alimentary limb and close the enterotomy with the V-lock suture, and in a single layer or two layer depending upon your forward. So single layer or two layer gastrojejunostomy is, this enterotomy is closed, and once we are through with it, we do a leak test, and after a leak test we just place in the drain. So this is our data which we have collected from our last. These were the baseline characters of various patients. We have BMI of 45 to 42 to 45, and these were the various. You see, they have sleep apnea in 42% of the patients, dyslipidemia requiring heart surgery, almost 53% of the patients. So whatever the operative time, almost 1.5 hours to 2 hours. Nowadays we take almost 1 hour for completing MGB. So this was the outcome after 6 months to 1 year. So most of the, you see, BMI has fallen down between 6 months to 1 year, from almost 43 to 26, 33. So these are the basic TG levels. TG levels have again come down. See the graphs. They have, over a period of 1 year, they have come down to basic level of 148. Cholesterol, again, after 1 year, these were the various parameters which were studied. And all these HDL, the reverse has even made it true. That HDL level has increased to from 15 to 44. So most of these patients are off the drugs at 1 year of age. Be it hypertension, be it statins, or be it the insulin. So these were the various complications we came across. We had a bleeding in one patient of late, which was done almost 1 month back, and which was managed by endoscopy and clipping. There was a bleeding at the anastomotic site, gastrojejunostomy site. Endoscopy was done, and the clipping was done, and patient was all right. We had leak in one patient, which was managed. After 3 days. We could pick it up, and we did a re-laparoscopy, and we found that there was no leak from gastrojejunostomy site. The leak was at gastric tube site, at the fundus. So we just made the we dissected out and applied few sutures, underending sutures, and the patient was all fine in the post-operative period. We had polylithasis in 8 patients, and these patients, they presented within almost 1.5 years after mini gastric bypass. So we had to subject these patients to lab poly. So these were the long-term complications we had. GERD in 9 patients, hair loss, maybe because of nutritional deficiencies, and polylithasis in 8 patients. So this is the conclusion. Mini gastric bypass can be done by any surgeon who is doing basic and some laparoscopy. Because it is simple, it has a short operating time, it leads to effective and long-term weight loss. It faster recovery and improve, metabolic comorbidities. Thank you so much. So whenever you require a weight loss, it needs to cut something. So you have to cut the stomach and reshape and reroute it in various ways. Thank you so much.
Thank you very much, Mr. Reddy.
Thank you so much, sir.
Indeed, most of these procedures concentration not only reducing the weight, but getting them treated for metabolic change like hypertension and thank you very much. Thanks for the presentation. Is there any comment or any question? Thank you very much.
Thank you, sir. Thank you so much.
It's my pleasure to invite Dr. Akhtar Ganai, Consultant Surgery, JLNM Hospital, Srinagar. This topic of presentation is laparoscopic removal of intra-abdominal foreign body.
Sir, that is मेरा सर है.
Good afternoon, everybody. First of all, I would thank the organizing committee for allowing me to present my experience. But sincerely, I feel really awkward that because my presentation does not deserve this session. It's a guest faculty session.
मेरा था.
Deserves a better session.
It deserves early session.
Better session.
I have given you my talk, sir. Please go ahead.
Anyway, sir, I will present. There are 3 cases with one foreign body within the got ingested foreign body. The other was a retained needle, and the third one where we could not make it from the history where from the foreign body had come. Probably, and then with retrospectively we thought it has entered from the anterior abdominal. So the first one will go intra-abdominal, left out foreign body. This was a needle. Patient had hysterectomy around 5 years back. He had some LBA and recurrent pain abdomen. Ultrasound were normal. She went to the orthopedician. Orthopedician got an X-ray done, and there was a needle. CT was done. First of all, I will say what is a retained surgical instrument. It is an instrument or an item that has been left accidentally within the abdomen while you are operating. The frequencies has been reported from 1 in 100 to 1 in 5,000, but some people have given a frequency of around 1 in 1,000 or 1 in 100, 1,500. So what are the types of radiance? As you all know, maybe a spine, a gauze, a square, tweezer, forceps, needles, safety pins, knife blades, scalpel, scissors, or any other device which are used during an open or laparoscopic surgery. Retained foreign bodies can be harmless. They can give simple or minimal complication, and sometimes they can give very serious complications. Surgery is not advising all, but there are certain foreign bodies which need to be removed. The first case I will present is a 55-year female who underwent abdominal hysterectomy, open abdominal hysterectomy, around 5 years back. She had recurrent pain abdomen, ultrasound was done, which was normal. Then she went to an orthopedician who asked for an X-ray, and he found a right leg fossa. We got a CT scan done and localized this, what's called as the needle. It was in the right leg fossa, just behind the cilium, embedded in the flat of the head. With the video, the patient was subject to laparoscopic. When was laparoscopy and removal of the stone was done. Removal of the needle was done. It was just the right leg fossa. It's a simple thing, but another case was an injust scarf needle. As you know, majority of injust foreign bodies may cause spontaneously, but there are certain situations where they can get impacted. You can remove them by endoscopy, but if endoscopy fails, you need a surgical removal. That can be open or a laparoscopy. Here I present a case, young female, 21 years, unmarried, had ingested what's called scarf needle, accidentally. She had recurrent pain abdomen. She was observed for around 3 months. It was moving from one place to other, ultimately it got stuck in the left leg fossa. We got the colposcopy done. Here we saw these are X-rays. This is around August. This is around again August. This is September, and this is October. We thought probably it is in the colon. We got a colposcopy done. There we could see a bulge in the sigmoid colon, but it was not possible to retrieve. So we thought we'll go for a diagnostic laparoscopy and laparoscopy. With the help of CR, with this help of CR, we could, by moving the gut, we could feel that there is a stone, there is a scarf needle. Next. The foreign body was localized and enterotomy was done. The enterotomy was secured and the ports were closed. There was one other patient where we could not accept him. Wire from the patient got it. Probably with the retrospect thinking that it had entered from the anterior abdominal wall. Elderly male, diabetic and abdomen with fever, leukocytosis, ultrasound showing omental edema, and some collection. We got a CT scan done. Then we decided to go for a laparoscopy. Diagnosed laparoscopy and is the CT? So there was Janus adhesion with the cranial wall, momentum was generously adherent, and it was a collection of pus. We did an adrenal and omentectomy was done laparoscopically, and peritoneal lavage was given, and the patient was drain was put in the intra-abdominal cavity. The short video, you can see it was wrapped in the momentum. So these are the three post-operative pics. This is the first patient with a retained needle. This is the second patient with just a needle, and this is the last patient with a omentectomy. Again, what I want to say that laparoscopy is an attractive alternative for impacted foreign body. Foreign body is within the abdomen, in the gut, or within the omentum. It is less invasive, less painful, of course, faster recovery. Give a small scores and is cosmetically better. So wherever you fail to get impacted foreign body from the gut, fail from endoscopy, I think laparoscopy is an alternative procedure. So laparoscopy removal of long and short foreign bodies from the abdomen is feasible and safe. Thank you very much.
Thank you, Dr. Akhtar, for a nice presentation. Any questions from the audience? Okay. Now I call upon my dear friend, my colleague right from 1986 as a batch fellow, great surgeon, great person, nice, Dr. Sir, who is working as professor of surgery.
Dr. Mustafa had been my classroom to at GMC. I'm so glad to see that my classrooms are accepting me to stand here. Thank you, sir. And to my teachers, I have learned much of things from the class. I would, sir, I was planning to make a talk on pancreas, but that has got virus. I was checking. If you allow me, I will make a talk on spleen. You are allowed within time. Within time. At the outset, I must thank my friend, Dr. Ravinder. He has been our student, our postgraduate, that's how, but now he has gone ahead, and I am still struggling to become head of department. He has already done it, so I am congratulating him. That's how the life plays a game. The teachers who have taught me. So this is what is a game. What I want to convey is that the mental obesity, he talked about physical obesity. Patanya sir was talking about the mental obesity. I am with mental obesity. That spiritual lectures have to be learned, sir. That's what I. So I talk about spleen, and I took around 2016 or 17. I performed my first try to feel like how it tastes to touch spleen minimally, in a minimal way. So that is, as I could not get into this, you all know this historical aspects. Spleen is the most unnecessary organ there. That's what people had a thought once upon a time. And then they gave different names to it. And still the mystery probably is shrouded from Sir Ajaz that was present. And I will not get into the anatomy part, you all know this. And the functions and all that, we all understand and know it. Honestly speaking, yesterday, 3 days before, I told my registrar to later and look back at how many splenectomies I have done. I, as a civil department, I don't understand and know. I take care of my data. So it is 64 splenectomies we have performed in a span of 9 years. And I'm lucky to tell you that I got it for the free indication almost, what this indication tells. I must have, and each video is preserved on my YouTube site, and thankfully I have published more than 600 videos of different surgical aspects. The idea is to make it as a record and put it to the project. But as we have learned from you, somebody can learn from us. That's how the legacy goes on. So these are the indications, and I have tasted all indications. Probably I was lucky to get the indication for screening. The vaccination, of course, I have a debate with the hematologists about vaccination. You know the CDC surveillance and the guidelines. We don't follow them. I don't know why. The reason is our hematologist says that we should elective we should give post-operative. Otherwise, 2 weeks later, as we all understand, I don't know, and we follow what he tells us. Otherwise, he will stop giving cases to us because he's a hematologist. Screen comes to us from hematology. So we oblige, we go against the guidelines to get a screen. So these are the different techniques. I have mostly done it in the supine and the lateral position and transabdominal route, which is the most preferred route. The different CTs and post-operative videos, you will see some of these on my detailed videos. If you are interested, you can go to my website. We have recently completed 603 videos. And we have 2 publications. One is a technique which is puppet modification on our name, and another is a very rare case on sarcoidosis of the spleen we published. This is my channel, and I hope this is a very thankless job which I still keep on doing out of passion, and this has gone to making the around 600 videos of different subjects. Let me just tell you the technical aspects of different. I might not complete in the time, but I don't know what is in this because this talk I was not prepared, but I don't know. This is for hereditary spherocytosis. You can understand hereditary spherocytosis, the spleen will be very huge. So understand it will be like a monster sitting out there around 25, 27. We created a record of laparoscopic splenectomy in 3.5 kg, which is already published. And that when I went to the literature looking back at how these spleens work, there's nothing like the size matter. That's our observation, our thing. Size is not a problem, even if it is a massive spleen, kindly do it laparoscopically, because it's not only the length of incision, the precision, the vision, and then of course the morcellation and removal of the specimen is a problem because of the bleeding which at the end you may have. But I'm not going to tell you how this spleen looks like. You will not take a measuring tape that is only 15 centimeters. So what we do, we take a tubing, which is not a feeding tube. It is almost 20, 30, 40 centimeters, 50 even. And then you measure from the upper pole. You can see a handshake sign. Handshake sign is when the liver crosses the upper pole of the spleen. It's a handshake sign. So otherwise, normally you will not find the liver crossing touching or kissing the spleen. So these are different. This is hereditary spherocytosis. Always expect a huge spleen, totally bizarrely. And then going around the splenic hilum is a problem that you all understand. We are always worried about the bleeding. But the thing is that if you have an angio-CT, you can do to say whether it is a distributive pattern or it is a magisterial pattern. Surgeon would love to have a magisterial pattern. And problem happens in a portal hypertension where you have to handle these dancing snakes. It becomes very tough to handle such spleen. So I will just push off to tell you what exactly I want to show you is the splenic dissection. We enter through the levorenal technique. Now you can appreciate that as you go there, most of the time the splenic vein is intracapsular. So separating the splenic vein, you can appreciate this is a splenic vein here. But as we have taught that we should take the artery first. But the problem happens that the vein comes first. So you have to handle the vein, push it down somewhere here and there to look back at the artery and ligate it. That's a problem. So what we learned the technique how to do that, because in the early beginning of your career, you may probably in the first few cases you may jitter doing that because of injury, and vein should be respected more because it's too friable. Even you are holding it by instrument will sometimes create a problem. Now you can appreciate this is a vein here, a huge vein. Even clips should not be done. Always put a. This is what we have learned out of 64 splenectomies. And honestly speaking, I never had a conversion. Luckily, I don't know, either I'm too meticulously doing it or probably it's a God's blessing that I never converted for spleen. But the issue is that you have to be very precise. You can see now the artery is looking up and the vein is there. And there is a very good thing which God has created. 1 centimeter distance between the splenic tail and this. Exploit that 1 centimeter. Otherwise you will injure the tail. So you can appreciate I am lifting the pancreatic cells from the tail of pancreas and trying to only explore the vein. Now in between you have to go up, take the, this is vein and spleen is lying on the other side, just sleeping. Don't let it know that you are around it. So try to separate this plane. What we learned that in the beginning we used to use these angle retract, but slowly I learned that this best instrument for it is the needle holder. Keep on screwing. It can create a very safe plane between the artery and the vein. You can see on the top here is the artery and this is the vein. You have to now make a cleavage here, which could be done by different instruments. But my feeling is it is needle holder. Now you can see I will take a needle holder, probably not in this, in the next I will show you. But what you do is that you take a suture, never put clips. Just putting a clip on a vein sometimes cuts and this just happens. So please put sutures. I know it will be difficult, you will be tempting to put a clip, but no, take time. You see now I am taking the artery first and then leaving the vein there. Sir, adjust. You can make it. Then taking the artery first because that will not conjure this and then lose some blood unnecessarily. Not taking the artery. So that is one scenario. In the other scenario, let us see this patient. What is he coming with? Okay. Now this patient, I don't know, spleen for massive spleen. Yes, this was a huge spleen sitting over there. For the indication, I may not be revealing for all. ITP gives a very small spleen. ITP is a very simple splenectomy, but yes, you can see we have marked the ports will vary in measures. We will sometimes make it in the right leg portion. So that is how it is. So now you can see this spleen. Let me show you how. Now this is a patient who had a hereditary spirocytosis. I am doing a single hand cholecystectomy first through the same ports and then turning to the other side because they lie in the different villages. One is on the right village, other is the. It's not on the same side doing cholecystectomy and nephrectomy. You have to say, and handling with the same ports is technically difficult, but can be done. Now you will see I am doing cholecystectomy, just doing with one hand only. One port on this side, you will not see the second instrument on this side. This suture, what I am doing is called intero-exterior. See, with one hand you can do single suturing. I try it in colon, I try it in gastric surgery, even in pancreas. I have been trying it, and this suture makes you so comfortable. You don't need second hand to hold it. You can see the amount of spleen, the huge spleen that is lying there. This is called the monster spleen because it is eating the RBCs, then it gets a bronze color. So when you look at a bronze color, you will make a diagnosis spot like this is a patient of spirocytosis. There's this spleen has killed so many and these RBCs. Now you can see how to lift such a spleen. That's a technique. If you just create it is such a pliable spleen, you just prick in it will not leave you. It will not stop. So you can see with my left hand instrument I am holding the spleen up. This spleen must be around 32 centimeter spleen. See, 12 is the normal. You can appreciate. Now I will go ahead to show you the dissection at the highlight. The problem is that sometimes there is so a vascular arcade that you don't know how and where and what should be clipped first. That's the problem. It's such a bizarre dance of vessels that it takes you to demons. Now in that situation, kindly understand that bleeding might occur because a lot of vessels making arcade, especially if you have a left-sided portal hypertension, but a compensated portal hypertension and good LFT. Please make sure, otherwise they will decompensate the effects. It can happen. So please make at least child's food should be a good adequately maintained than before you see. Now you can see the amount of vessels you can have here, how we are ligating one by one. You don't know whether you are doing the same vessel twice. Is it because of the dance? So that is the worry. So in that situation, stay more away towards the tail of pancreas, then take the vasculature. So you can, I don't know whether in this patient, where what happened, but I had a bleeding. I'll tell you how to handle that. Bleeding has never been a question with us for conversion, so you should not play the heroics. Whenever you feel, you can convert. But I'm talking, luckily we did not have, but it can happen. Probably somewhere, let me see there. No, I have to not watch this in the morning. I was prepared for pancreas. So somewhere there is a bleeding, vessel gets hit. That's why we are making it anyways. That's what we learned that the use of needle rotor. We published it as our own innovative technique, and it was referenced. Thankfully, we have crossed 16,500 citations with our work, and it's highest in the North India. So now let me honestly tell you that what is the problem in getting the splenic vein out is that it is so friable that even a touch sometimes, especially in these iridocytosis, hereditary spherocytosis in such patients can give a very tough time. I hope I can see it somewhere coming at some point of time, get a bleeding, and then no problem. Actually, I did not watch this even in the morning. Maybe. Okay, I'll leave this. Somewhere you can watch this video is fully published. So another scenario is when you have a cirrhotic patient and doing a splenectomy. Cirrhotic patient, a macronodular cirrhosis, just put it, liver is like this, and then you are doing a massive spleen. Massive spleen has been our, a passion to handle these massive spleen. And how we made it safe is that use of instruments and the precision anatomy has to be learned. Kindly don't bother to do CT angio to see the pattern of vasculature in the spleen. That will make you very, you will be more precise in your, and you may be secure in understanding the splenic vasculature. Probably in this patient, we had that problem. And all of them have different indications. I don't remember exactly. Everything is written, all these. There are publications of more than 45 spleens on my website of different sorts. Probably in this patient we had a bleeding. You can see somewhere we had a bleeding. This is a plane we are trying to create between the splenic vein and the splenic artery. So here, while taking the artery, I injured the vein. I hope it comes in this video only. Yeah, that's it. So here a beat of what will go. Because if you don't take it properly, you need to understand that it's such a friable vein. It is vein, not artery. While taking the artery, vein got cut. And just a small nick over there, just to holding this vein again, you can see you are groping, but precisely handling it, you leave it. I'm holding it with the wrong instrument because that's the only instrument that will happen. If you leave it, so much of blood will pool out, it will take a lot of time. Getting a gush like this, you can all understand, we all are afraid of bleeding, but precision helps, and precision, calm mind, I think all of us know that has to be appreciated and has to be practiced. Unless you just put a clip over there silently and don't shout at your team. I never do that, thankfully. I don't know, God has given that. I don't shout at because I am wrong, my assistant is right. So I should see this again. You can see a bunch of veins and vessels there, and we proceeded with this patient, completing it laparoscopically. And then you can see, appreciate the vein. I'm putting sutures and then putting the clips. That will collapse the size also. Then you can put a clip to the tune of clip, it will come. Otherwise, sometimes veins are 2 centimeters, especially when you have left-sided portal hypertension. That's another situation which I wanted to tell you. There is another situation in lymphoma, how to do splenectomy. Now, this patient had a laparotomy, 2 laparotomies. One is the midline huge scar, you can see a subcostal incision there. Then going in to do drop a spleen of this patient. And then here the issue is that I don't know what I want to show in this. I will just take 2 minutes if you allow me, because 2 scenarios are interesting to watch. So you can see now here I am taking a suture for the splenic vein. This vein must be around 2 centimeters, right? This is a lymphomatous spleen. I will not do morcellation here, but I can do a chopping, which is recommended. But a gross appearance for the pathologist is important. So that's another scenario. I think in hydrated we all have done it. We all know it for the hydrated. Only the prescription is that you should put packing and gauze and all that. Let me not go into this. I just see a sarcoidosis. We got a best post award at the national level, one of my PGs. Just because sarcoidosis, getting a spleen of sarcoid, purely sarcoid, because you could have distal sarcoid, you could have this is a sarcoid, And you can see, appreciate the sorboid spleen is little different because you will get, it's a granulomat, non-granulomat. So you have to rule out, it should not be tuberculosis. In one steroid is a treatment other. Say, angiotensin converting enzymes are precisely high in a spleen. You can see, appreciate this spleen. It is small, but sorboids are all over it. They are like granulomats nodules. You can see that nodule there at the top. So this was a young 35-year-old man. He did it somewhere else and leaving it. Finally, the diagnosis. You can see these are sorboids. So you can appreciate them. And doing splenectomy in this. And I just recently, I think 2 months before I operated a young girl, she came to me referred by a hematologist. She wanted to do laparoscopy. The problem is they call it sand. I don't know how many of us know sand. I did not know sand. Sand is a sclerosing angiomatoid nodular transformation of spleen. It's a tumor of the white one, very fibrous. It took half an hour. It took me to get the spleen out, but it took me 1 hour to chop that spleen because that fibrotic. Just take a 1 minute. This is very interesting. I don't know how many of you have encountered this. This is an interesting case. Finally, see this spleen. This spleen is splenic. We call it a sand spleen. SANT. Sclerosing angiomatoid nodular transfer. Young girl, 19 years. 19 years, 1 month old. I think past the suspense is the day when I operated somewhere else. So now you see, when I went in, I wanted to check the spleen, do an inspection. How is the spleen like? You could see a tumor, but external look was something like a fleshy. Spleen is all fleshy. But when I went in to handle the spleen, it was exactly like a fibrous, dense fibrous tube, which took me 1 hour to chop it. You can see from the lower pole now here, the tumor is appearing. Outside it looks very soft, but inside I'll show you at the end of the day. Now what is the technique we have published, which has been referenced lately into many, is the use of needle holder for dissection of vascular dissection at this time. We use staplers also. We have tried all of them, but they are cost. So we do best with the suture. So you can appreciate what I am doing is that here I will tell you a trick. That is what I feel safe. Now look at the vein is coming. Spleen, pancreas is down. Vein is coming. Now what are you going to do? How are you going to make the vein and artery dissection? This is the tumor on this lower pole. You can see on the left side, a very fleshy tumor. And now this is the needle hole. What I am doing a screwing movement. It's very safe. Don't take right angle. That will, once you turn the right angle, the vein may get injured, and then you will have some angry movements, as you know. Then you again see. I'm just screwing it. It's a very soft instrument, not like a suction. It is just pointing at it, not exactly like a pointing, very pointedly blunt. So you go and do a screwing movement, but you should just know how to screw. Only that is the point. So that is it. As you go, and then you go to see the splenic artery. As you go to see, now see the plane. The artery is on the top and vein is on the down. So you will first flip the vein. That is the problem. But don't do that. Just look back at how the plane is created. I will use a suture. Hold the suture up with your left hand and then go to the artery to clip. Just see, this is a vein. Vein is clipped, anchored by a suture, and the artery is looking down. Now I can create a plane, go safely to take themselves. Though you can do both together, no problem. But there is a saying in reference, very rarely you could develop an arteriovenous fistula. For those people who are so meticulous about this, for them I can say, for myself also for learning, is that this is a way when we can safely go and take the artery first. Now you can see I will take a clip to the artery first and leave that. I have taken a clip. I am just going fast. The clip is put. Now you can take suture the vein and go ahead. And then at the end of the day, take the spleen up itself. If you put a position, the spleen is up. We chop it and just 2 to 3 centimeter incision is up. That makes the thing. Thank you, sir, for bearing me for 2 minutes. 2 minutes more.
Thank you very much for your presentation of splenectomy. Being here, I would like to share some important comments because this is a surgery everyone should not try to do unless and until you have a committed departmental referral and you have clear-cut indications. So you a lot of adrenals and spleens, you know that there are some lessons which we have learned. Once you are dealing with veins, never try to clean them. Even in adrenals now we are very going to the hemlocks. It's better to avoid a catastrophe. Number two is that the simplest way if you are dealing with a big spleen is to go to the lesser sac, find the splenic artery, put 2 clips, go have a cup of coffee.
I've done it most of
come back.
I 100% agree.
Third,
Exactly 2 centimeters from the celiac axis.
Third,
Absolutely.
moderator is not always important.
Oscillation chopping we do with knife, with the scissor.
You can even use a fan steel and take out that gas.
Absolutely true.
There's no problem.
There's no problem. But a young girl, suppose sometimes there's a question of humanness score of 3 centimeters. I think 12 mm port I enlarge. Most of my pictures are there on my YouTube. And I try to take time to just for the heck of, but it is wisely said, you can make a concealed incision down there in the pouch of this
Once we are dealing with hereditary spherocytosis and we have, because we might have a combination of polycystic, we might have a CV exploration, and then searching for the extra
Spleens.
It is a Herculean task.
Absolutely.
It's a lot of time.
Absolutely.
I think a single case in a day.
Sure.
Sometimes. So these things are not easy, but you are doing a commendable job. Nice. Anybody wants to watch the videos can go on the YouTube channel and watch the videos.
Thank you.
Any question or comment from the audience? Hello.
You're audible. Last week, you're audible, sir. Organizing and looking at us very.
I still remember I did my first lab splenectomy at Government Hospital, Gandhinagar, some 25 years back, and that was probably the first lab splenectomy of the state. And this patient had a huge hydrated cyst, and we had arranged some 7-8 units of blood. All of the blood bank was there because technology and techniques were limited. Your team was limited. Your anesthesia colleagues were very shaky. And we completed this procedure and the patient was all fine. And one day, almost after 2 years, I got a call from my surgical colleague from GMC that this particular patient has developed incisional hernia at the extraction site. So, you see, removing such a big spleen, now it is a routine. I think we must have done some more than 100 cases in our department of lab splenectomy because of improved technology and techniques.
Only 64 I have.
See, we have almost
36
yes. I am quoting it from the department. I must have done some 48-50 cases of splenectomy till now, lab splenectomy, because we have a very large and a robust referral system.
Most of us are doing it.
So techniques and you see these have involved, but still you have to take care while extracting these spleen. You have to stitch back this port side or the extraction side very nice.
One thing I'll tell you over time, we have a policy that we don't do splenectomies and photographs. I can tell you, you can have on-table deaths. Idea would be a shunt, followed by whatever you do. Like.
So as
it was going inside
Professor Atri made us
in a clear-cut portal hypertension will be a disaster because the vessels right from the abdominal wall, once you put a port, they bleed like that.
I would add a very interesting here. It's published in my website. Spleen in the disguise of heterotaxy, what you all know. What happened? We got a patient landed with us with a mass in the left iliac fossa. We got a CT done. It showed a mass in the left iliac fossa. I told them on the rounds, because we make an exhaustive round, I told them, this is what is the diagnosis. I said this could be a left-sided appendix or a diverticulum, which is infected. We did a CT, it did not show diverticulum, it showed a dissolved lump. But it did not show spleen. So I told them this could be spleen, it's a wanting spleen that is there, but it was very short. I went to the person before doing a diagnosis lab, and he said, sir, it is not spleen. This patient has congenital spleen. I think the postgraduate is here who published, got an award last time in Amasi for it. So when we went in, I'm seeing a very bizarre mass wrapped with omentum. Now I'm dissecting the omentum, I'm seeing there is an atrophic spleen. Texture is like spleen, but eyes cannot give the diagnosis. You can say a possibility. It is the histopathologist to tell whether it is a spleen. But I first went to his
left leg fossa. I am saying it's an open leg. There is nothing there. So it is the spleen. I said no. Where else? Then I told him, can there be a condition where a person is asplenic born and then he could have a wanted spleen? I told him, go to literature, please get back to me tomorrow. I did not have time there. He searched the literature and said, sir, these patients live 1 month. They die. This patient is 40-year-old man coming with a swelling. So how he would live agar asplenia hota? So I said, this is interesting. This is a very, I mean, wanted spleen. Wanted, no. You are not trying to say it is in a heterotax sequence. I said, how could he live? And my CT scan person is telling me, sir, there is no spleen. Take it granted, it is not a spleen, it is some naam. When I went in, it turned out to be a spleen, sir, and we removed that.
Wanted spleens are the best operated. We have operated many, and they are.
Wanted spleen is a known thing. It is a part of the model. I am talking, it was a heterotaxy which had turned out, sir. It was a heterotaxy which turned out to be in the disguise. Thank you very much.
Thank you.
Sir.
Thank you. Thanks a lot. We are getting late as the inauguration is scheduled in time.
Thank you, sir.
May I now invite the Professor Dr. Zakir Hussain, Professor and Deputy Secretary, GMC Jammu, GMC Rajouri, and his talk is abdominal tuberculosis, our experience at GMC Rajouri.
Yes, sir.
Respected chairmen, colleagues, and abdominal tuberculosis is a study, mainly the treatment is conservative, but surgery is restricted for only emergencies. First is our objective is history, who to identify and decision making. Brief history of the tuberculosis, when conflict with tuberculosis started from as evidenced by the Egyptian mummies. The Babylonian sculpture also shows 5,000 BC. Chinese literature, it is called as European. India, Rigveda described it 200 BC, described it as eruption of the ancient Persian, Greek and Mediterranean. They describe the process of the oldest bacteria in the earth environment. Germany, the oldest disease one is acid phosphorus found in the human against the last pattern in the medal one. 4th century BC, Hippocrates, the pulmonary lesions and the intestine named as Iasis means waste away. The patient died after diarrhea and this was the mortal symptoms. Lung is called as pythona of the lung. Hippocrates observed the patients are open to tuberculosis with developed secondary intestinal complication. Then Jews King in 1643 the intestinal ulceration of patient died and autopsy was discovered in that autopsy. Robert Koch in 1882 mycobacterial tuberculosis effective month of in 1882, Wesley was acid fast, Z and Nelson acid fast was John denied the tuberculosis. He described the weapon after death. Oliver Wendell Holmes described it as white plague. In the second half of the 19th century, surgeons started operating on the abdomen, and abdominal tuberculosis. It was only in the 19th later of the 19th century. Calvert and Durant's posters in 1921 described BCG vaccination. The mapping of the trends of the extrapulmonary tuberculosis to extrapulmonary tuberculosis, you can see the trend of the tuberculosis from 2005 to 2011. Total patient was 528, lymph nodes was 17 extra, and abdomen it was 3, and at the end it comes out to be the 7 and then 9. Total patient was 51. Abdominal tuberculosis classification. Acute or chronic GI tuberculosis comprising of 49%. The peritoneum 42%, eccentric lymph node 4 and salt vista only 5% of the body. GIT gastric duodenal, duodenal and colorectal. Then we have peritoneal acute or chronic, it is the metacytic, fixed fibrotic, dry plastic or persistent laculated one. Visceral is liver, pancreas and spleen. You can see the abdominal glucose is predominantly disease of a young adult. Most common site of involvement in the intestinal glucose intestinal region, which is followed by colon and duodenum. In the large cities, the digestive tract is located in the upper GI tract 8.5%, this small intestine 33.8%, in the large 22.3% and peritoneum 30.7%, liver is 14.6%. Mode of involvement of the abdominal glucose by ingestion, infected milk, and then primary intestinal glucose infected sputum through the pulmonary tox. The mutagen spread can occur from the distant focus and continuous spread from the infected adjacent foci or through the lymphatic channel. Etiopathogenesis and the risk factor. Poverty and overcrowding, people infected with HIV infection, urinary infection, the counts raised to 57%. The cause of immunosuppression, then chronic debilitating disease, malnutrition, underlying pregnancy, cirrhosis, alcoholism, addiction to the manpower, elderly, patient, incarcerated, institutionalized individual are at the risk of tuberculosis, traveling to the country with high incidence. And symptom pain is the most common symptom. It is accounts for 85%, weight loss 66%, fever will rise 35 to 50%, nitrogen 30%, malaise 30%, diarrhea is only 20%. So there is commonly seen that aseptic type of liver. We have the clinical symptomatology and features of the digestive tract disease of tuberculosis, esophageal, gastric, and rectal. The site is small intestine ulcerative structure. Then symptom could be diarrhea, malabsorption, symptom of tuberculosis, and stricture it lead to obstruction. Then large intestine and ulcerative hypertrophy can lead to rectal bleeding, numb, and obstruction. Peritonitis, ascites or abdominal pain, distension, fever are symptoms of tuberculosis. Adhesion is the obstruction. Lymph nodes, thumb, abdominal pain, fevers, then systematic symptom, liver, malaise, weight loss, gender, thumb pain, hepatomegaly, pancreas pain, gastric pain, weight loss, jaundice, gastrointestinal bleeding. The tuberculosis should be considered in the differential diagnosis of unusual gastrointestinal presentation, especially with high incidence pandemic area. These are shown by Patrick and S. Godium, accounting for cellular problems as the and World Health Organization also have pointed out the global tuberculosis report 2018 and Ranji and Gambia government tuberculosis are also published. The intestinal tuberculosis differential ulcerative can be differential diagnosis ulcerative Crohn's disease, but ulcerative uveitis, infectious disease, atrophic skewness, small intestinal disease, stricture Crohn's disease, malignancy, adenocarcinoma, lymphoma, then is hypertrophic carcinoma, lung, granuloma, actinomycosis, Crohn's disease, perforation, then typhoid, Crohn's disease, or fistula, then Crohn's disease. The diagnosis of the tuberculosis, high degree of suspicion is the only way of diagnosis. Then lymphocytosis, raised USR, active gastric, it could be because of the primary lesion, this is pulmonary tox, sputum examination, AFP, ultrasound examination, cytokidney sign because of the cold of cecum media, subpet space, upper GI endoscopy, endoscopic ultrasound, FNACL biopsy, review the diagnosis. CT scan, abdomen, finding colonoscopy or enteroscopy. The endoscopic biopsy, histopathological PCR, then next MTBR, IF, the ascitic fluid analysis, cytology, ADA and LDH will define. The most important is laparoscopy. You do laparoscopy, you find and take the biopsy, and final confirmation will be in case of suspected.
Peritoneal tuberculosis, positive PD test 38%, abdominal chest radiograph 90 to 83%, as such include protein greater than 3 grams, they are present 84 to 100%. Then lymphatic predominant AD up to 100%, they have these three culture 35, but culture is a time consuming and intestinal culture is time consuming and take time more than gamma. Interferon gamma is 93%, PCR is confirmed the diagnosis 93%. Then differential diagnosis of the exudative situs. Malignancy, particularly malignancy, diagnosis peritoneal carcinomatosis, hepatocellular carcinoma, mesothelioma, metastatic liver disease, abdominal infection, could be because of study of this country, failure peritonitis, then tuberculosis peritonitis, chlamydia. The other diagnosis, pseudomyxoma peritonitis, advanced myomatosis. Polymerase chain reactions you can take, and then everybody knows the diagnosis of the process. Then pseudo kidney signs ultrasonic because of ileocecal region is pulled up and showing the subhepatic region, it is a pseudo kidney sign. Then we have pressure or inverted umbrella sign. The thickening of tip of ileocecal bulb, you can see here the thickening of tip of the ileocecal bulb, the white gapping of the valve is the narrowing of terminal ileum. This is diagnostic of the ileocecal tuberculosis. When we have goose neck deformity signifies the loss of normal ileocecal angle and dilated terminal ileum. You can see there pairing regions of the retracted and fibrous cecum. Then you can have ileocecal tuberculosis demonstrated by, you can see these are the central conical retracted cecum, multiple structures. You can see they are arrow, they are transverse concentric in the loops of the then there comes the smooth outline of the short concentric, smooth outline of the stitches is diagnostics of the ileocecal abdominal tuberculosis. You can also see Crohn's disease as different. The multiple eccentric stitches are here. They are not concentric, and the stitches in the load is made of the ileocecal valve is always spared in the Crohn's disease. Barium iliopsoas sweating pattern involving the long segment of the ileum. There is a sparing of the ileocecal valve. You can see CT abdomen, the cold abdomen, you can see there. Then consistent almost ascites is also present in the process abdomen. These are the CT abdomen findings suggestion of gastric hepatopathy. You can see number of electrodes they are seen in the you can see the peritoneal tuberculosis, the lesions in the right is the peritoneal tuberculosis, but in case of peritoneal metastasis, they are pearly whites. This is a differentiation. The lesion you can also see in the peritoneal tuberculosis. Definitive diagnosis of culture of the colon biopsy. Culture of colon biopsy contains the then histological demonstration of acid fast specimen. Historical evidence of granuloma. Then test gene expert MTG acid can do. Then look at the polymerase scan. These are the peritoneal findings. The side of Crohn's disease again, indication of the Crohn's disease young age, indication or intestinal tuberculosis only continuous type. Lapse and remission of the short duration of the Crohn's disease, short duration of then epithelial ulcer is there. Perennial disease also there are multiple fistulas. Enteric fistula is the perennial fistula. Extra intestinal manifestation of the Crohn's disease through the tuberculosis involvement in the giant skin, eyes, and in the plating process. But in case of tuberculosis, continuous chronic disease and high fever at 38 was why before presents of empty diagnosis fever then peritoneal involvement being cycles 130 disease then diarrhea is present in the non-stage then negative PCR, MTP, but positive इसमें there multiple sites in heart of sites present perennial disease there endoscopic feature ulceration after subsequent purple swelling are there perennial disease lung circulation involvement sparing of physical but the feature of picture start picture involved physical valve different deep dense center and thicker endoscopic feature transverse are present in the you can see the electrical valve and the structure. We have treatment of the process, treatment healing of the right of the situs, regions. So treatment is mainly chemotherapy only surgery is restricted only for the surgery of abdominal tuberculosis with emergency and chronic manifestation of pharma and continuous manifestation in the patient type abdominal tuberculosis acute abdominal ulcerative stricture ulcerative ATT stricture strictoclastic section and static adhesion and then abdominal tuberculosis and sepsis acute abdominal presentation open abdominal adhesionolysis mesenteric lymph nodes and peritoneal tubercles peritoneal biopsy confirmation and chemotherapy ileocecal ileal obstruction stricturoclastic ileocecal mass ileotransverse or section of tuberculosis or right these are abdominal adhesions adhesion they have to start. This is the ileal structure stricturoclastic. This is the ileocecal mass intersection and then peritoneal tuberculosis lymph biopsy peritoneal biopsy diagnosis and then surgical getting about 6 months or 12 months and then after dry of the cycle then bone infection complication bone infection bone lesions enterocanis fistula and sepsis tuberculosis hemolysis spread jelly cycle jaundice 12 months extremely rare spread is post the prospective study was in our phase 2 we have totally 20 patients in 5 years 46 patients treatment of regional surgical emergencies process peritoneal hospital and then prospective study total 46 patients we have done number age-wise distribution man it was present man presentation was young adult it is 20 to 41 total then here and female distribution mainly
Rural was 14 and urban was less. 86.55% for the club. Then supplementals at the time of presentation, men and women 86%, 30%, idea 30%. Even 50% weight loss was physical sign, valor, medical medically 32.6%, surgery was application 34%. Blood preparation was 9%, blood extraction 60.7%, and petrolites were 23.5%. And blood extraction was active man process and disease of young adult
माइक नहीं है मैं करूँगा मैं अभी करूँगा ओके
respond back to the
माइक लेंगे ना आप माइक
stitches are present.
माइक
Wait and watch. Thank you.
The paper which we have presented creates significance of part of the world. Because diagnostic laparoscopy has really given diagnosis to so many abnormals. Whereas medical people and non-investigative work has not used when it comes to malignancies, tuberculosis, and other. So laparoscopy is the answer and diagnostic.
Any comment, anything? Thank you very much, Dr. Zahir.
That concludes the invited faculty lectures. We extend our heartfelt gratitude to all our distinguished speakers for their insightful and enriching presentations and truly embodying the essence of this conference.
We would also like to express our sincere thanks to our respected chairpersons for their time, guidance and invaluable contribution to this session. We now request our esteemed chairpersons to come forward and felicitate our respected presenters. First, we would like to call Professor and Dr. B.S. Pathania to collect our token of gratitude. Next, we would like to call Professor and Dr. M.R. Atri to come forward for the felicitation.
Yes, please.
Thank you, sir. Next, we would like to call Professor and Dr. Gustav Chalu on the stage to collect our token of gratitude.
Center. Yes, please. Yes. Okay, sir.
Thank you, sir. Now, we would like to call Dr. Akhtar Ganai on the stage for the felicitation.
Okay, sir.
Thank you, sir. Now, we would like to call upon stage Professor and Dr. Zakir Hussain on the stage for the felicitation.
Okay.
Now, we would like to call Professor and Dr. Sanjay Kumar Basi, Department of General Surgery, GMC Jammu, to felicitate our esteemed chairperson. First, we would like to felicitate Professor and Dr. Sulaiman Chaudhary.
Yes.
Thank you, sir. Next, we would like to felicitate Professor and Dr. Ratnakar Sharma.
यार ये चंगी फोटो आनी चाहिए देखो ये तालियां मारो भाई क्या बात कर रहे हो तालियां बजाते यस प्लीज
Next, we would like to felicitate Professor and Dr. Ajaz Ahmed Malik.
ये हमारा ये
Thank you, sir. Next, we would like to felicitate Professor and Dr. Nazir Ahmed Bani.
yes
Thank you, sir. The organizing team has decided to felicitate the doings of surgery during inaugural ceremony, but a senior surgeon, Dr. Y.P. Singh, due to health issues, wants to leave early, and hence our organizing team has decided to felicitate him, for which I request former chairman of JAKASI, Professor and Dr. Nisar Chaudhary, Professor and Dr. Tariq Azad, Professor and Dr. N.C. Digra, Professor and Dr. Sulaiman Chaudhary, and President JAKASI, Professor and Dr. Ajaz Rahsar, to felicitate a senior surgeon for his services to the society. Thank you.
तारिक सर कहाँ गए?
yes please look here okay yes sir थोड़ा ये okay
Thank you, sir. We now request everyone to please proceed to the lawn area for the tea break. We shall resume the further proceedings of the conference after 15 minutes. Thank you.
और असर क्या हालत
हाँ जी कोई नहीं बैठो ना बैठो बैठो आइए नहीं बैठो
सामने
हो गया मैं सच्ची बता रहा हूँ ध्यान नहीं दिया अभी बड़े सारे लोगों को छोड़ गया उन्होंने चिंता कराया बड़े सारे लोग हमारे साथ नहीं आ रहा वो पकड़ा ठीक है क्या है मैंने सारे बड़ा लेट कर मैं नहीं चल ठीक है चला बड़ा बोलो शुरू करो
Surgery, the practical art that yields immediate life-changing results, inspired by the teachings of Sushruta, the father of surgery. Good evening, everyone. It gives me immense pleasure to stand before you today at this landmark occasion, the Midterm Conference of Jammu and Kashmir State Chapter of the Association of Surgeons of India, hosted by the Department of General and Minimal Access Surgery, Government Medical College, Kathua. It is truly a proud moment for all of us to witness this congregation of surgical minds united under one inspiring theme, the mastering the art of general surgery practiced with precision. Today is not merely an academic gathering. It is a celebration of knowledge, craftsmanship, and collaboration. The essence of who you are as surgeons. As we begin this two-day journey of learning, exchange, and reflection, I feel deeply humbled by the presence of the most respected names in our fraternity, stalwarts whose lives and work have defined surgical excellence in Jammu and Kashmir and beyond. Their presence here today reflects not only their commitment to academic excellence, but also their belief in nurturing the next generation of surgeons. To our young residents and trainees, this conference is your classroom beyond walls.
Learn from the stalwarts not just the techniques of surgery, but the values that make one a true healer: humility, precision, and compassion. The theme of this conference, Mastering the Art of General Surgery, Practice with Precision, beautifully captures the dual nature of our profession. Surgery, as we know, is not merely a technical act. It is an expression of both intellect and instinct. To master the art of surgery means to understand that beyond every incision lies a story of trust, courage, and responsibility. Sushruta, in his timeless wisdom, taught us that the true surgeon is one whose hands are steady, whose heart is pure, and whose knowledge is unending. In today's world of robotics, artificial intelligence, and image-guided interventions, that lesson is more relevant than ever. While technology continues to expand our capabilities, the essence of surgery remains profoundly human. The connection between the surgeon's hand and the patient's home. This conference is a milestone for the surgical fraternity of Jammu and Kashmir. For the first time, Kathua becomes the meeting ground for the experts from every corner of our Union territory, from Srinagar and Bemina, from GMC Jammu, Anantnag, Rajouri, Baramulla, Doda, and AIIMS Vijaypur. This is not just a meeting of institutions, it is a meeting of minds. Together, we are building a network of excellence, one that extends from the academic halls of our medical colleges to the operating room of our district hospitals. Such gatherings carry deep significance. They break silos, encourage mentorship, and inspire young surgeons to dream beyond boundaries. Every paper presented, every question asked, and every discussion held here will ripple outward, shaping better practices, safer surgeries, and a stronger collaboration. Let us remember that conferences such as this are not merely for information, they are for transformation. They remind us that mastery is not a destination but a continuous pursuit. To master the art of surgery is to remain forever a student. What student? A curious, disciplined, and compassionate student. I wish this conference grand success. May it ignite curiosity, strengthen collaboration, and deepen our commitment to serve humanity through the art of science and surgery. Now, I call on dais our dignitaries, Honorable MLA Kathua, Dr. Bharat Bhushan sir, please sir. Honorable MLA Jasota, Mr. Rajiv Jasotia sir, please sir. Professor Dr. Surinder Kumar Ratri, Principal Government Medical College Kathua. Professor Dr. Ejaz Ahmed Rathar, Chairman JAKASI. Professor Dr. Ravinder Kumar, Chairman Organizing Committee Midterm Conference. Dr. Harvinder Singh Bali, Honorary Secretary JAKASI. Dr. Anshuman Chandar, Organizing Secretary Midterm Conference JAKASI. Now I request Dr. Ankush from the Department of Surgery to please present bouquet to Dr. Bharat Bhushan sir.
Sir, please. Sir.
Now I request Dr. Junaid from Department of Surgery to present bouquet to Honorable MLA Jasota, Mr. Rajiv Jasotia, sir. Okay. Now I request Dr. Sanjeev to present bouquet to Professor Dr. Surinder Kumar Ratri, Principal Government College, Medical College, Kathua. Now I request Dr. Deepti to present bouquet to Dr. Ejaz Ahmed Rathar, Chairman JAKASI. Now I request Dr. Nancy to present bouquet to Professor Dr. Ravinder Kumar, Chairman Organizing Committee Midterm Conference. I request Dr. Shubham to present bouquet to Dr. Harvinder Singh Bali, Honorary Secretary JAKASI. Now I request Dr. Vinay to present bouquet to Dr. Anshuman Chandar, Organizing Secretary Midterm Conference JAKASI. दीपो ज्योति परम ब्रह्मा दीपो ज्योति जनार्दनी दीपो हर में पापम संध्या दीपम नमोस्तते नमोस्तते. Light has always been the symbol of wisdom, purity and enlightenment, the flame that dispels the darkness of ignorance and illuminates the path of truth and knowledge. I now invite our esteemed dignitaries to kindly come forward and join in the lamp lighting ceremony, marking the formal inauguration of this midterm conference of the Jammu and Kashmir State Chapter of Association of Surgeons of India. Thank you so much. As a matter of ceremony, I would request Senior Governing Council Member of Association of India, Professor Dr. Sanjay Bhasin Sir, to put Chairman Medley to Professor Dr. Ijaz Ahmed Rathod, Chairman JAKASI.
Yes, please. Okay, sir.
Thank you, sir. It is now my honor to invite on stage a leader whose energy and commitment have been central to bringing this midterm conference to life. Dr. Ravinder Kumar, Professor and HOD, Department of Surgery, GMC Kathua, who has been instrumental in conceptualizing and organizing this conference as Chairman of the Organizing Committee. Under his stewardship, the department has expanded its academic outreach, hands-on training and practical workshops, all aligned to our conference theme, Mastering the Art of General Surgery, Practice with Precision. Colleagues, remember him for his clarity of thought, systematic approach to operative technique, and dedication to the resident teaching. I welcome you, sir, on stage, and please deliver the welcome speech.
At the very first outset, I am privileged and delighted to be the chairman of the midterm conference hosted by JAKASI, for which I am extremely thankful to the leadership of JAKASI for giving me this opportunity to organize this prestigious event. Respected and Honorable MLA, Dr. Bharat Bhushan Sahib, Mr. Rajiv Jasrotia Sahib, Worthy Principal, Government Medical College Kathua, Professor Dr. Surinder Kumar Athari, Chairman JAKASI, Professor and Head, Department of Surgery, Skills Medical College, Bambina, Honorary Secretary, Dr. Harvinder Singh Bali, Associate Professor, ESCOMS, Batra, Jammu, and my Organizing Secretary, Dr. Anshuman Mahesh, Dean of Surgeries, on the dais, delegates, faculty, colleagues, ladies and gentlemen. This is indeed a moment of proud privilege and great honor for me as Chairman Organizing Committee Midterm Conference of JAKASI to stand before you this evening and extend my heartfelt welcome to all the participants of this event hosted by my department. This prestigious conference marks an important academic milestone for our Government Medical College Kathua, as this is the first major surgical conference ever held at Government Medical College Kathua. It reflects not only our department's growing academic stature, but also the collective commitment of the surgical fraternity of Jammu and Kashmir towards promoting continued surgical education, innovation and excellence in patient care. This 2 days conference is serving as a vibrant platform for knowledge exchange where renowned experts are sharing their experiences, research and perspectives on the evolving landscapes of general and minimal access surgery. Our scientific program has been thoughtfully curated and designed to cover a wide range of topics from recent advances in laparoscopic and general surgery to evidence-based approach in trauma, gastrointestinal surgeries and oncological surgeries. This session have included invited guest faculty lectures, PGs and SR paper and poster presentation, offering great opportunities for young surgeons and PG students to engage in meaningful academic dialogue. Government Medical College Kathua, though relatively young, yet has made remarkable strides since its inception. In a short span of time, it has emerged as a hub of medical education, patient care and research in the region. Our department has been in the forefront of this growth. We have established ourselves as a center of comprehensive surgical care, offering wide spectrum of procedures ranging from the general and advanced laparoscopic procedures. I feel proud in sharing that our department has been granted post-graduation MS seats as announced by the National Medical Commission under the guidance of our worthy principal, GMC Kathua Professor. So, our faculty and residents have contributed to several publications, papers at various conferences due to commitment and vision of surgical leadership. I would like to express my deep gratitude to the esteemed guests on the dais for accepting our invitation and gracing this occasion with their esteemed presence. I once again welcome one and all. Thank you so much. Jai Hind, Jai Bharat.
Thank you, sir. Our Honorary Secretary JAKASI, Dr. Harvinder Singh Bali, Associate Professor ESCOMS Jammu, recognized for inspiring laparoscopy techniques and academic excellence, I request him to present report of JAKASI.
Dignitaries of the dais, my teachers, friends and students. At the outset, I must congratulate Dr. Ravinder for putting up a great show and getting a conference of the state level to Government Medical College Kathua. This has been endeavor after taking over JAKASI, myself, Professor Ejaz, our Chairman JAKASI. It has been our endeavor to take these conferences to all nook and corner of the state. All the peripheral colleges have been at our agenda to take these conferences to that. Last time we did a midterm at Kupwara, then again the second one at Rajouri, we did the JAKASI 2025 at GMC Anandnag, and now at GMC. So we are trying to cover each and every part of the state so that not a single part or single place of this unit territory of ours is left behind, so that we are far at state level and we are then at far at a national level. I wish all the success to Professor Ravinder and his team. Thank you and good night.
Now हमारे next dignitary, Dr. Ejaz Ahmed Rathar, Professor and Head of Department of General Surgery at SKIMS Memna Srinagar, Chairman JAKASI. Dr. Rathar holds fellowships like FRCS, Royal College of Surgeons, Edinburgh, FACS, American College of Surgeons, FICS, International College of Surgeons. He has numerous publications in national and international journals with research interests in general surgery and urology. Sir, I welcome you on stage.
Honorable members of Legislative Assembly, Dr. Bharat Bhushan and Shri Raju Jasudriya, Principal, Government Medical College, Kathua, Dr. Surinder Adri, my student, friend and colleague, Professor Ravinder, the backbone of this conference, Dr. Harbinder, our Honorable Secretary, and Dr. Anshuman, the organizing secretary of this conference, former principals, former heads of the departments of all the medical colleges of the Union Territory, heads of the department of Sikkim, Missouri, AIMS, Jammu, heads of the departments from all the medical colleges, founder members of JAKASI, and faculty and delegates, a very good evening to all of you. It's indeed a great honor and privilege to address the distinguished gathering of surgeons as the president of our JK chapter of the Association of Surgeons in this midterm conference. As surgeons, we know that the technology is changing at a very fast pace and we have the knowledge explosion. So the traditional and conventional surgery is being replaced very fast by newer techniques like keyhole surgeries, laparoscopic surgery, the robotic surgery, the artificial intelligence, and whatnot in future. So we have to keep ourselves abreast with the latest techniques, the latest innovations in the field of surgery, because if we don't do that, we will be obsolete. As the medical science advances at a very fast pace, what was new yesterday becomes obsolete tomorrow. So organizing these conferences is an essential component of teaching, learning, and also it helps us to know about the newer techniques. And so on behalf of JAKASI, Association Services of JK Chapter of India, I congratulate Professor Ravinder for standing on the front foot and having organized such a big event. I can understand that organizing such a big event is not that easy, especially in a newly established medical college, while we have the shortage of faculty, while we have the shortage of resources. But I hope with the support of principal, he has all stood on the forefront, and along with his dynamic team, he has faced all the challenges, all the shortfalls. So now I may tell you that in this era, where new procedures are transforming the surgery, human touch remains irreplaceable. Our scalpels may have become sharper, our monitors may become smarter, and other gadgets may have become smarter, but the moral, ethics, and compassionate heart of a surgeon must remain constant. Yet, amid this technological brilliance, I wish to draw our attention towards the two timeless pillars which form the moral compass of medical profession, that is, ethics and empathy. Our next generation must inherit a discipline grounded in ethics and excellence. Equally important is empathy, that is the ability to see the patient not as a case or diagnosis, but as a fellow human being in pain and uncertainty. Empathy is what transforms our sickle into healing. A gentle word, a reassuring touch, and few extra moments of listening can ease more sufferings than any sharp scalpel can ever do. Let us never be so busy that we forget the person beneath the drapes. It is what makes us pause before making an incision to see the human being. Under the sterile drape, it may be our mother, anxious to see her children, the son, anxious to look his parents after surgery, a young female recently married undergoing LSCS to see her newborn and her loving husband after surgery. Friends, the greatest advance in surgery will always lie not only in the operating rooms but in our hearts and conscience. Let this conference be a reminder that while technology may define the future of surgery, ethics and empathy will always define the future of a surgeon. The true excellence in surgery is not only about mastering the anatomy, it is about listening and feeling and connecting with the patients. And alongside empathy stands ethics, that is our moral backbone. In the era where healthcare is increasingly corporatized and commercialized, where the choices are influenced by cost, competition, and convenience, ethics reminds us of our sacred duty to act always in the best interest of the patient. Ethics should live in our daily decisions, in the honesty with which we explain the risks, the humility with which we admit our own complications, and in the integrity with which we choose what is right over what is profitable. Let me remind the words of Sir William Osler, who said, "The good physician teaches the disease, but the great physician teaches the patient who has the disease." So we are good surgeons, but let us be great surgeons. To conclude, my dear colleagues, in a world racing ahead with machines and metrics, the surgeon's true strength will always lie in human touch. The ability to comfort before we cure and care even when we cannot cure. As we deliberate in this conference, let our decisions and discoveries be guided by these principles: empathy and human medicine, and ethics that dignifies it. Together, let us ensure that while surgery continues to evolve in science, it never loses its soul. Thank you. Live with the spirit of compassionate surgery. Long live ASI, long live. Thank you.
Thank you, sir, for such enlightening words. Now, our respected principal, Government Medical College, Kathua, Professor Dr. Surinder Kumar Khatri, sir. Under his leadership, GMC Kathua reached new heights and successfully completed many new endeavors. To count a few, we have got 20 MD MS seats in the 9 departments. Remaining 9 will hopefully get in the next session. We are in the process of increasing our OTs from 8 to 14. By next year, we will be 600 bedded hospitals with a new ICU. Now, I request our principal, respected Dr. Surinder Kumar Khatri, sir, to please come on dais and share his words.
Very good evening, respected Honorable MLA Jasrota, Shri Rajiv Jasrotia, Honorable MLA Kathua, Shri Dr. Bharata Bhushan sir, all senior teachers, Dr. Tariq, Dr. Naseeb, Dr. Charangu, all delegates, faculty members of GMC Kathua, students, SRs, DNP residents, and interns. At the outset, I congratulate Department of General Surgery, Dr. Ravinder and his team for taking this initiative and organizing for the first time a state level conference. And I hope with this, the other departments will be motivated and we will have such national, international and state level conferences in our institute. I also thank JAKASA, Dr. Tariq, Dr. Naseeb and President Dr. Rathar for helping us and for taking this initiative for organizing this conference in our institute. And I hope with this conference, the patient care management research innovative techniques will be started in our institute. Thank you. Jai Hind.
Thank you so much, sir. Our Honorable MLA Jasota, Mr. Rajiv Jasotia, sir, member of Jammu and Kashmir Legislative Assembly from Jasota constituency since 2024 and was formally elected from Kathua constituency in 2014. He has served Minister for Forest, Environment and Ecology of Jammu and Kashmir. He is an excellent orator, he is the voice of his people. He keeps no stone unturned for the development and progress of his constituency. I request Honorable MLA Sir to please come on stage and share his words of wisdom.
Honorable MLA Kathua Dr. Bharat Bhushan ji, Chairman of this JAKASA, Izaz Ahmed Rathik Sahab, Principal of this Medical College, Sudhir Atri ji, Dr. Ravinder ji, Dr. Harvinder Singh Bali ji, Dr. Ansuman Chandar ji, and all senior surgeons from different medical colleges of JNK, and some students, I guess. Firstly, I apologize that I have been late. It went out of my mind. But my wife gave me a reminder. Because Ravinder ji, he has an association, our family association. So I don't know what I have to say. But I can only say that the people who came me to invite, they were gracious enough and I spared my time. It's my pleasure to be among this fraternity. And I was asking Dr. Saab, Chairman Saab, what is this all about? I have no idea. I came sudden from some program and landed here. He said this is an organization of this nation, of surgeons, if I am not wrong. And when he was interacting with all of us, I can't understand technicalities, but what as a representative I could accumulate, and the concern you have shown, though it's a medical college with the lack of faculties and resources, but I promise we got this medical college at Kathua. There were 4 colleges at that time when I was MLA Kathua. There were different colleges coming up at the same time. I just want to share with you, we worked very hard for this medical college. And I often say, Kathua is a town and Kathua district is the fastest growing district and the fastest growing town in this entire UT. There was some hitches, we cleared it. This medical college, which is where it is now, it was supposed to be somewhere else. Had the location been that, the things would have been different. And there was a cabinet order for that. We got it revoked. Bali Sahib, he was health minister. Why I am sharing with you this thing is, you said, I know, I can guess that there is a shortage of staff I agree. We have shown our concern to the concerned minister too. But I can with guarantee say that colleges which came up at that time, simultaneously there were 4 colleges. With the efforts of the principal sir and the people working in this institution, in this medical college, they have made great efforts. And I can bet on it that this is one of the best new medical colleges who has been delivering. Today you are thinking of holding this conference here. This is because of the efforts of the people who are working here. You make a comparative studies about other colleges. They are still struggling. Out of these 4 colleges, I think Kathua is best, and next time you come here to hold conference, we will give you no chance. Few days back we got some CT scan, what you got? MRI. CT scan is coming. Or your shortage का issue है, we'll work on it. But I earlier said that Kathua is the fastest growing town. When people like you think of contributing, because life alone is not this way, we have to struggle for our survival. Now life is beyond that. There was India where there was no health concerns. Now this is India, this is 21st century India, which shows health concern too. And you have made an immense contribution in this, as far as this institution is concerned. Holding this midterm conference will be making some value additions. You have invited me here, and as far as technicalities are concerned, what could I guess? If this institution is doing good, I don't know, it's for 1 day or 2 days. Whatever you share your experience, it goes down to the society. And your commitment and your service to this Kathua, I once again thank entire people, especially people who organized this conference, and for all of you, you have spared your time to be among us. Thank you very much, and thank you me for inviting.
Thank you, sir. We are so grateful for you to be here amongst us. Honorable MLA Kathua, Dr. Bharat Bhushan, Honorable MLA Dr. Bharat Bhushan completed his MBBS and then joined Jammu and Kashmir Administrative Services. Dr. Bharat Bhushan has served in various departments during his tenure as a dynamic officer. Presently, he is a member of Legislative Assembly from Kathua constituency. Dr. Bharat Bhushan is working day and night for the people of Kathua. I request Honorable MLA Sir to please come on stage and share his thoughts with us.
Thank you, Joseph. Good evening, ladies and gentlemen. Honorable MLA Jasota constituency, respected Jasotia sir, respected President Joint Chapter of Indian Association of Surgeons, Dr. Rathas ji, Organizing Secretary Dr. Bali ji, Principal Jammu Kathua Medical College Dr. Sundar ji, the organizer of this conference, Head of the Department Dr. Ravinder ji, Dr. Ankush ji and their team, and all senior doctors and dear friends. It is really a matter of great pleasure, pride and privilege for me to be here, that Postgraduate Department of Surgery under the patronship of Dr. Sundar, Principal Medical College Kathua, and hard work and devotion of Head of the Department of Surgery, Dr. Ravinder ji, GMC Chapter of Association of Surgeons of India, have organized this midterm surgical conference in Kathua. I am sure the deliberations here will go a long way in furthering the cause of medical medical improvement in Kathua and other parts of Jammu and Kashmir. For me, this occasion is very special, as many of my senior teachers, like Dr. Tariq Azad, Dr. Nasir Chandigraji, Dr. Sanjay Singh ji, and many of my other colleagues are participating in this conference. I welcome you all here, sir. And I also congratulate the team of Kathua Medical College that this college has not only got 50 MBBS seats in addition to normal seats, but also PG classes will also start in 8 disciplines. It shows that how much hard work these people are putting in despite many constraints like staff, infrastructure. I congratulate Principal Sir for all the for leading this institute to newer heights. As Surti Sahib has told, there is no doubt that Kathua Medical College has been doing very well as compared to other new medical colleges, and the time will come that this Kathua Medical College will shine like other medical colleges of our state and the country. I again thank the organizers for inviting me to be part of this important conference, and especially my thanks are due to Head of the Department, Dr. Ravinderji, and his team, that they have been doing very hard work for the last 10-15 days, and I wish all this conference to be very successful in their future. Thank you.
Thank you, sir, for such encouraging words. Now I request Dr. Ravinder Kumar, sir, to please come on stage and take the program further.
Thank you so much. Now it's a time for felicitating the doyens of surgery who have contributed a lot to the society in the field of surgery. I will call Rajeev Jasotia sir and Dr. Bhatushan sir to come on the stage for felicitating the respected doyens of surgery. I will call upon Dr. Nisar Chaudhary. He is a founder president of JAKASI, retired as HOD General Surgery and Right Specialties, Sher Kashmir Institute of Medical Sciences, SORA. Has represented J&K in various academic forums at national level, widely respected personality.
Yes.
Now I will call upon Professor Dr. Tariq Azad. He is a senior surgeon of the state, retired as Professor of Surgery, Government Medical College, Jammu, retired as Principal Medical College, Doda, ex-chairman of JAKASI, ex-governing council member of ASI, widely respected faculty.
Yes, please. Yes, sir. Okay, sir. Sir, please. Yes. Yes.
Thank you, sir. Now I will call upon Professor Dr. Sanjay Kumar Bhasin, Professor of Surgery, Government Medical College, Jammu, a dynamic personality who is continuously occupying one or other position in JAKASI since 2012. He is a dedicated hard worker, gave new directions to JAKASI, now a GC member of Association of Surgeons of India, multi-talented surgeon, academician and writer also.
Yes, please. Sir, mobile picture, please. Yes.
Now I will call upon Professor Dr. Aizaz Amar Rathar, sir, Professor and Head Surgery, Slims Medical College, Bamina, Chairman JAKASI, under whose patronship this conference has been possible. He is an academician who has vast experience in representing Jammu and Kashmir at various conferences.
Yes, please. Yes, sir. Yes, go.
Now I will call upon Professor Dr. Naseeb Chandigra, retired as Principal Government Medical College Jammu and Technical Secretary to the Government of Jammu and Kashmir, ex-HOD Surgery GMC Jammu, past GC member, President-elect JAKASI, now Vice Chairman JAKASI, and academician and brilliant pediatric and general surgeon.
Yes.
Now I will call upon Dr. Zafar Khande, Professor of Surgery, basically pediatric surgeon, former Treasurer of and Honorary Secretary of JAKASI, now GC member, ever smiling face.
Yes. Yes. Okay.
Now I will call upon Professor K.S. Mehta, HOD Surgery, Ascons.
Yes, please. Okay.
Now I will call upon Professor Dr. Azaz Ahmed Malik, Professor and Head General Surgery, Skims, Sora.
Yes.
Now I will call upon Professor Dr. Rajrishi Sharma, my elder brother, retired as HOD Surgery, founder and HOD of GMC Kathua. He has laid down the foundation of GMC Kathua that how it's continuing its growth.
Yes, please. Yes.
Now I will call upon Professor Dr. Nazir Ahmed Wani, HOD Surgery, Government Medical College, Anantnag. He has been associated with the JAKASI for the long time. He has contributed a lot for the progress and development of the JAKASI.
Yes. Okay.
Thank you so much, sir. Thank you so much, please. Thank you so much.
Thank you, everyone. Now, I request Professor Dr. Ijaz Ahmed Rathod, Chairman JAKASI, Professor Dr. Ravinder Kumar, Chairman Organizing Committee, Dr. Harbinder Singh Bali, Honorary Secretary JAKASI, Dr. Anshuman Chandar, Organizing Secretary, to felicitate Honorable MLA Jasota.
Yes, please. Okay.
Now, I request Professor Dr. Ejaz Ahmed Rathur, Professor Dr. Ravinder Kumar, Dr. Harvinder Singh Bali, Dr. Anshuman Chandar to felicitate Honorable MLA Kathua.
Yes. Yes, please.
Thank you. Now, I request Honorable MLA Jasota, Honorable MLA Kathua to felicitate Professor Dr. Ejaz Ahmed Rathur, Chairman JAKASI.
Madam, please. Yes.
To present this token of gratitude to Principal GMC, Dr. Surinder Kumar Atri.
Yes, please. Yes, yes.
Now, we present token of gratitude to Professor Dr. Ejaz Ahmed Rathur, Chairman JAKASI.
Side, please. Yes.
Now,
yes, please.
I request Honorable MLA Jasota, Honorable MLA Kathua to present token of gratitude to Professor Dr. Ravinder Kumar, Chairman Organizing Committee.
A round of applause.
Yes. Please. Yes, please.
Now I request Honorable MLA Kathua, Honorable MLA Jasota to present token of gratitude to Dr. Harvinder Singh Bali, Honorary Secretary JAKASI.
Yes, please. Yes.
I request Honorable MLA Jasota, Honorable MLA Kathua to present token of gratitude to Dr. Anshuman Chandar, Organizing Secretary, JAKASI.
Round of applause.
I call upon stage Professor Dr. R.K. Chirangu. Please come on stage, sir, and receive token of gratitude and appreciation.
Sir, please. Yes.
And my teacher. Everyone's teacher.
Madam. Yes. Yes, please.
Thank you so much. Now, I request Dr. Anshuman Chandar, Associate Professor, GMC Kathua, Organizing Secretary, Midterm Conference, for vote of thanks.
Good evening, all of you. First of all, it's my privilege to stand in front of such great teachers, great surgeons, and the various academicians and clinicians from all of the departments. It's been a privilege to stand in front of all of them from whom I learned the art of surgery. So now it's both an honor and privilege to propose the vote of thanks on the behalf of organizing committee of this surgical conference. So at the outset, I extend my deepest gratitude to our chief guest, our guest of honor, and our special guest, worthy MLAs, Dr. Bharat Bhushan, worthy MLA, Mr. Rajiv Sisodia, and our worthy principal, Dr. Surinder Kumar Atri, for gracing this occasion with their esteemed presence and their inspiring address.
Your words have truly motivated us to continue striving for excellence in surgical education and patient care. We are profoundly thankful to all our speakers, guest speakers, special guest speakers who have shared their vast knowledge, clinical experience, and recent advances with such clarity and depth. The scientific deliberations and discussions over the past sessions have been truly enlightening and thought-provoking. Our sincere appreciation goes to all the session chairpersons, moderators, and coordinators whose guidance and timekeeping ensured that the academic sessions proceed seamlessly. A heartfelt thanks to all the participants and delegates, faculty, postgraduates, senior residents, junior residents, whose enthusiasm and engagement have added immense value to this conference. Their participation reflects the collective spirit of learning and collaboration that defines our surgical fraternity. Now, gratefully acknowledge the support of our institutional leadership, our sponsoring partners, and the technical and administrative team, and the venue staff of this very hotel Akash, whose commitment behind the scenes and efforts made this event a resounding success, I hope. Finally, I extend my gratitude to every member of Team JAKASI, our organizing committee, and all our volunteers for their dedication, teamwork, and attention to detail throughout the planning and execution of this conference. So, as we conclude, let us carry forward the insight and innovation shared here and continue to work together for the advancement of surgical science and betterment of patient outcome. So, thank you all for your presence and participation and support. We look forward to welcome you again and again and again for all our future academic endeavors. Thank you all on the behalf of all the organizing committee of GMC Kathua Midterm Conference, Surgical Conference. Thank you all.
जैसे ही हम कार्यक्रम के इस गौरवमय पल पर पहुंच रहे हैं, आइए एकता, सम्मान और राष्ट्र गौरव की भावना में एक साथ जुड़ जाएं। राष्ट्रगीत सिर्फ एक गीत नहीं, ये हमारी पहचान, हमारी आशाओं और उन बलिदानों का प्रतिध्वनि है जिन्होंने इस देश को मजबूत बनाया। इस क्षण में आइए इस गर्व को महसूस करें कि हम सब एक समुदाय, एक लोग और एक देश के रूप में यहाँ खड़े हैं। जन गण मन गाने से पहले आइए एक छोटा सा क्षण अपने हृदय में कृतज्ञता के लिए रखें, स्वतंत्रता के लिए, अपनी विविधता के लिए और उन अनेक वीरों के लिए जिन्होंने भारत को आज जहाँ है वहाँ पहुँचाया। हमारी आवाज में सम्मान, शिष्टता और इस देश से गहरी लगन झलकनी चाहिए। अब मैं सभी उपस्थित मेहमानों से विनम्र निवेदन करती हूँ कि कृपया राष्ट्रगान के लिए खड़े हो जाइए।
भारत भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा, विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा, तव शुभ नामे जागे, तव शुभ आशीष मांगे।
की
जय।
भारत माता की
जय।
भारत माता की
Jai Hind. My heart